So
Introduce
you
her.
you introduce, you talk for 1 minute, then I will pick up from there.
We are live.
Very good afternoon, everyone, and a very warm welcome
Some
to everyone.
audio इतना ही है. Piyush, 1 second.
We are
Please,
live, so can you mute everybody? Can everybody mute, please?
yes, to mute.
Very good afternoon, everyone, and I extend a very warm welcome to everybody tuning in, and welcome all of you all to the third midterm conference of the Maharashtra Ophthalmic Society. Now, the idea of the conference is over here is to encourage and support as many young ophthalmologists as possible, give them an opportunity and a podium to speak and present their work with our expert panel, which are senior ophthalmologists, and they provide their inputs in different difficult situations and situations when there are dilemmas. Another first that we have is the free paper session, which is traditionally done in the annual conference. And because of the large number of residents that study in our state, this is a very nice opportunity for those residents. We had a pre-final competition, free paper competition, and the five best papers were selected from the free paper competition. All kudos over here to the Secretary of the Scientific Committee, Dr. Sumit. And I hereon pass the baton to Dr. Sumit Lahane and to Dr. Ganesh Gaikwad to introduce the judges and then quickly start the free paper session, which is a competitive session, the awards of which will be given at Moscon, Goa.
Very good afternoon, everyone. Thank you, Piyush sir, and the whole MOS team for giving this platform and coming back again to the midterm MOS, which was started in the COVID time, and since because of its favoritism and every year it increasing audience for the same, we continue still a virtual conference of midterm Moscon. So we start here with the free paper final session. We have 5 presenters and the 4 judges. We have Dr. Karandikar sir. Karandikar sir, Sunaina ma'am, I must say they are my mentors, so they don't need any introduction. They have taught my father as well. So, and they have taught, I think, most of us here in the faculty today as well. Dr. Usha Zori ma'am is a ex-president BOA and always enthusiastic for participating all the educational program. And Parikshit Gokte sir, again ex-president of MOS, a very hard-working researcher and does a research out of the box thinking, and pleasure to have him here. So with this, I introduce my co-moderator, Dr. Ganesh Gaikwad, who is a prolific cornea surgeon at Nashik. And we start the presentation with Dr. Nilesh Zaifai, who is talking about optimizing outcomes with the toric lenses in tertiary healthcare center. Dr. Nilesh, you can share the screen, please. Sunilji, timer for the 6 minutes.
म्यूट केलेलं आहे मी म्यूट केलेलं आहे आता पण माझा आवाज नाही येत.
Should I start, sir?
Yes, please.
Yeah. Good afternoon, everybody, moderators, judges, and all the teachers. Today, I would like to present my paper, Optimizing Outcomes with Toric Lenses at a Tertiary Healthcare Center, presented by myself, Dr. Nilesh Zaibai, third-year junior resident at Department of Ophthalmology, SRTR GMC Ambazogai, under the guidance of Dr. Jnanobha Darade, Professor and Head of Department.
1 second, Nilesh, enlarge your screen, enlarge your slides. Some part is getting cut off from the corner. I don't know what's happening. What size yours? No.
Is it visible, ma'am?
No, it's still getting cut off. Anyway, I think you better continue. The time is going.
Yes, ma'am. Coming to the introduction, astigmatism is one of the most common refractive error of the eye. 30% of the patients posted for cataract surgery have about 1 diopters of astigmatism. Significant astigmatism is associated with poor uncorrected distant visual acuity, increased spectacle dependence, and decrease the quality of the vision by distortion and smearing of the images. Various intraoperative modalities are available for correcting the corneal astigmatism, which includes the incision on the steep axis, limbal relaxing incisions, peripheral corneal incisions, and toric intraocular lenses. Cataract surgery with a toric intraocular lens provides an unique opportunity for the surgeon to address the issue of preoperative corneal astigmatism in pursuit of achieving the intended postoperative spectacle independence and optimal patient satisfaction. Now, coming to the aims and objective, to study the various factors in preoperative, operative, postoperative phases affecting the outcomes of toric lenses, and to study the visual outcome after toric intraocular lens implantation. Coming to the materials and methods, the study area was Department of Ophthalmology at Tertiary Healthcare Center, that is SRTR GMC Ambazogai. Duration of the study was 18 months. The study method was observational study. Inclusion criteria was a senile cataract with a regular astigmatism of more than 1.5 diopters and patient willing to be part of the study. My exclusion criteria were patients with compromised back support, nuclear, hard or intermittent cataracts, patients with ocular pathologies such as pterygium, synechiae, uveitis, any retinopathy, glaucoma, corneal dystrophies, irregular astigmatism, and corneal scars. Also, the patients having eyes with a poor pupillary dilation were also excluded, and patients not willing to be the part of the study were excluded. Coming to the pre-operative assessment, pre-anesthetic workup was done and physician fitness was obtained. Detailed ocular examination, including autorefractometry, autokeratometry, anti-segment examination, fundus examination, and slit lamp examination was performed. IOL biometric calculations were performed using immersion ultrasound A-scan biometry. Written informed consent was obtained for this study and cataract surgery from the patients. Now coming to the selection of the intraocular lens, in my study I have used Oroview EV toric lenses. This is the website for the selection of the lens. On the website we have to put the flat keratometry value, flat axis, steep keratometry value, steep axis, IOL power calculation that we have done, and surgically induced astigmatism, and our preferred site of incision. After the values are inputted, the toric intraocular lens is suggested by the website for the given patient. This is one example of a patient that we have operated. In this patient, the lens position was given from the website as 176 degree. After operating the patients in operative procedure, first there is a pre-operative marking. It can be done by various instruments like Nugis lane bubble marker, plumb ball marker, Akahoshi X-axis toric marker, or various digital platforms. In my study, we have done it using manual method with simple tools, that is toric reference marker. This is the image of a toric reference marker on the right hand side. It has fenestrations and 3 blades for the marking. In the procedure of the marking, the patient is seated straight and comfortable position. Eye speculum is applied. The slit beam is adjusted to the diameter of the cornea, and slit beam is moved from one eye to the other eye, and it should align with both eyes cornea so as that the head tilt is removed. The conjunctival and corneal surface is dried with an earbud. Limbus is seen via the fenestration of the toric marker, and the ink is applied over the blades of the toric reference marker, and the mark is performed on the limbus. It is the marks. There are 3 marks. The first mark is at 0 degree or 180 degree, and the 2 marks are 90 degree and 270 degree. After the marking, patient is shifted to the operating room. In operating room, there is an intraoperative marking. It can be done using various apps such as iToric marking app, Precision Toric, or Toric M app. In my study, I have used manual method using simple tools, that is Mendes degree gauge and Toric axis marker. The Mendes degree gauge is aligned with the pre-operative marking of 0 or 180, 90 degree and 270 degree. The Toric axis marker, which has 2 blades, which is shown in the lower image, is used to mark the incision location and the IOL axis alignment axis. IOL has 3 dots for making the alignment. During the implantation, the IOL is kept 15 to 20 degree under rotated. After clearing out the OVD from the anterior and the posterior side of the IOL, the final axis alignment is done. Now coming to the complications, the expected intraoperative complications were poor pupillary dilation, iridodialysis, vitreous loss, lens dislocation, donor dialysis. Fortunately, in my studies, all the surgeries were uneventful and no intraoperative complications were noted. For postoperative complications, patients were monitored for corneal edema, wound leakage, hyphema, opacification of the posterior capsule, and endophthalmitis. No significant postoperative complications were noted in my study. Now coming to the observations and results, total eyes enrolled in my study were 25. Demographically, males were 17 and females were 8. In pre-operative evaluation, with the rule astigmatism was found in 23 patients. Against the rule, astigmatism was seen in 2 patients. The number of patients and the corneal plane astigmatism chart is shown in the right side. 3 patients had the astigmatism of more than 1.5 diopters to 2 diopters. Majority, that is 21 patients, had astigmatism of 2 diopters to 4 diopters, and only 1 patient had astigmatism of more than 4 diopters. On the postoperative day 40, the refraction was performed for the patient. The accepted cylinder in majority of the patient, that is 14 patients, was less than 0.5 diopters. 10 patients required 0.5 to 1 diopters of astigmatism, and only 1 patient required more than 1 to 1.5 diopters of cylindrical correction. For this acceptance of the sphere, majority patient accepted sphere less than 0.5 diopters. Only 11 patients needed sphere of 0.5 to 1 diopters, and only 2 patients required sphere of 1 to 1.5 diopters. The alignment of the toric axis was checked on the day 40. The no rotation was seen in 14 patients, less than 5 degree was seen in 9 patients, and 5 to 10 degree was seen in 2 patients. The final result, the average preoperative astigmatism, that is delta K, in the corneal plane in all my patients was 2.93 diopters. Average postoperative astigmatism, that is the diffraction accepted was by the patient, was 0.49 diopters. The limitation of scope for further improvement, first, the high cost of the lens for patients. In my study, our EV toric was supplied to us by the company for 6,300 rupees, no financial interest. Second limitation was low number of study participants, only 25 eyes. Third, improvement for the further scope for improvement is role of toric lenses lesser than 1.5 diopters of astigmatism, role of posterior corneal curvature, and comparison with advanced toric marking suites or imaging system that I would like to perform. Now to the conclusion, toric IOLs are safe, effective, and surgical strategy for accurately correcting astigmatism with adequate knowledge and optimization of science, case selection, preoperative evaluation, IOL biometric calculation, preoperative marking, intraoperative markings, alignment of lens, and postoperative evaluation. Successful outcomes can be achieved even with limited resources. These were my references. Thank you for the time.
Okay. Thank you for your presentation. I would like to invite judges to ask a question to the presenter.
Karandikar, sir, you'll have to unmute yourself.
Am I audible?
Yes, sir.
Sir, you are.
Nitesh, you had a very good presentation, no doubt about that.
Thank you,
It
sir.
was a good study, but
Yes.
it doesn't go with the title of your study. Your title was Optimizing Outcomes. So
Yes,
in
sir.
that, I expect that different methods of selection of toric IOLs was done, which was not done. Only one method you have presented it like a speaker presenting his cases, not a comparison. This is a
Yes.
paper. When you are presenting it as a pre-paper, you have to have a comparison with other methods of optimizing outcomes.
Yes, sir.
I didn't find any advantage of a, again in your title, tertiary healthcare center.
Yes.
It also why even if it is, although your institute was a tertiary healthcare center, you have not used any other method for deciding the toric IOL.
Yes, sir.
No, see, this is all right as a case, as a not a case study. As a study, this is all right. But your title, optimizing outcomes, means with different methods you should have tried. What was the
Yes.
advantage of being a tertiary healthcare center? That also I didn't find anywhere. Anyway, you have done marking on a slit lamp.
Yes, sir.
Is there any difference if the patient is lying down?
Yes, sir. If the
What
marking is
is
done while the
wrong?
patient, yes, sir. If the marking is done while patient is lying down, there is a cyclotorsion of the eye.
That's right.
About 3 to 7 degrees. In majority of patient, there is a exocyclotorsion, sir, and in minor patient, there is
Right,
incyclotorsion.
right.
To avoid that, we have done marking sitting position, sir.
Right. Whatever deficiency of correction of astigmatism was remaining, was it dependent upon earlier high degree of astigmatism? Because there is no again comparison in your description, in your discussion of different degrees and how much of it was corrected. Whether lower degrees or upper degrees, that is not very clear from your slides at least.
Yes.
That would have been a part of a study when we are talking about the optimizing toric, isn't it?
Yes, sir. Yes, sir.
Another thing was whenever you are looking through the microscope, you have correctly mentioned about the head tilt that should be corrected. But what about the visual axis? Do you ask your patient to look straight into the light or not? That you have not mentioned because that again makes a difference.
Yes, sir.
Known complication of toric IOL is a misalignment.
Yes,
In
sir.
your presentation, you should have included that the complete removal of the OSD, viscoelastic substance, is necessary. Otherwise,
Yes.
there is always chance of a rotation post-operatively, and astigmatism will recur, or rather, it will be very difficult to convince the patient subsequently. Do you agree? Okay,
Yes, sir.
your presentation was good, but as a paper, I had my own limitations.
Yes, sir. Yes, sir. I will improve it, sir.
Did you mention, Nilesh, about how many were compound myopic astigmatics or compound hypermetropic astigmatics in your study,
No, ma'am, I haven't mentioned it.
in your paper? I
No,
don't,
ma'am, I haven't mentioned it.
pardon?
Doctor, how come you had post-operative sphere and post-operative cylinder? I mean, you planned it that way, or you had planned for emetropia?
No, sir, we have planned for emetropia. Despite planning for the emetropia, Those were the refractions accepted by the patients at the final
So
refractions.
what kind of biometry do you use, sir?
Sir, in our institute, we have a ultrasound immersion biometry.
Array. You
Ultrasound.
use ultrasound and optical biometry.
Immersion biometry, yes, sir.
You have used optical biometry? Have you done
No, sir, in our institute, optical biometry was not available, sir. Only recently we
That's
have
what I was
acquired it.
telling. That's what I was telling, because a paper has to have a statistical analysis also. Comparison has to be there. Anyway, it was a good presentation.
Yes,
Yes, that's all what.
thank you.
Thank you, judges. We have to move to the next presentation as because of time is limited. Now, Sangram Gaike will present presentation on exploring Nd:YAG laser energy levels in the management of PCO. Sangram, start presenting.
Share your screen, please, Sangram.
Yes, ma'am.
Yeah.
Good afternoon, everyone. I am Dr. Sangram Sunil Gaike from Krishna Vidyapit from Karad. I am second year junior resident. My paper title is Exploring India Laser Energy Levels in the Management of Posterior Capsular Opacification. Posterior capsule opacification or secondary cataract is a common delayed complication of cataract surgery by the growth of residual lens epithelial cells leading to visual symptoms. Even the advancement in intraocular lens design and phacoemulsification technique, it remains a common complication in lens surgery. Despite the advancement, PCO occur in 50% of the patient between 2 months and 5 years after the surgery. Posterior capsule opacification occurs in 3 types: fibrous PCO, abnormal lens epithelial cells growth can like wrinkle on the posterior capsule. Membranous PCO, it's also called listening pearls. Swollen opacified lens epithelial cells form pearls on the posterior capsule. Fibromembranous type. Sommering rings, a combination of fibrous and membranous growth on posterior capsule. The treatment of choice is Nd:YAG laser capsulotomy, a non-invasive procedure that uses high-power laser pulses to break down the opacified tissue with success rate of over 95%. The Nd:YAG laser at 1064 nanometer is in solid state laser that breaks ocular tissue through optical breakdown using a short high-power pulses. Nd:YAG laser capsulotomy is effective for treating PCO carried potential complications. Complications may include IOL damage, dislocation, increased IOP, glaucoma, retinal hemorrhages, iritis, vitreous prolapse, corneal injury, retinal edema, retinal detachment, cystoid macular edema, pupillary blockage, hyphema, vitritis, etc. Aims and objective. The main aim of the study is the mean energy level of Nd:YAG lasers for various types of posterior capsular capsule opacification. Specific objectives. Primary objective is to study the mean energy level of Nd:YAG laser required for various types of posterior capsular opacification. Secondary objectives are to find out the association of Nd:YAG laser energy levels required in different age group, to assess change in visual acuity after Nd:YAG laser capsulotomy, to assess change in intraocular pressure after Nd:YAG laser capsulotomy. Methodology. The study design. Descriptive observation study conducted at ophthalmology outpatient department of a tertiary care hospital. This study was done with written informed consent was obtained from all participants. Study population and sample size. A total of 48 eyes diagnosed with posterior capsule opacification after cataract surgery were included in this study. The sample size was calculated based on prior studies on Nd:YAG laser capsulotomy energy levels, considering a 10% difference in reported energy levels with a standard deviation of 67.63 plus minus 8.53. The calculated sample size was 16 eyes for each type of PCO. A sampling method was used to select the patient who meet the inclusion criteria. Inclusion criteria are patient diagnosed with PCO and who had undergone cataract surgery at least 3 months prior. Exclusion criteria are traumatic cataract, diabetic retinopathy, age-related macular degeneration, posterior capsular rent, retinal detachment in fellow eye, history of vitreoretinal surgery, excluding from the study any other complication that extended PCO. Study procedure: patients were evaluated using thorough ophthalmological examination, including best-corrected visual acuity, slit lamp biomicroscopy, intraocular pressure measurement using a Goldsman applanation tonometer. Fundus examination was performed with 90-D lens or indirect ophthalmoscopy to rule out any posterior segment pathology. Iliac laser capsulotomy was performed using a standardized protocol with the Zeiss Visualis 3 machine. Energy level required for capsulotomy are recorded. Variable studies are the primary outcome. The mean energy level required for Iliac laser capsulotomy is in different types of PCO. Secondary outcome: post-laser IOP changes and post-laser best corrected visual acuity. Result: demographic and clinical characteristics. The study included 48 eyes from 48 patients with a mean age of 64 plus minus 9.2 years. There was a predominance of female in this study with 27 females and 21 males. The initial energy levels for types of PCO: membranous require 1.5 millijoule, fibers require 2.3 millijoule, fibromembranous require 2.2 millijoule. Mean Iliac laser laser energy levels for different types of PCO. Mean energy levels required for membranous is 48 plus minus 6.5. Fibers require 82.8 plus minus 9.1. Fibromembranous require 74.8 plus minus 8. Visual acuity pre and post.
Sangram, 1 minute remaining. You have to sum up in 1 minute.
Visual acuity pre and post Iliac laser capsulotomy. Pre-procedure, best corrected visual acuity for membranous it was 6/18. After Iliac, it was 6/6. For fibrous, after Iliac it was 6/9. Fibromembranous 6/9. The p-value is significantly changed. Is less than 0.001%. Intraocular pressure pre and post operatively. Pre-operative for membranous it was 15.2 plus minus 2.3. Post operative after 1 hour it was 17.75 plus minus 4. Change in IOP after 1 hour it is 2.5 for membranous and p-value is less than 0.01. Post procedure after IOP 1 week it was normal as previous. For fibrous 16.1 pre-procedure plus minus 2.4. Post procedure IOP after 1 hour it was 19.7. The change in IOP after 1 hour is 3.6, and after the 1 week the IOP was normal as previous. Fibromembranous, the pre-procedure IOP was 15.7 plus minus 2. After procedure, change in IOP after 1 hour is 2.9. Discussion. My study which analyzed 48 eyes from 48 patients with mean age of 64.9.2 years with female predominance, broadly aligned with the 8 will differ from the several recent studies on Iliac laser capsulotomy. In my study, membranous PCO required the lowest mean energy, which was 1.5 millijoule, followed by fibromembranous, than fibrous PCO. These values are in line with the trends noted by Jitendra Kumar and Tiwari in 2020. Total Iliac laser energy levels in my series is 48 plus minus 6.5 millijoule for membranous, 74.8 plus minus 8 millijoule for fibromembranous, and 82.8 plus minus 9 for fibrous. The transient intraocular pressure elevated noted were plus 3.6 mmHg in fibrous PCO, plus 2.5 mmHg in fibromembranous PCO, and at 1 hour post procedure with normalization within 1 week. Study limitations: the sample size was small. Additionally, the follow-up period was limited, which have missed the last onset of complications such as persistent elevated IOP. Conclusion: the data reveal that the fibrous PCO type, which typically requires higher energy for treatment, is associated with the more pronounced immediate IOP increase compared to the membranous and fibromembranous.
Okay.
In a fibromembranous type
Okay,
of
you can stop the presentation. Time is up. So, judges, any question?
Yes.
Can I?
Sangram,
yes, ma'am.
one thing you must remember when you are preparing your slides. Please do not put paragraphs and just read them. You are supposed to make point-wise points and then elaborate on those. That is the right way of making your PPT. Remember, and always stick to time. You have overshot the time by far. You must.
You started very well.
Yes.
You started well and then
Yeah.
lost track. Somewhere you just got lost in all those figures. The study was good. Actually, I felt it was a very good study because you studied different markers, you studied best corrected visual acuity, you studied IOP, you
Yes.
studied the amount of energy required. I think Dr. Usha wants to say something.
Yeah.
Yeah.
Sangram, it was an excellent study, and as you rightly mentioned, the study, the size was, pretty small. But just tell me one thing: does a surgeon, when he's operating, do they play a role, in the type of the posterior capsular, thickness that you said, whether it is fibrous or membranous or fibromembranous? Does surgeon play any role? Is one thing that I want to ask you.
Yes, ma'am.
Yes, what?
Yeah?
What is
Yes
the
or no?
role?
What is
Their role or
how
not?
important? How
Yes, ma'am.
important is the
Their role is
surgeon's
important, ma'am. It's
role
typical.
while operating? If there is a posterior capsule, polishing. I think that you should have mentioned in your study. That surgeon does play a very important role. And in addition to transient complication that you mentioned, glaucoma, is there anything else you can think of?
Angle closure glaucoma.
Apart from glaucoma.
Yeah.
Anyway,
Yeah.
apart
That's
from
okay.
what doctor has said, Dr. Javeri has said, is there any selection of the IOL which can make a difference for occurrence of a PCO? Yes, Sangram.
No, sir. In our institute, we only
Oh,
put rigid and foldable lens, sir.
okay.
Yeah,
May
so
I
in
suggest you
foldable,
one-
which
may
type?
sorry. May I suggest you one, Parikshit, before you start, may I suggest your title should have been slightly different. You have written exploring ND-ag laser energy levels. See, ND-ag laser has got 4 types of energy levels. We are not concerned with that, but your title insists for that. In fact, role of ND-ag laser in different types of PCO. That should have been a better title. Otherwise, your study and your statistical analysis was as on an expected line. Nothing new in that. But anyway, so it was a good presentation. Parikshit, please, I interrupted you. Parikshit, please.
No, sir, I interrupted you. I'm sorry. No, you have done a very good study. You studied all the parameters, but as Malik ma'am said, you must stick to the time, because if you have done so much and you are not able to present all of it, and if not able to conclude, then you're not doing justice to the work that you have done.
Yeah.
And
I think, Sangram, you could have skipped the initial few slides, which were theoretical.
Critical part. Yes.
like
But it
Usha
was a
ma'am
very
was
good
saying,
presentation.
what will the surgeon do? So has surgeon done phaco? Has he done SICS? If he has put a lens, depending on the lens, does the PCO vary? Even that is also important, the technique and the type of lens. So that also you should mention the
And
next time when you do it.
to all the audience, except for the judges, of course, I would really like to say, all of you PG students need to learn how to make your presentations. You need to learn that. It's a very important part. Believe me. Okay, we'll go to the next, Ganesh.
Yes, ma'am. Dr. Nikhil will present on eye diseases in preterm babies. Dr. Nikhil, you can continue.
Ganesh, 1 minute. Dr. Parandikar is saying something.
No, I am
Yes.
not saying anything. In fact, teachers have to play important role in making students' presentation.
Sir, teachers को पूछता कौन है आजकल?
No, that is different story. Also,
should be-
altogether socio-economic changes are there. Anyway, please go ahead. Please go ahead. Sumit, please go ahead.
Yes, sir.
So put it on a slide mode.
Ganesh, sorry.
Hello, am I audible?
Yeah, Nikhil, you can start.
No
Good
slide.
afternoon, everyone. Myself, Dr. Nikhil Narade. I will be presenting my paper on topic Born Too Soon, studying retinopathy of prematurity in the preterm babies at a peripheral tertiary care hospital. As we all know, retinopathy of prematurity is among the most common causes of childhood blindness. Approximately 32,300 infants worldwide are diagnosed with irreversible vision impairment due to ROP annually, out of which approximately 20,000 become blind or severely visually impaired. Despite advances in neonatal care, the occurrence of ROP and associated vision impairment has been increasing somewhere on Earth, and it still remains difficult to control. The occurrence of ROP in India and other developing nations is also known as the third epidemic, which is a resultant of combination of uncontrolled supplemental oxygen, which was seen in first epidemic, and the evolving pattern. And the second was evolving but uneven care of very preterm infants, which was seen in second epidemic pattern. This is a slide that depicts the zone-wise distribution of ROP. And here is the stage distribution of ROP, in which stage 1 belongs is line of demarcation. Stage 2, presence of ridge. Stage 3 is ridge with extra retinal fibrovasculature. Stage 4 is subtotal retinal detachment, and stage 5 being total retinal detachment. Along with a plus disease mentioned as dilatation and tortuosity of vessels in 2 or more than 2 quadrants. Our aim was to study the prevalence of retinopathy of prematurity and its severity levels at a peripheral tertiary care center. It was a prospective observational study done for 12 months with 195 neonates selected using universal sampling technique. These were my inclusion criteria. I don't have any financial disclosures or conflicts of interest. Procedure. The study was conducted after acceptance from the institutional ethical committee. Informed consent from the mothers were taken after explaining the procedure. The eye drops of the neonates were eyes were dilated with phenylephrine 2.5% plus tropicamide 0.5%. The topical paracan eye drop 0.5% was instilled, and the pediatric via speculum was applied. Examination was done with indirect ophthalmoscope along with 20 diopter lens, with scleral indenter being used whenever needed. The neonates were called out for follow-up depending upon their severity levels of ROP. Let's come to the results. In our study, 65% neonates were males, whereas remaining were the females. Among those, 60% belong to the low birth weight group, that is 1500 to 2500 group. In our screening, we found 80% neonates being normal retinal vasculature, along with 20% were having some degree of retinopathy of prematurity. In the first chart, we can show the distribution of cases along the zones, in which the zone 2 was comprising majority of the cases, that is 59 cases shown in light cyan color, followed by the zone 3 and zone 1, which is suggestive of peripheral to mid-retinal distribution of the diseases. In a second chart, we can see that the cases were distributed along the severity of the disease, having 65 cases belonging to the plus disease, while rest belonging to the 3 plus disease, suggestive of larger cases experiencing more severe form of the disorder. Another chart shows the breakdown of the cases along with the stages, with stage 2 is the most common comprising, that is 45.7%, followed by stage 1 and stage 3 with 23% and 18% respectively. On follow-up, the majority of the cases, like 30% patients were lost to the follow-up, suggesting major gap in the continuity of the care, while 27% cases showed spontaneous resolution, while 8% showed progression to the aggressive ROP. Let's discuss some points. In our study, in the first table, we can see the comparison of our prevalence of retinopathy of prematurity in our study with that of Journal of Ophthalmology, USA, Korea, and Singapore. The prevalence being 20%, 30 to 47%, 21.3%, 27.7%, and 29.2% respectively, suggesting a global significance of retinopathy prematurity as a concern of neonatal care. Whereas in other second chart, we can see the comparison of prevalence with various studies conducted in India, showing prevalence being Kaul et al., Manohar et al., Gupta et al., and Anupdip et al. As being 28%, 19.9%, and 21.7%, 37.7% respectively, suggestive of likely reflecting the difference of neonatal care screening protocols or the health care infrastructure. Along with in this, we can
1 minute remaining, Nikhil. You have to finish in 1 minute.
In this slide, we can see the comparison of zonal distribution of the majority of the cases. In our cases, majority of the patients belong to the zone 2, whereas in a study conducted by others, they were in the zone 3, suggestive of the more central retinal involvement in the disorder in our cases. Whereas stage-wise, there was no differentiation found with other studies comparatively in that of our study. In conclusion, in our study, we felt 20% were diagnosed with ROP. Along with that, 7.69% of the total cases presented with aggressive ROP. This suggests there is a need of initiative to improve the availability and accessibility for the ROP screening in the rural areas where there is a limited access to specialty. Along with a significant number were lost to the follow-up. Along that, 8% progressed direct to the aggressive ROP, bypassing the intermediate stage. This also suggests that there is a highlight. It highlights the urgent need to raise the awareness about the importance of routine follow-up, screenings, and regular treatment for the at-risk neonates. Final conclusion, with advancement of neonatal care, the neonatal mortality rates have declined, but this has been accompanied with a rise in ROP incidence, which emphasizes the need for vigilant monitoring, follow-up, and timely intervention to detect and manage the ROP in early stages and prevent the complications. These are my references.
Thank you, Nikhil.
Good.
Good paper. Good paper, Nikhil. Well presented also, and you finished in good time. And as you said, of course, ROP is very important nowadays. I will give you a point of view from the layman's point. You know, many laymen nowadays feel that all babies who are born in hospitals are shifted to the NICU for the purpose of census. You know, this is the point of view especially among the rural population. That's why many babies are lost to follow-up because they don't bring them back. They feel if they bring them back for follow-up, then again they might be put in the NICU and they can't afford it. So this is one point I wanted to highlight actually, and it's a good thing your paper was there.
Thank you, ma'am.
Over to the other judges.
See, with the improved interventions and other things, neonates are surviving longer. And that's why it has, as you have correctly pointed out, so the incidence of ROP is also more, has occurred in the old age people. The survival rate has increased, so geriatric diseases have also increased. What is important here is of medico-legal importance. If the pediatrician and ophthalmologist don't work in coordination with one another, there are cases in the court of law which have got a medico-legal importance. So you have correctly laid a stress on ROP in neonates. Again, you wanted to include other eye diseases also in preterm babies. That's what
No,
the title for, studying eye diseases. What can be the other diseases in the preterm babies? I mean eye condition, eye diseases, apart from the ROP. I am a comprehensive ophthalmologist.
there can be retinoblastoma present at the birth.
Oh, retinoblastoma at birth?
Sorry, sir. Or glaucoma.
Not retina. Any other?
Glaucoma, present of congenital glaucoma.
Preterm.
Can you not get congenital cataract in babies? Anyway, I think the scope of your study was ROP. So,
apart from, no, that is a perfectly all right. The title is eye diseases in preterm babies.
yeah.
Not ROP in preterm babies. See, there is
Can you think of
incidence of strabismus and increases incidence of myopia in preterm babies. Whenever you see the follow-up with the ROP patients, you will notice this thing, that the strabismus and myopia are becoming more and more common with these preterm babies. Okay, this is just additional.
Usha ma'am, any comments?
Just one last question. Can you suggest something, in a premature child which is related to brain, Nikhil? Your presentation was very good. So can you give me one, can you tell me one condition where the eye and brain is related in a preterm child? Have you heard of a terminology which is called as a cortical visual impairment, CVI, which is very, very common in a premature child? Yeah. And one more thing which I wanted to ask you was, you mentioned about phenylephrine 2.5%, right? Can you just tell me the the trade name for this drug? Phenylephrine 2.5%?
Don't think
One last question. What is it that you said that prevention is better than cure. We need to create awareness. How do you think that you can create awareness?
First of all, ma'am, we can the mothers who are going giving birth to the preterm child, in those mothers, we need to inform their husbands also. This is the another possibility along with the preterm birth of your child. This can happen to your father also, because in Indian society there is unfortunately it is sad scenario that mothers don't get that much of say in the treatment. Most of the times, husband since
They can't
I'm
hear
working in a
them.
tertiary care hospital, we most of the time see mothers say that the बच्चे के पापा तो सारे पैसे दारू पे उड़ा देते हैं, तो हमको हमारे पास इधर आने के लिए पैसे नहीं रहते हैं. Like for example, these are the kind of express reasons we get. So we need to convince the father also along with the mother that your child might suffer from this disorder, and you have to take care of the child for that purpose also.
Do you feel that
Thank
in
you,
an
Nikhil.
NICU? Do you
Well,
feel that in an NICU, every child who is in the NICU should be examined by an eye specialist? Every child, whether it is required or not required.
yes.
Yes, ma'am.
Yeah, do you think so?
Yes, ma'am. Yes, ma'am.
Good presentation, Nikhil. Thank you.
Thank you, Nikhil. Samruddhi,
Thank you,
if you
Nikhil.
are available, you can start sharing your screen. Samruddhi will be presenting on catching the clue early, case of Waardenburg syndrome.
Am I audible, sir?
No,
Hello?
it's not. No.
Network is slow. That's why
Rani, you need to share first.
start sharing. Yeah.
First share. Yeah. Go ahead. Okay, now make it full screen.
Everyone, I'm Dr. Samruddhi Rane. I will be presenting on catching the clues early, a case of Waardenburg syndrome. Waardenburg syndrome is a rare clinical entity with a worldwide incidence of 1 in 40,000. It is an autosomal dominant disorder of neural crystal development, but autosomal recessive inheritance patterns are also observed in some subtypes. It is characterized by pigmentation abnormalities, that is, heterochromia iridium and white forelock, sensory neural deafness, dystopia canthorum, and broad nasal root. Here is a case of a 3-month-old female infant who was brought by her parents to the ophthalmology OPD complaining of difference in color of the two eyes. The child was born at full term by a normal vaginal delivery following a consanguineous marriage. There is history of hearing loss and loss of speech in mother. On ocular examination, the child followed light in both the eyes. The head posture was normal, ocular posture was orthophoric. On examination of lids and adnexa, we noted telecanthus or dystopia canthorum, that is, increase in the distance between the two medial canthus. On calculation of Waardenburg index, it was found to be 2.05. So, a Waardenburg index of more than 1.95 is considered significant. Conjunctiva was normal in both eyes, cornea was clear. On iris examination, we could note heterochromia iridium in the left eye. Anterior chamber was of normal depth. Lens was clear. On distant direct ophthalmoscopy, a bright red glow was noted in the left eye. And on indirect ophthalmoscopy, choroidal hyperpigmentation was seen in the left eye. On audiological examination, we could see bilateral indication of outer hair cell dysfunction on otoacoustic emission, and there was right profound and left moderately severe hearing loss on auditory brainstem response. Here is a clinical picture of the patient depicting the broad nasal root, dystopia canthorum, and heterochromia iridium. The dystopia canthorum was confirmed by calculating the Waardenburg index with the help of the formula W is equal to x plus y plus a by b, where a is the inner canthal distance, which was found to be 40 mm, b is the interpupillary distance found to be 65 mm, and c outer canthal distance found to be 105 mm. So on calculating, we got the index as 2.05, so it is more than 1.95 and considered significant. Here we can see the bright red glow in the left eye on distant direct ophthalmoscopy. So the diagnostic criteria involved are major and minor. The major criteria involves sensory neural hearing loss, iris pigmentation anomaly, white forelock, dystopia canthorum, and if any first degree relative is affected. Minor criteria are skin hypopigmentation, medial eyebrow flare, broad nasal root, hypoplastic alanasi, and premature graying of hair. So for clinical diagnosis, one must meet either two major or one major and two minor criteria. In our case, the clinical findings, that is sensory neural hearing loss, heterochromia iridium, dystopia canthorum, broad nasal root, along with the maternal history of hearing loss and loss of speech, supported a diagnosis of Waardenburg syndrome type 1. Early diagnosis enabled timely referral for audiological rehabilitation and genetic counseling. Auditory pigmentary syndromes are caused by physical absence of melanocytes from the skin, hair, eyes, or stria vascularis of cochlea. There are 4 types of Waardenburg syndrome. Type 1 is characterized by dystopia canthorum, where Waardenburg index is more than 1.95 and associated with other abnormalities. It is due to mutations in PAX3 gene. Type 2 has pigment abnormalities and it is due to mutation in microphthalmia associated transcription factor gene. Type 3 is also known as clean Waardenburg syndrome associated with type 1 characteristics. Along with upper limb abnormalities, it is due to paired box3 gene mutation. And type 4, also known as Shah-Waardenburg syndrome, it is associated with type 1 characteristics along with Hirschsprung's disease, seen with the mutations in SOX10, endothelin receptor B, and endothelin 3 gene mutations. So, this case highlights the importance of early recognition of syndromic features in infants with ocular pigmentary changes and hearing deficits, enabling prompt intervention and multidisciplinary management to improve long-term developmental and communication outcomes. These are my references. Thank you.
Thank you, Samruddhi. Over to judges. Any questions? So, yeah.
Ideally, Samruddhi, yours was a single case. So it doesn't really qualify as a free paper, but it's okay. Since you've been included, we accept that. Ideally, it should have gone as a poster, but fine. And you presented it very well. Your slides were very good and very clear and precise. So
Thank you.
I quite liked it.
Samruddhi, can you please
What is the type of
close the screen
inheritance?
sharing?
Stop screen sharing.
What is the type of inheritance in
It's
Waardenburg?
autosomal dominant mode of inheritance.
So there is no role of consanguinity as such. You have specifically mentioned about the consanguinity. So if
Yeah,
it is
yes.
autosomal dominant, you wanted to
There is only 50% chance that the offsprings will get affected, and if either of the parent is having the genetic defect, so it may be.
how your early diagnosis is going to help the child in the long run. You have said catching in the early, isn't it? Catching the clues early.
Yeah, yes. So, because we have diagnosed it at just a 3-month-old child, and so early diagnosis will enable us in proper audiological rehabilitation. That is the main thing, and speech therapy can also be provided.
Correct.
So, multidisciplinary management is involved basically in this study. Not only ophthal, but we need to look after audiology,
What will
speech
you do
therapy.
in ophthalm?
And
In
visually, what will you
ophthalmology,
do?
Pardon?
sorry.
What will you do in ophthalmic?
Yes, sir. Yes, sir. In ophthalmic management, we can give sunglasses if because there is heterochromia iridium, so pigmentation, there is iris hypopigmentation. Then even we can give colored contact lenses for cosmetic purpose. We can even go for any ophthalmic plastic surgery for the telecanthus, dystopia canthorum.
Dystopia,
Then,
not telecanthus.
the dystopia canthorum.
Okay, fine.
Okay, thank you, sir. Thank you, ma'am. Now, Dr. Pallavi Garg will be presenting on Eyes Silent Cry, unmasking the mysteries of hidden systemic diseases. Pallavi?
Yes, sir.
Yeah.
Is it visible, sir?
Yeah. You start presenting.
Okay.
We can see.
Good afternoon. Yes, sir. Good afternoon, everyone. Thank you for the opportunity. Today, I'll be presenting a case series. The title of the series is The Eyes Silent Cry, Unmasking the Mystery of Hidden Systemic Disease. So the systemic disease we're talking about today is ANCA-associated vasculitis, which is a rare immune-mediated necrotizing vasculitis of small to medium vessels. It commonly affects the respiratory tract and the renal system, but ocular involvement is seen in 30 to 40% of the cases. And in 8 to 16% of such cases, eye involvement is the initial manifestation. The two cases here today have ANCA positive, and the first case is that of a 32-year-old female who presented with painful protrusion of the left eye, which was acute in onset, rapidly progressive, with redness, discharge, and vision loss since the past 20 days. She has multiple history of episodes of bilateral eye pain and redness, for which she sought medical attention, but she was only treated with unknown topical medications. She also gave a history of hematuria, cough, hearing impairment, on and off fever since the past 1 year, and generalized weakness. She was referred to us from an outside hospital, and they had a working diagnosis of left eye proptosis with suspected peripheral corneal thinning secondary to an unknown etiology. So on examination, the right eye visual acuity was 6.6. Extraocular movements were full and normal in all cases. Fundus was normal. On palpation, there was no orbital mass felt. But the left eye, she denied the PL, and her extraocular movements were restricted in all cases. And on palpation, there was a firm, tender swelling with irregular surface and ill-defined margins that was noted in the superolateral quadrant of the left orbit. It was immobile, non-transilluminant, non-reducible, devoid of pulsations, and fingers could not be insinuated. So at this point, we went ahead with some investigations. We'll first look at the anterior segment. So left eye anterior segment, there was axial proptosis, there was diffuse congestion, there was inferior corneal perforation with iris collapsing from the wound, and there was a purulent discharge sticking to the cornea. And also the anterior segment, since there was perforation, it was collapsed and flat. So rest of the details could not be made out. At this point, we went ahead with some investigations to rule out any infective cause. On B scan, we saw that there was no vitreous echoes. So we ruled out panophthalmitis and endophthalmitis. We went ahead with a CT scan of brain in orbit, which was suggestive of an orbital pseudotumor in the left eye superior temporal quadrant, same quadrant where we had felt the mass. We went ahead with systemic investigations, including an USG abdomen, which showed a grade 1 renal parenchymal change. HRCT chest was done, which showed multiple cavitatory nodules. On blood investigations, her C-reactive protein was positive, RA factor was positive, and anti-PR3 IgG, which is C-ANCA, was also positive. So she was diagnosed as left eye axial proptosis with inferior corneal perforation secondary to a peripheral ulcerative keratitis, secondary to ANCA-associated vasculitis. Second case was that of a 56-year-old female who presented with pain more in left eye than right, which was sudden dull aching since the past 2 months, associated with tetanus photophobia and watering since the past 1 to 2 months. In left eye, she also had mild discharge. She had generalized weakness since past 4 months and had a fever episode 2 weeks back and was diagnosed with a UTI. So on examination, right and left eye, both eye had a visual acuity of 6.9 unaided, improving to 6.6 on pinhole, neovision of N12. Color vision and fundus was normal. Extraocular movements were normal in both the eyes. Mild pain was there on movement in the left eye. Right eye on anterior segment evaluation showed a focal conjunctival congestion present on the temporal side, which was non-blanching, with nodule present 3 mm temporal to the limbus, which was measuring about 2 into 2 mm in size. So she had right eye nodular scleritis. Left eye on examination had a diffuse conjunctival congestion, which was extensive, which conjunctival necrosis and retraction was seen from 9 o'clock to 1 o'clock position. Scleral thinning was noted in that same area with underlying uveal tissue to be prominently seen. Corneal haze and thinning was noted in the same area from 9 o'clock to 1 o'clock position peripherally. So left eye, she had a necrotizing scleritis kind of a picture. On a USG abdomen, she had grade 3 renal parenchymal changes, and she also had rapidly increasing creatinine, decrease in urine output, and pyuria. So clinically, she was diagnosed as rapidly progressive renal failure patient. On blood investigations, her CRP was positive, RA factor was negative, but anti-PR3 IgG, which is C-ANCA, was positive. So right eye, she had nodular scleritis, left eye, she had necrotizing scleritis, secondary to ANCA-associated vasculitis. So in both the cases, we saw that C-ANCA, which is anti-PR3, was positive. There were ocular features. First case had a HRCT showing cavitatory nodules, and urine analysis of the second patient showed a rapidly progressive renal failure kind of picture. So both of them were ANCA-associated vasculitis, presenting with varied ocular findings. Both the cases ocularly were treated with topical antibiotics. In left eye, in the first case, since the left eye had a perforation as well, After initial treatment with antibiotics, we went ahead with a left eye medial tarsorrhaphy, and later a BCL was applied. In second case, with antibiotics and steroids, the patient improved very well. The
1
rheumatologically
minute remaining. Pallavi, 1
a
minute remaining.
patient was given initial course of steroids, IV, followed by oral steroids. Eventually, cyclophosphamide was started for both the patients. So my discussion is that both the cases, even though was C-ANCA positive vasculitis, they had a very different eye manifestations, and it's very important for us to know the ocular manifestation of this disease, which usually involves the sclera, the conjunctivitis, the cornea, sometimes involving the lid, optic neuritis, and retinal vasculitis is also seen in rare cases. So it's very important to know the ocular manifestations. So the summary is that in C-ANCA associated vasculitis, even though there is varied ocular findings, as an ophthalmologist, it's very important to timely recognize the pattern and go for a multidisciplinary approach so that it can prevent irreversible ocular damage and systemic morbidity. Thank you.
Good.
Yes, sir. Over to the judges.
A very good presentation. You have
Thank you, sir.
pointed out all the aspects very correctly, taken into account all the systemic features which are so important to come to a conclusion and manage the case properly. On many occasions, otherwise, what happens? Our attention remains only towards eye and eye only. So we may happen to neglect sometimes. Except for that matter, nodular scleritis. Here we definitely go for. But the first case which you had, really speaking, I would not have thought of a systemic seeing the eye condition itself. So it was a very good presentation overall. Other judges, please.
Good presentation. I've described all the features, and it is a very unusual disease. Actually, we don't come across it very frequently. So, good paper.
Thank you, ma'am.
Yeah. For the Pallavi, it was an excellent presentation. But I was wondering the second case, what was the differential diagnosis which you thought of it, before, because the second case was, scleritis, which we see, on a regular basis, episcleritis, scleritis. So did you ever think of, for the second case I'm asking you, did you ever think of any differential diagnosis for the second case?
Ma'am, rheumatoid arthritis was more like in our mind, but since RA factor was negative, it was like a shock for us also. Then we had this pattern of kidney not behaving very well and the creat rising. So rheumatologist has suggested let's go ahead with other features, or let's go ahead with ANCA as well. So that came out to be positive. So yeah, like usually patients, if they would have come with episcleritis, scleritis, we would have just told them that it might be rheumatoid arthritis, likely to be more than ANCA.
Right. And did you ever think of ankylosing spondylitis?
Yes, ma'am. Like she actually never came with any complaints of arthralgia also. Like her only complaint was generalized weakness. She had no joint pains, no back pain. So that was also not in favor of ankylosing spondylitis as well as RA.
Because in our day-to-day practice, what we do is whenever we see a case of scleritis, the first line of treatment is, of course, the steroids, and it's known for exacerbations and remissions. We never think, the diagnosis which you thought of.
Yes,
It's a very good presentation.
You did HLA-B27 also, no?
No, sir. We had gone for ANCA after RA. So since that came out positive, we didn't go for HLA. It's like a costly investigation. So
not very costly. Okay, anyway.
So where are you? One last question, Pallavi. Where are you studying? Because your slide was showing Mangalore.
Yes. I am doing my post-graduation from Kasturba Medical College, Mangalore. But since I've done my UG from Maharashtra, Mumbai, so I was in touch with people from Maharashtra. So I wanted to present in this conference as well.
Good. But are you a member of the Alliance?
Yes, ma'am. Yes, ma'am. I'm a member of it.
Because you have to be.
Yes, ma'am.
Managing committee member.
Okay.
Thank you.
Thank you.
Thank
you.
Was it the last presenter?
Yes, ma'am. Yeah, this was the last presenter. Over to Dr. Sumit for concluding the session.
And I must congratulate all of us for concluding absolutely in time. We have over a single minute.
Yes,
So,
ma'am.
You didn't ask many questions, that's why.
so you are the one who asks all the time.
No, no, and we have to also compliment the speakers, of course, and the organizers, Dr. Piyush and Dr. Sumit. They
Yes.
knew all the eminent judges who are going to be there, and they still kept it in such a way that it will finish in 1 hour.
I would like to add just one thing. Today is Parikshit's birthday. So wish him a happy birthday.
Oh,
Parikshit, happy birthday.
Thank you,
happy
ma'am.
returns of the day, Parikshit. A
Happy
party will
birthday.
be there.
Thank
Huh?
you for sparing your time,
Arre nahi, sir.
managing OPD, teaching
No.
young residents whilst
Yes,
also
Cam.
celebrating your birthday.
Thank you.
बहुत बहुत बहुत
पार्टी ड्यू रहेगी परीक्षित.
पार्टी ड्यू है मैम, आपको कभी भी पार्टी आपके आके दे
Online
देंगे
wish,
पार्टी आपको
online
मैच
wish, online party. You can say.
नहीं नहीं ऑनलाइन नहीं मैम, प्रॉपर पार्टी. हम पार्टी देने में एकदम पार्टी मैन है.
don't believe in virtual.
चलो, I think we better hand over to the next session.
And, yeah.
Yes.
Thank you.
So the
All of you.
mark sheet
Thank
कहाँ
you.
होगी for us to fill?
Sorry, I think you have to write it and send it to Sumit.
Send it to Sumit.
Sumit or Ganesh.
You
no?
can send to Ganesh and me, ma'am.
Sure.
Ganesh will calculate together.
Yes, yeah. Thank you, Sunaina ma'am, Parikshit sir, Usha ma'am, and Karandika sir. Thank you very much.
Thank you for having us, judges. Thank you.
Thank you,
Thank
Fran.
How are you?
So with this, we
Yeah,
move
Go
on
to
thank
next
you,
session.
everyone.
Yeah.
Thank you, everyone. So we would be starting with neurophthal session. I invite Dr. Abhilasha. Yeah, Abhilasha, please.
Hello, everyone. Am I audible?
Yes, Abhilasha, we can hear you. Please go
A
on.
bit louder, closer.
Yeah. So hello, everyone. I welcome everybody for this wonderful neurophthal session. And let's come together and let's be so precise and excellently, flawlessly we'll conduct this session. So I first welcome our president and all the scientific committee members and our chairman, Dr. Himalini Saman, who is like well-renowned neuro-ophthalmologist, pediatric ophthalmologist, and the president of BOA, along with Dr. Shubhangi Bhave ma'am, who is a past president of BOA from Nagpur. Apart from that, I would like to ask Dr. Trupti to enlist all the rest of the esteemed panel of speakers.
Yeah, good afternoon, everyone. So we would be starting our session. I request the participants to adhere to their timings. Those who, yeah, good afternoon, Bhave ma'am. So those who have the difficulty in uploading, then we will take them in the second thing. Now we start with the first case by Dr. Vardha. 6 minutes is your timing, and Dr. Mithila and Dr. Ramesh Murthy sir would be the panelists for this session. Dr. Vardha.
Yeah, I'm going to share my screen.
Vardha is working at Madhav Netralaya, Nagpur.
Is my screen visible?
Yes.
Okay.
Yes, Vartha.
Yes.
Yes.
Shall I start?
Start, Vardha.
Please start,
6
Vartha.
minutes.
So, good evening, all. First of all, I would like to thank MOS Scientific Committee for giving me this opportunity. I'll be presenting a case when infection strikes the apex, post-viral orbital apex syndrome. So, this man presented to our clinic, 68-year-old, presented with rash over his right side of the face, nose, involving right eye for 3 weeks. He had diminution of vision in the right eye for 2 weeks, diplopia for 2 weeks, drooping of the upper lid, along with pain, watering, and redness in the right eye for 2 weeks. So he was diagnosed locally as a case of herpes zoster and was treated for the same for past 20 days. He also had an history of left side Bell's palsy 2 years back and also had hearing loss long back, like for the left ear. There was no systemic illness. On examination, his right eye vision was reduced, color contrast were reduced. There was a relative afferent pupillary defect. Rashes were seen over the right side of the face, nose, nasal bridge, involving the tip of the nose. there was right hypotropia in all gazes, hypotropia with proptosis. Ocular motility was limited in all gazes. There was ptosis, skin over the lid was edematous, and there were vesicles over the lid. There was congestion and chemosis of conjunctiva. Cornea was clear. Whereas in the other eye, there was lag of thalamus of around 2 millimeters and there was no corneal exposure. Rest of the anterior segment examination was normal. I did fluorescein staining for the corneal stain. It was negative for both eyes, but the corneal sensations were reduced in the right eye. Fundus examination was normal in both the eyes. Intraocular pressure was measured for the left eye, not for right eye, because of the acute condition. And cranial nerve examination was done, which involved right side, second, third, fourth, fifth, and left side, seventh and eighth nerve. So the diagnosis of right side herpes zoster ophthalmicus, right eye ophthalmoplegia with multiple cranial nerve involvement. It can be orbital cellulitis or orbital apex syndrome. I was a little confused. And also left eye had a left side Bell's palsy and lag of thalamus. So herpes zoster ophthalmicus is caused by reactivations of the latent varicella zoster virus infection in the trigeminal ganglion, the ophthalmic division of ophthalmic division. The onset of the ocular involvement is around 1.8, that is 1 to 4 weeks later after starting the rash, you get an ocular involvement, and it is seen in 20 to 70% of the patients of HZO. So if you look at the anatomy, when the infection pierces the orbital septum, it is called orbital cellulitis. And when it invades furthermore, it is called orbital apex syndrome. So orbital apex syndrome is an extraorbital complication of orbital cellulitis, which can be sight-threatening as well as life-threatening infection of soft tissue posterior to the orbital septum. We get confused between orbital apex syndrome, superior orbital fissure syndrome, and cavernous sinus thrombosis. The differentiating features are involvement of second nerve and V1 and V2 branches of the trigeminal nerve. So in orbital apex syndrome, there is involvement of second, that is optic nerve. On doing literature search, I could find only 20 reports of orbital apex syndrome secondary to the herpes zoster ophthalmicus. The etiology of orbital apex syndrome can be neoplastic, inflammatory, developmental, traumatic, and infectious. Here it is infectious, and blindness can occur uh, by way of extraorbital extension of infection to the orbital apex. My slide is not moving now. Yeah.
Just click on the screen.
Yeah, got it. So we proceeded with the MRI brain with orbit along with MR venogram, and which was suggestive of orbital inflammation and in which cavernous sinus was not involved. Further investigations like complete blood counts was done, which showed leukocytosis, ESR was raised. Fasting blood sugar and postprandial blood sugars were normal. Thyroid profile was normal. Chest, paranasal sinus and X-ray of chest and paranasal sinus was done, which was normal. CSF analysis was normal. We deferred perimetry and VEP considering the acute stage of the disease. The diagnosis of right side herpes zoster ophthalmicus complicated by orbital apex syndrome was made. The patient was treated under ophthalmologist and physician's care. Vitals as well as ocular signs were very closely monitored. He was started on intravenous antivirals, intravenous methylprednisolone, oral calcium supplements and antacids. Left eye was treated with lubricants and taping at the bedtime to prevent exposure keratitis, and right eye was treated with topical acyclovir eye ointment along with topical steroid and lubricants. On literature search, complete or near complete resolution of ophthalmoplegia due to herpes zoster has been reported to occur in 76.5% of the cases, and it may take between 2 weeks to 1.5 years. We followed up our patient for around 4 months, and after 4 months, we could restore his vision to 6, 9, and 6. Even the ocular motility was full after 4 months. So this is the picture after 4 months. So the take-home message is orbital apex syndrome is a rare but severe complication of HZO. Primary care physician should be aware of this complication and should monitor patients carefully during the first 3 weeks after the onset of HZM. The workup should be initiated through blood test and radiography, especially MRI and MRV, and prompt identification is imperative for proper treatment and preservation of vision. Thank you.
Thank you, Varada.
So,
Excellent.
very interesting case, Dr. Varda. And like you rightly said, it's not something we see very commonly. And all these patients, I think we really need to look for any underlying comorbidities or anything which may be causing immunosuppressive states. Also, like you rightly said, a long-term follow-up may be needed. A few of these cases have needed antivirals and even the steroids for up to a year to manage these patients. So just to give a small tip, whenever we are seeing all these cranial nerve palsy patients in our OPD, even if it's a very obvious mononeuropathy, I think all of us, along with the motility, we need to test for the corneal sensations and the cheek sensations, eyelid sensations. Many of us may not be doing that. Apart from the motility, we should start seeing all these also so that we don't miss any important information. Ramesh Murthy, sir, please for your expert comments.
Yeah, thank you, Dr. Vada. That was a very great learning case. I just want to highlight 2 points. One is herpes zoster can have unusual presentations. So I had this anatomy professor who presented with severe chemosis, severe lid edema, and severe pain for 2 days, and the rashes came on the third day. So herpes zoster can have very unusual presentations, and it can mimic many other diseases. The second point is we should have a very high index of suspicion for aspergillosis, mucormycosis in our setting because we see these cases routinely. So any orbit Lippic syndrome, we should treat very seriously and ask the patient to go get an immediate imaging done.
Yeah.
Yeah. Thank you.
Thank you.
Thank you, Vardhan.
Thank you, sir. Thank
Right.
you.
Bhavin? Yeah.
Yeah. It was a great case, Varda, very well presented. Did you give steroids initially along with the antiviral?
Yes, along with after starting antiviral, after 2 days, they've started intravenous steroids.
Okay. So this case exemplifies the need for multi-speciality management of a case. Basically, one has to also rule out any reason for immunosuppression. Old age was one in your patient. So that also needs to be, but a very well-managed case.
Thank you.
Anybody, other panelists would like to comment?
So I just want to make a comment saying that, I just want to say that even I had a similar patient, Varda, similar to yours, except that it was not an orbital apex. So the optic nerve was not involved, but presented with a laterectus palsy. But I didn't have to give any steroids. It just got back to normal on its own.
One more input from my end, you need to do a nasal cavity examination and a dental examination because nasopharyngeal tumors, they do have the base of the skull involvement and then you have the multiple cranial nerves.
Yes. Yeah. So if there are any other comments anybody wants to make or questions, we will definitely take at the end of the session, Dr. Varda. So we'll discuss. So now I welcome our next speaker, Dr. Harsha Pagad, who will be presenting When Only One Eye Tells a Story. And the panelists are Dr. Janil Seth and Dr. Mayur Morekar. I welcome everybody. And Dr. Harsha, we can go ahead with your presentation.
Am I audible?
Yes, yes.
Is my screen visible?
Not yet.
Not yet. Now?
Initially, it was visible. Now it's not.
Now, can you see my screen?
No.
Not yet. Okay. Just a moment.
So till the time Dr. Harsha is uploading her presentation, Dr. Varda, I would like to know your experience. Okay, we'll take this question afterwards. Let's go ahead. Yeah.
Yeah. A very good afternoon and thank you, Moscon, for giving me this opportunity. So when only one eye tells a story. So this is the case of a 37-year-old female married, non-lactating with a 2-year-old child. So she came with a history of recurrent headache past 2 months. The headache was generalized, associated with transient visual obscurations, giddiness, and typically had postural variation. It was not associated with any projectile vomiting, diplopia, tinnitus. There was no systemic history or neurological history, and she was not on any medications. So on examination, she was obese. The BMI was around 30 kg per meter square. General and neurological examination was normal. On ocular examination, she had an unaided visual acuity of 6.6 and 6 in both eyes. Pupils were round, reactive to light with no RAPD. Color vision was normal. Anterior segment was normal. Intraocular pressure was within normal limits. Extraocular motility was full with no pain on eye movements. But on fundus evaluation, she had, this was the fundus photograph of the patient. As you can see in the right eye, the optic disc is small with a 0.1 to 0.2 CDR with a healthy neuroretinal rim and healthy vessels, and rest of the retina is normal. In the left eye, you can see that there is blurring of the all the three margins except the temporal margins with mild hyperemia, mild obscuration of the vessel suggestive of a grade 1 edema. So we did a OCT RNFL and then found out that the signal strength was not very good in the left eye, but right eye was normal, but you can definitely see the retinal nerve fiber layer edema in the left eye compared to the right eye, and also the loss of cup disc ratio. So this was the perimetry 30-2 of the patient. Right eye was quite normal and left eye showed mild enlargement of the blind spot. So in view of the suspicion of a headache and in view of patient symptoms and the other optic nerve functions being normal and enlargement of the blind spot and OCT findings, we subjected the patient to neuroimaging. Initially a CT was done and then an MRI and also a CT venogram was done. So in the MRI, you can see that there is a mild tortuosity of the optic nerves with a cuff of fluid around the optic nerves. There is mild, very minimal or no indentation of the globe. And on sagittal section, you can see the empty sella syndrome. The ventricles are normal in size. So these were the findings which were suggestive of IIH, and on venogram, the sinuses were normal. So other investigations like hematology, CRP, LFT, KFT, blood pressure was all normal. So she was referred to the neurology department where she underwent a CSF tap where the opening pressure was around 30 centimeter of water, but the composition of the CSF was normal. So here we were with the diagnosis of this patient with a typical IH, that is unilateral disc edema. So she was advised weight loss management. She was put on tablet acetazolamide 500 milligram TID, and also painkillers. So the discussion is like, we all are aware of typical IIH where there is persistent increase in the intracranial pressure in the absence of any intracranial lesions. So classically, we have a presentation of bilateral disc edema, which we call papilledema, and typically it's seen in women of childbearing age, but can also occur in children and other adults. So this is a diagnostic criteria proposed where we diagnose IIH when we have papilledema, when the neuroimaging is normal and the neurological examination is normal except cranial nerve, sixth cranial nerve abnormalities, and on lumbar puncture, the opening pressure is high with normal CSF composition. There is also an entity called IIH without papilledema, where you have only the radiological features of empty sella, flattening of the globe, distension of the perioptic spaces, and also transverse venous stenosis, but papilledema is starkly absent. And then diagnosis of IH is still considered probable if A to D criteria are met, but the CSF pressure is less than 250 millimeter. So this is just a pictorial depiction of how there is a mismatch between CSF production and then absorption, which is the cause of raised intracranial pressure in IIH. The signs and symptoms would be typically headache, transient visual obscuration, blurring of vision, tinnitus, and diplopia. So, and the management would include general, medical, and surgical. General is weight reduction with salt intake decrease. Medical, acetazolamide, furosemide, and topiramate are the drugs. Surgical, we consider when there is continuation of visual loss like optic nerve sheath fenestration and shunt surgeries. So what I would like to highlight in this case is why unilateral. So a review of literature showed scattered case reports, many small case reports, but not a great large series. And there have been different reasons which have been elucidated. Like one paper said the difference, there is no edema in one eye because of the change in the optic canal diameter. The other report said there is loss of compliance, elasticity, and flexibility of the aging posterior lamina cribrosa, which can give rise to edema in one eye and no edema in the other eye. Also, there could be congenital anomalies of the optic nerve sheath or variations of trabecular meshwork or fibrous adhesions in the subarachnoid space. One case report were recently reported by Dr. Savino said that because of the hypoplastic sinus on one side, there is include collateralization on the other side, which can give rise to unilateral disc edema. There's also a case report which said unilateral high myopia, they did have asymmetric disc edema because they found that the optic nerve was long with kinking noted, which was the cause of edema in one eye and no edema in the other eye. So as we all know, unilateral disc edema is always alarming because it's suggestive of optic nerve.
Harsha, please wind up.
Yes. So my takeaway points are unilateral disc edema is usually due to intraocular or orbital causes like ischemic optic neuropathy, neuritis. Raised ICT can also be a rare cause of unilateral disc edema in less than 4% of individuals. So in such cases, appropriate neuroimaging and CSF analysis will clinch the diagnosis. Pathology of this unilateral edema still remains unclear. These two parameters like optic disc height measurement using a 5-line raster scan can be helpful. And also one paper says that optic nerve sheath diameter with B scan can still be increased in both eyes despite edema in only one eye, which can be used to document IIH in such cases. Thank you.
Thank you, Dr. Harsha. For comments by panelists, Dr. Janil.
Yeah, thank you. Very well presented and very interesting case, Dr. Harsha. So this is a known entity, but it's very rarely reported, and more commonly reported is highly asymmetrical disc edemas, where there is like grade 5 one eye and grade 1 or 2. And this case, I think the RNFL is quite very clear that there is no disc edema in the right eye. But interestingly, when we see the MRI, at least the axial cuts which you have given, there is a remarkable kinking in the eye which does not have a disc edema. And that is exactly what there has been theories that with remarkable kinking, there is no transmission of the rise in the CSF to the retrolaminar area that would not allow it to cause disc edema. So that's correlating in your MRI. What I just noticed that right eye does not have, and the kinking is remarkable. Though the sagittal section will be very good to see how much of that kinking is there, but I could correlate. But however, it's very important to everyone to keep in mind that disc edema unilaterally, where we don't call it papilledema, may also have a diagnosis of IIH. So neuroimaging always to be kept in mind in such patients. Of course, look at the other ocular findings also.
And the choice of neuroimaging should be MRI always. I mean, in this patient, a CT was done, then later an MRI was done.
Yeah, because I think they were not affording, they did a CT scan.
Yeah, but that is what we need to drive home, that even if the patient is not affording, it's waste of money to do CT and then an MRI. It's always MRI only.
MRI with MRB.
Yeah.
The things you need to.
Opacity of the other eye also shows some RNFL thickening. So it could be an asymmetric papilledema, not strictly unilateral in that case.
So due to
I think we go to the next case now.
Yeah, next case by Dr. Susha and Dr. Renu and Dr. Ashwin Sanani sir will be the panelists. Dr. Susha, are you there?
Yeah, I'm just trying to share my screen. I'm unable to share it. Is someone else sharing the screen?
No, nobody's sharing the screen, doctor. You can
Just stop sharing it.
There is no sharing. There is no sharing.
Okay. Can you see my screen now?
Yes.
Yeah, hi. Good afternoon, everyone. Thank you to Moss Scientific Committee for giving me an opportunity in this wonderful session with all the stalwarts. Without further ado, let's just quickly go up with the case. My topic is eyes inward, minds apart, when a common sign hides an uncommon diagnosis. We are going to be talking about acute comitant esotropias, which is often idiopathic or related to benign causes like refractive errors. But it can sometimes be the first manifestation of something more serious. Let us explore two cases with distinct underlying pathologies with the same presenting symptoms. So this is case one, where a 5-year-old boy was brought by his father with complaints of an intermittent inward deviation. It was lasting for a few hours and then it would recover. No neurological symptoms, birth and family history was normal, no developmental delays, history of seizures or any prolonged illnesses. His clinical picture, he was 6'6" in both eyes, did not have a refractive error, head posture was normal, extraocular movements were full free in all cases. Now, on the first visit, he seemed to be orthotropic, didn't even have a flick esotropia or any kind of squint. But on the following visit, he had a 15-degree right esotropia. So I had asked his father to get him during an episode. So his BSP by Worthford dot test for distance and near showed a diplopia to fusion. That is, at times he was seeing 5 dots, at times he was seeing 4. Fatigue-based variability was noticed and stereopsis was present. Accommodation and convergence was unaffected. Everything else seemed normal, including the cranial nerve examination. Now let's jump to case 2, wherein there was a 5-year-old girl who was also brought with a complaint of sudden inward deviation of the right eye. Now in this case, it was fairly constant since the past 7 days. The mother did not notice that it has been intermittent or gets better after some time. She also had no neurological symptoms. Every birth and family history was normal, no developmental delays. Her BCVA was 6/6 in both the eyes, head posture was normal, extraocular movements were full in all cases. Now, the corneal reflex showed a 15-degree esotropia. On cover and cover test, she had a 40 prism diopter esotropia for distance and a 30 prism diopter esotropia for near. BSV by Worthford test for distance and near showed a right eye suppression, stereopsis was absent, and all other cranial nerve examination was normal. Now, we went ahead and asked her for her earlier pictures because the mother said there was no squint ever, before. So these are her pictures, and it actually didn't show any squint. Now we come back to the first case. In this case, the fatigue test was positive, but the eye spec test was inconclusive, basically because there was no ptosis as such. Fatigue test was positive, as in the amount of squint was variable when the child was asked to look up for a minute or two. In order to rule out a neuromyotonia before any other further investigation, a pediatric neurologist opinion was sought. A CT chest was normal, and then in the blood investigations, the acetylcholine receptor antibody assay was weakly positive, and the anti-musk was negative. Now, we did a single fiber EMG and that showed a decremental response of more than 10%. He was diagnosed as a juvenile myasthenia gravis, though rare, and started on oral pyridostigmine and steroids under the pediatric neurologist's care. And his symptoms and signs got better in 4 months with the dose of 1 milligram per kg per day. And it's been 3 years now, he's been asymptomatic. Whereas for the other child, because it was acute and fairly constant, we went ahead and did an MRI brain, which revealed a peg-shaped, elongated tongue-like cerebellar tonsil herniating into the upper cervical canal through the foramen magnum. Now, this elongation was there, which made us think it is an ardent Chiari type 1 malformation, because the rest of the ventricles and all were intact. Now, she had no other symptoms. That was what was notable. Her neurologically, she was absolutely fine. So she was referred to a neurosurgeon who advised nil surgical intervention. What we did was a strabismus surgery after 2 months in her right eye with a medial rectus recession of 4.5 and 6 millimeter lateral rectus recession. So this is her before and after picture. She was Hirschberg's orthotropic on first post-op day and 1 month follow-up. No residual strabismus was there. Her binocular vision improved, stereopsis improved, and rest of the anterior and posterior specimen findings were normal. So, in conclusion, an acute comitant esotropia can be the first sign of an underlying neurological or systemic pathology. And with case 1, it was an intermittent esotropia with no systemic symptoms. But because it was variable, we considered ocular myasthenia. And in case 2, because it was a persistent acute kind of an esotropia, neuroimaging was critical in this case. A full orthoptic and neurological workup is essential in acute onset esotropia. And don't assume that just because it's comitant and non-paralytic, no other testing is required. Early multidisciplinary input ensures better outcomes. So these are my acknowledgements, and thank you for your attention. I hope the talk was both comitant and convergent. Just to start with the discussion, I'll just ask a quick question to the panel and audience if there is time. Is it okay?
You have time, Susha. In fact, you finished 20 seconds before, so very good.
Yes. So just a quick question to anybody in the audience or anybody in the panel who would like to go ahead. If a 6-year-old child presents with a sudden onset left esotropia and comes to a clinic, and we see that the vision is 6/6 and has no systemic symptoms.
Doctor, time's up.
Yeah, so just passing on the question to the panel, like what would you prefer to do in such a case?
So, I mean, hello?
Yes.
So cycloplegic refraction in glasses is a must. Then I'm going to do an MRI brain for sure if I'm going to operate on this patient. If the MRI is coming normal, I would still want to rule out a myasthenia gravis for all these patients. So all these things need to be done.
Yes, ma'am. So what will be your priority? Like cycloplegic refraction and glasses will be your priority, or will you think that because it's acute, we need to do an MRI?
No, I will do an MRI for sure. There's no question about it.
Yes, ma'am. So
everything is needed. We need to do everything.
Was there
I
a
do
doses
one
investigation?
and yes.
Okay, let's
One comment.
get
Sorry.
Dr. Renu
The
Agarkar
panelists
and
have to.
Dr. Ashwin Sainani to ask their questions.
Yeah, no. So I feel that these accommodative, the acute comitant esotropias quite commonly fit into the more benign forms. So you want to rule those out. And as regards going ahead with investigations like you listed, Susha, I think it'll be based on your findings as well as on each patient's history. So if you are getting a cyclic pattern which is really fitting a great cyclic pattern, I would probably not be investigating right away. If it's got accommodative component, and it's fitting into an accommodative type of acute ESO or accommodative spasm, I will not be thinking of MRI. So I think it depends on what you're finding. And these you more commonly will reach a clinical diagnosis. And based on that, you take it on through your list. Your list is absolutely complete. As regards the myasthenia that you picked up without a ptosis, that was a good pick. It is, very uncommon to find ocular myasthenia without it. So, having the single fiber EMG is not easy, is not as reliable unless you've got a great center that does it to have a definitive diagnosis. But that is the clinching, test apart from acetylcholine receptors.
Thank you very much, sir.
Just to add there, Ashwin, that even the single fiber EMG is more specific if you have a ptosis.
Absolutely right.
To have a positive finding with an esotropia is the center is really, really good.
True, true,
Dr.
true.
Renu,
More
you
than
would like
30% is detrimental. That is, it should be more than 30%. So in her case, though the ACTH antibodies were weakly positive, but
Yeah.
what you can have is like a seronegative myasthenia gravis, which would be there. And the ptosis was not there. Of course, she did presented with esotropia, which was there. And we need to give them a medical treatment. The ocular symptoms in this cases comes uh, first, but over a period of 2 years, after 2 years, they have a possibility to getting it converted into a generalized myasthenia. So
Yeah,
you
that's
need to keep them under proper follow-up, and you need to see that the recurrence, and if they are allergic, I mean to say, if they have steroid-related complication, then they need to be shifted on immunosuppressions,
Trupti, we
and
need to move to the
counseling
next,
has to be
please.
done.
Dr. Trupti, we need to move to the next.
Yeah.
Yeah.
Thank you.
You comment on the Arnold-Chiari malformation. I had a similar patient, but she had a downgaze nystagmus
Nystagmus.
with esotropia. So one has to look for that downgaze nystagmus.
So now we'll start with the case 4.
Dr. Trupti, just a minute. Dr. Renu wanted to say a comment on this.
Yes, quickly, please.
No, just I think most of the points have already been covered. Great presentation. Both the cases were presented very well. Last line is important. Only combatants does not mean benign. So yes, a complete workup and case-to-case basis, we need to go ahead with the investigations and the treatment accordingly. I think we can just go ahead. So
Thank you.
Susha, good presentation.
Thank you. Yes, Dr. Arohi, you can. So let's next presentation is by Dr. Arohi Khade. She'll be presenting diagnostic dilemma, and the expert panelists are Dr. Anushri Ane and Dr. Snehal Thakre. Kindly go ahead with the presentation and stick to time, please.
Yes. Good afternoon, everyone. I'm Dr. Arohi. Today I'll be presenting two interesting pediatric cases under the guidance of Dr. Abhilasha Parke. The goal is to highlight the importance of detailed evaluation and neuroimaging. In our first case, low vision in left eye was recently noticed by a parent of 5-year-old child. There was history of fever at age 2, but no other systemic complaints. Visual acuity was 6/9 in right eye and only counting fingers close to face in left eye. The child presented to us with outside records. Refraction showed right eye vision 6/9 improving to 6/6 with minus 0.5 astigmatism and left eye counting fingers close to face. Left eye RAPD and 18 prism diopter exotropia. Outside diagnosis was dense amblyopia, and vigorous 4 hours patching was advised in view of left exotropia of 18 prism diopter. On our detailed re-evaluation, the child had good control of intermittent divergence squint of 18 prism diopter, and RAPD in the left eye was confirmed. Dilated fundus evaluation was normal. These are the photos of left and right eye. Then neuroimaging was advised. MRI brain and orbit plane plus contrast showed a small soft tissue in left orbital apex of 1.4 by 0.8 centimeters, suggestive of cholesterol granuloma, and altered signal density in left pitreous apex, suggestive of cholesterol granuloma or a proteinaceous fluid within the pneumatized pitreous apex. We also ordered visualized visual evoke potential test, which confirmed the optic nerve dysfunction. Considering MRI reports recent vision loss, RAPD in same eye, we advise pediatric neurologist opinion. IV methylprednisolone was given for 3 days at neurologist setup, followed by oral steroids for 15 days. The child's vision improved to 6/6 in both eyes. Then we had advised NMO and MOG antibody test, which was negative. Then we advised genetic workup for parent and child. In second case, our second case, 3-year-old child who had a headache and increased irritability as per history given by parent, but duration and onset was not clear. The child was already undergoing patching for left eye amblyopia due to exotropia. On our detailed re-evaluation, visual acuity on Cardiff cards was 618 in right eye and left eye 6/120. Left eye RAPD was present along with the pendulum nystagmus of fine amplitude and moderate frequency. Orthoptic assessment showed intermittent exotropia of 20% diopter with good control. Both optic discs appeared pale. So this is the fundus photo. Here we can see discs are pale. Then OCT RNFL could not be done due to poor cooperation of child. Hence, an urgent MRI was ordered. So, which showed a large cellular supracellular mass with solid and cystic component measuring 86/70/63 mm, which was suggestive of craniopharyngioma. So we can see a tumor extension is noted within third ventricle and middle cranial fossa on the left side. So neurological consultation was sought, and within a week, shunt procedure was performed on a child. So to summarize, in both cases, the initial diagnosis was amblyopia, but can sometimes mask more serious underlying pathology. The presence of red flag led to timely investigation and discovery of serious underlying pathology. In first case, it was cholesterol granuloma involving orbital apex, possible inflammatory optic neuritis or perineuritis, and craniopharyngioma in second case. So here I want to emphasize key red flags that should alert us to look beyond the amblyopia. So relative afferent pupillary defect, disproportionate vision loss, optic disc pallor, nystagmus, lack of improvement with appropriate amblyopia therapy, and neurological symptoms like headache, irritability, and behavioral changes, which must not be missed. Thank you.
So very nice presentation, Dr. Aroi. Both the cases were very interesting. And both these cases, they just emphasize that a thorough ocular examination is needed. You just can't label somebody as amblyopia. Like both your cases, if the examination was done correctly, the relative afferent pupillary defect was the clinching diagnosis that there is something wrong other than amblyopia. Plus, when there is a disproportionate visual loss, you just need to have a high degree of suspicion that it is something else rather than amblyopia. So, yeah, these are to my sense.
Dr. Snehal, would you like to comment on the case?
Yes, congratulations for approaching the patient in the correct way. Because with the RAPD and the severe visual loss, it was definitely something more than amblyopia. So we should keep our eyes open and mind open to examine the cases completely. And I don't think I can say much more because the case has been approached very well. Good. Congratulations.
I think for amblyopia, to diagnose amblyopia, there has to be an amblyopiogenic factor, at least a refractive error or squint or 18 prism diopters of exotropia will not cause such a dense amblyopia. So one has to search for an amblyopiogenic factor before diagnosing it as amblyopia. RAPD, of course, will not be there.
I would just like to add few things, like the second case had a craniopharyngioma. Whenever you have a craniopharyngioma or any pituitary anomalies, so definitely give weightage to looking at the clinical features or the patients, like is there a acromegalic features or is there a obesity, or they would be having a big acromegalic features is the very most commonest thing what you might be having, and the weight gain and the height, those things should be paid attention for the systemic.
So due to time concerns, I would really have to move forward with our next speaker. I would request Dr. Meghna to upload her presentation, and expert panelists would be Dr. Madhavi Bijlani and Dr. Supti Kadam.
Good afternoon, ma'am. Am I audible?
Yes.
Can you see my slides, ma'am? Good afternoon, one and all. Thank you, Moss, for giving me this opportunity. I am Dr. Meghna, recently passed out JR from AIIMS Nagpur. Wanted to present nystagmus enigma, decoding the underlying causes. My patient is a 37-year-old male who came to our department with complaints of binocular double vision since 4 to 5 days, which is aggravated on horizontal gaze. There is no history of any horizontal gaze. There is no history of any diminution of vision, no history of headache, trauma, seizures, no history of any systemic illness or any GI surgery done. He is a chronic alcoholic with daily consumption of 1.5 liters per day since 3 years. On ophthalmic evaluation, we can see end gaze nystagmus, horizontal end gaze nystagmus with left abduction limitation in the patient, which can be seen in 9 gaze also. His vision, color vision, diplopia charting along with anterior and fundus evaluation is within normal limit. On gait evaluation, the patient has unsteady gait with tendency to fall. This led to our clinical diagnosis of Wernicke's encephalopathy. To rule out other systemic causes, we have done investigations in this patient in which serum electrolytes are normal, but there is complete blood count deranged, like deranged hemoglobin along with microcystic hypochromic anemia due to reduced vitamin B12 levels, and whole blood thymine level was also reduced, but his MRI brain and orbit suggested to be normal. So he was admitted and treated along with neurologist support. He was administered IV thymine 500 milligrams twice a day for 3 days, followed 3 days later by 250 milligrams twice a day. And also, as the patient has methyl B12 deficiency, methylcobalamin was given and oral thymine was administered later on. 1 week post-treatment, the patient has improvement in left gaze, which we can see in this image, and he also has improvement in his mild improvement in gait ataxia. So Wernicke's encephalopathy is characterized by a triad of end-gaze nystagmus or ophthalmoplegia with gait ataxia along with confusion state. This typical triad occurs only in 10% of patients. Confusion is the most common early manifestation to occur in patients. This occurs due to thiamine deficiency, either due to chronic alcoholism or metabolic causes. The pathogenesis, coming to pathogenesis, it is due to alcohol consumption leading to reduced thymine transport and absorption, which is an important cofactor for key enzymes which are required in ATP production. So there is decreased ATP production leading to increased oxidative stress and glutamate toxicity, damaging the neurons. These neurons are damaged by cytotoxic edema due to breakdown of blood-brain barrier, and there is neuronal necrosis which can later on lead to irreversible damage. So before 14 days we have to treat the patients. In histopathological report we can see the gliosis of the neurons. How long it will take for Wernicke's encephalopathy to occur? Initially the patient present as thymine deficiency, which can be days to months. Prolonged history will make the patient to have symptoms, and if we not treat then also, then the patient develops into Korsakoff psychosis, which can lead to permanent brain injury. This mostly Wernicke's encephalopathy is a clinical diagnosis, which is shown by these 4 criteria. This is only sensitive in 85% cases, and this criteria is not validated in non-alcoholics. So what is the unique feature in my case is, this case presented with features mimicking sixth nerve palsy with end gaze nystagmus, and when we did diplopia charting, it is normal. Careful history and ataxia evaluation has led to our diagnosis in this patient. According to extensive literature search by European Federation of Neurological Societies, it is a systematic analysis. in which the most common cause is due to alcohol intake, but in non-alcoholic patient it occurs due to these causes. And in alcoholics, the most common clinical feature being presentation by all like eye symptoms initially, and in non-alcoholics it is due to dietary deficiencies. MRI findings are also less like showed less positivity in alcoholics when compared to non-alcoholic causes. So early diagnosis, early recognition and timely management is very important, along with prompt time in replacement. This case can be missed due to absence of alcohol history, can be misleading. And when the patient present in unconsciousness, sometimes we give glucose before giving thiamine. That may lead to further worsening of the symptoms. My take-home message is Wernicke encephalopathy is more than confusion. Ophthalmic signs are first to respond, and they are initial signs to present also. So clinical diagnosis is more important than imaging. Early thiamine will save neuron. Don't be misled by normal tests and neuroimaging. Thank you.
Thanks, Meghna. It was a wonderful presentation. Madhvi, would you like to add?
Yeah, hello everyone. Dr. Meghna very well summarized. I really like the way you explained the pathophysiology as well, which we tend to forget nowadays. And the take-home message says it all. Like we've all been re-emphasizing throughout the whole talk, don't just look at the patient's eye, look at the patient as a whole. Many a times when they walk into the clinic, we might just see the ataxia happening. I've seen a lot of Parkinson's cases that way when they just walk in and you know something is wrong. Another thing I would like to add is in such cases, maybe it would be worthwhile to talk to the relatives as well, because if there are symptoms like confusion, mental disturbances, more than the patient, the caretaker may be able to tell you better.
Yes.
And another thing from my end would be, it is an easily treatable disease. So rather than waiting for neuroimaging for a long time, I think it would be worthwhile if you're really sure to start the thiamine. There isn't going to be any loss because of that, but it may just benefit the patient by reversing all that is happening. But very well put together. Nice case, Dr. Meghna.
Yeah, Meghna, one thing I would like to ask, like, what would be the non-alcoholic causes, especially in female and in other adults?
Yes, ma'am. There are reported cases due to hyperemesis gravidarum, which occurs due to pregnancy, due to impaired electrolytes also it causes, ma'am. And in patients who has undergone bariatric surgeries, like Billroth's 2 surgery and all, those people also had. And in according to European Federation, they have shown cases in cancer patients also, ma'am. The patients who are having GI malignancies to be having more due to decreased absorption of thiamine.
I had one patient with just end gaze nystagmus, and 3 months prior, she had committed a suicide attempt by drinking a acid. And so there were strictures in her esophagus and everything. And because of that, she developed a Wernicke's encephalopathy. And she had some confusion and a very little nystagmus in the end gaze. But then the thiamine treatment corrected it.
So I would like to ask panelists, now that we have sufficient time for discussion, we can take the questions, and sorry for asking everybody to run forward. So I have a question regarding this. So a lot of time we miss, we being ophthalmologists, a lot of us are sitting in individual eye setup or eye hospital. We miss parental nutritional history, the way ma'am said, because of strictures, she was not having the food by mom. So I think that history is very important. The other thing is, amongst the triad, we all know that classical book picture doesn't come in your clinic, right? Not every time. It is always a gray zone we have to battle. So I would like to ask Dr. Shubhangi ma'am and Dr. Hemalini ma'am that what are the key features that not every time the triad would be there? So what should we, is it just a high index of suspicion or a history?
Regarding, this patient nowadays, even the MRI gives you quite a good diagnosis. So any acquired nystagmus, you tend to image. So in my patient, the imaging itself showed that it was Wernicke's encephalopathy. So those tools also helpful, but of course doesn't means proper history also should be taken always, which helps in making a clinical diagnosis.
Yeah.
I would agree with Dr. Bhave, the same opinion.
Should we take one more question if anybody wants to comment anything? Yeah. So I would like to ask Dr. Harsha. Dr. Harsha, are you there? That whatever literature search you must have done, whether it unilateral disc edema, whether it correlates with MRV finding, the way we get stenosis particularly on the hypoplastic sinuses or stenosinuses. So whether it correlates with the side of the disc edema. I think Dr. Janel was also saying that on MRI we were seeing kinking, and I think Dr. Harsh.
Not there.
Yeah, that's okay.
Dr. Janil can come. Janil can come. Is he there at all?
I don't see Dr. Janil right now.
It's the
Yeah, please
clinical
unmute yourself, Dr.
diagnosis
Janil.
of papilledema, maybe especially when it's a very early papilledema, it may be difficult to diagnose clinically. But flattening of the posterior sclera and increase of the perioptic spaces can help us in diagnosing papilledema.
The radiological sign itself gives you a clue. And the CSF, what she did, in her case, the CSF was 30 centimeter of water, which was there. So over a period of time, you need to check out for their symptoms, how it is getting resolved. The Dimox, which is being continued, it should continue for a longer period of time. And you need to serially monitor the patient with the serial OCTs in such cases. Though this was not having a grade 5 edema, but symptomatically you need to keep, and then you have to give the TDS to QID doses, and you need to take care of the hypokalemia which is being there in such cases. So a long-term follow-up is required. With this, they do need a psychiatric counseling. So you should be having them psychological counseling is also important in IIH.
We should not ignore the eye which has no edema also, because sometimes they would also develop optic neuropathy over the period of time and have progressive field loss because the pressure is laterolaminar. So it may look very benign, but it can go a very haywire course. So that is also important in such patients actually to keep
One of my patients in COVID time was just sitting at home for 2 years, eating, just visualizing the screen too much. And he developed a benign intracranial hypertension, so much so that it was such a choked disc that once it resolved, it left behind a lot of damage. The vision was reduced. There was optic atrophy. So these cases, though if the pressure is too much, they resolve, but they leave behind some deficit.
So that brings us to the concluding this session. I would request Dr. Piyush to say a few words.
Thank you, Abhilasha, and thank you, Dr. Trupti, for conducting a lovely session. Surprisingly, we managed to end on time. Many congratulations to all the speakers, especially all the younger speakers. A big thank you to the chair and the moderators. And with this, we move on to the next session. I hope Dr. Uday Tekchandani is there. Yes. Wonderful. So we have the third session coming up, which is the final of the videos that were submitted earlier. And the session is going to be moderated by Dr. Uday. Judges in the session.
Good afternoon, everyone. Thank you.
Going to be Dr. Anagha Hiru, Dr. Atul Kadane, and Dr. Siddharth Kambe. I hope all of them are there. Dr. Atul, I know, is there. So over to you, Uday.
Yes. Hi, everyone. Good afternoon. Thank you so much to the MOS Scientific Committee for giving me the opportunity to moderate this session. So our session is the video final session. Our judges will be Dr. Anaga Herur ma'am, who is the Medical Director of Anil Eye Hospital in Dombivli. Dr. Atul Kadhane sir, who is the Medical Director of Yash Netralaya in Amravati, and Dr. Siddharth Kamble sir from Ganpati Netralaya, Jalna. I'll be the moderator for today. My name is Uday Tekchandani. I'm a VR surgeon based in Bandra, Mumbai. So our first presentation will be by Dr. Milind Changole. His topic being a floating globe, an opt case for floor fracture with implant compressing the optic nerve, should correct or not correct. Over to you, Dr. Milind.
The judges may please note that the timer for the sessions is going to be up on the top, on the right-hand corner. And we have 6 minutes for the video and then 2 minutes for discussion.
Dr. Piyush,
Yes,
regarding the marking, what will be the distribution?
it has already been sent. If you have,
yes.
Sumit, can you send it? I will just send it back.
Yeah, sure.
I don't see Dr. Milind. Dr. Uday, if you can move on to the second one. If the first
If Dr. Milind has some internet issues, maybe we can move to the second session, which is Dr. Shivani Patnaik of talking about oops moments in cataract surgery, handling intraoperative complications. Dr. Shivani, are you connected?
Dr. Shivani, please unmute yourself.
Hello, good afternoon. Dr. Milind here.
Okay, all right. Then we can have Dr. Milind first.
Okay, sir. I'm starting my screen share. Someone has to allow me.
There is no restriction, Dr. Milind. You can just start.
Okay,
At the
sir.
bottom of the screen, you'll have a button which says share. So you have to press.
Yeah. Not managed to share it.
Are you on a Mac, Doctor?
Dr. Milind, are you able to share? Or
Dr. Milind, are you on a Mac?
No, I'm on window and
Do
I'm
you
sharing
see,
my
yeah.
screen.
Do you see the green button on the bottom, 6 o'clock?
Yeah.
Just click on it.
My screen is visible?
No, doctor.
No, it's not visible.
Just click.
Okay, you can ask someone to start. Okay. We'll try within 5 minutes.
So, Dr. Shivani, can you share your screen, please?
Yes,
Regarding
I can.
performance of cataract surgery, we'll start with you and we'll come back to Dr. Milind.
Oh, lovely. Thank you. Good afternoon, everyone.
Sunil ji, any issue here?
Are you able to see my screen?
No,
Not
doctor.
yet, Shivani.
No, we're unable to. Admin, can you help her out, please?
You just click on the green button which says share. The pop-up will come. Just select the entire screen and the blue button. Again, share. Green button, blue button. Simple.
I am clicking the. Okay.
Are you on a Mac? Yeah.
Yes. Is this better?
Yeah. Just open your PPT, please.
Okay. This one. Oops moments in cat. So, am I audible to everybody?
Yes, you're audible.
So this video, I just want to give a brief 10-second talk about it. That it is a video that we made regarding all the complications that we may undergo in everyday times in cataract surgery, which may seem very trivial. But the reason we decided to make a video on this is because sometimes we ourselves overlook it. So we thought that if every step is pronounced in a way that we are looking at it in a different manner, then we may be able to avoid mishaps. So I hope you enjoy this video, because we had a lot of fun making it and we learned a lot while making it. So I'm just starting the video now. Cataract surgery, handling intraoperative surprises. These surprises can occur at every step of the surgery. Incisions, CCC, hydro, phaco, IA and IOL placement.
When there's something strange and the keratome slips, the capsule screams and the MVI hits. Who are you gonna call? Ooh, busters!
At times the keratome can slip.
and nick the anterior capsule. Solution to this is to start the rhexis from the same site and engulf the entire nick in the CCC to prevent a rhexis runoff. An accidental puncture of the anterior capsule can happen while injecting the viscoelastic in the AC. Reform the chamber and start the CCC from the same site of the puncture, go all around and engulf the puncture site. An accidental puncture of the anterior capsule happens with the keratome. Form the chamber with the viscoelastic and start your CCC from the site of the puncture. It's important to go around and make sure the site of the puncture is completely covered. And this will ensure the CCC does not give way and the IOL centers in the back. While performing rhexis with Utrata forceps, sometimes viscoelastic leaks. One must reform the anterior chamber, but reattempting a rhexis will cause a leak, and this can lead to a rhexis runaway. To prevent this, reform the anterior chamber and use a microrhexis forceps through the side port. Go all around grasping the CCC to complete it. When a small CCC is created, there is always the fear of a rhexis blowout during hydro procedures. In such cases, to perform in-the-bag phacoemulsification, reduce the bottle height, lower all parameters, observe the flap motility sign in phacoemulsification and in IA. Do not allow the chamber to collapse. Carefully inject the IOL, nudge it into the bag without dialing it to complete the case successfully.
Drop that one. Fix up that sleep. Don't go hunting. The water's deep. Taking your dive. It's time to win. Who you gonna call? Oops, Busters.
In a soft cataract, there is a good chance there will be a crater formation. This leads to thinning and you can see a beautiful glow coming through. If the pupil is smaller than the size of the rhexis and there is a crater formation, we can use either hooks, viscodilation, or continue struggling. The ideal choice would be to use hooks to get better exposure and perform safe phacoemulsification to prevent any complication. In another case during phacoemulsification, we face intra-op meiosis. Even viscodilation does not help, and the meiosis continues to worsen. In such scenarios, a ring can really help. But it is very important to make sure that the loop of the ring is not entrapping the CCC. We can release the trapped margin of the CCC from the loop before IOL implantation into the bag. The lens can then safely be placed into the bag. The ring which was placed can be easily removed. During bimanual IA, misdirected fluid causes iris prolapse. So we reposit it, change our hands, and direct the irrigation to correct the flow and prevent iris prolapse. This completes the IA successfully. In another case, while performing IA with a coaxial probe, one may accidentally hold the posterior capsule because the irrigation port is in the incision itself. In such scenarios, it may be wise to shift to a bimanual technique after IOL implantation to remove the subincisional cortex. In yet another case, while removing the viscoelastic from behind the IOL, the haptic can pop out from the bag into the anterior chamber. It can easily be put back into the bag under irrigation using Sinskey hook.
It flippity flips and sometimes slips. Oops, oh no! The eyes in splits. Who you gonna call? Oops, Busters!
During IOL implantation, it may flip. Place viscoelastic to protect the posterior capsule and the cornea. One can flip this IOL and orient the haptics correctly. Then the superior haptic can be dialed into the bag. While inserting single-piece hydrophobic IOL, one would have seen stuck haptics, but this is something different. The haptic is actually held on by the body of the IOL itself. Nothing to worry. The haptic actually just releases itself, and the IOL orients itself in the bag. In some cases, the haptic is trapped between the plunger and the cartridge itself. Don't be impatient. Cut the cartridge away from the haptic. This itself will release the haptic. Once the haptic is released, very simple, just dial it into the back.
Scream, shout, fear no more. Chill up, that's all. Who's got your back? Who's Busters? So hold your wits and grace, cause in the end you'll find a place. Who's gonna call? Who's Busters? Who you gonna call? Who's Busters?
Excellent video, Dr. Shivani. I thoroughly enjoyed the music personally.
Thank you so much. Thank you.
I don't know if it was just me or the others also faced this issue that the video kept buffering. So probably the presenter could switch off their webcam video to ensure that the maximum bandwidth of the Wi-Fi is going in while sharing the screen. Like maybe that might make a difference, but that just happened with me. I don't know if that happened with the others. So over to the judges, if they have any things they would like to ask, clarify. Over to the judges.
Yeah, very nice video, Dr. Shivani.
Thank you, ma'am. Thank you so much.
Nicely made, good concept. Yeah.
Thank you.
Nice.
So this is something that my mentor, Dr. Kumar, tells us in every OT, and he himself follows it. That if there's one step that can save the case, it's each and every step that has to be perfect. So that's how we got the idea.
Yeah, nice video, Shivani.
Thank
One
you,
thing
sir.
I just want to ask you, in the scenario when just like an Argentine flag sign or when you have a CCC broke,
Yes.
it's not in continuation. So there is one sign. How could you assure that it has not gone through the PC and it is still limited by the zonals? What is that? How do you by looking at what you can guess that the extension is not gone to the PC?
So this is the flap motility sign. If the flaps of the torn rexis are still mobile, that means that it has not run through behind. If they are taut and rigid, that means that yes, there is an extension beyond the equator. So
Good.
that's how we can save ourselves if we can find it.
Maybe for the beginners or few newcomers, this will be a good information.
Definitely, sir, for all of us.
Yeah, that's it. Nice video.
Thank you. Thank you so much.
Any last questions from Dr. Siddharth, sir?
Yeah, it was excellent.
Thank
The
you.
only thing is that after having Argentinian flap, if capsule has get extended, if you have done careful phaco also, you can extend the till posterior capsule while putting your IOL also. So you have to be very careful while putting the IOL. Your haptic, you should not push that tear further to extend it till the posterior capsule. So you should be more careful. You have done a lot of efforts in doing phaco and you have extended till PC while putting IOL. It's not a good situation.
Definitely.
Yeah. Anyway, it was
Excellent
very
tips
excellent
by-
tips for anti-Semite surgeons.
Excellent tips from Dr. Shivani showing all complications of cataract surgery except the one where we come in. But thank you very much. So I think Dr. Milind was able to share his screen. So
Just
Dr.
to
Milind,
add, Shivani ma'am has won the best
Dr.
AIS
Milind, can you
video
first
award for
open your
Jesse
PPT
Sashi award for
video and then
facility.
share, please?
Thank you,
Yeah,
sir.
yeah.
Thank you, sir, for giving
I
the
had shared
opportunity.
my.
Milind, if you're not able to share your screen, move on to the next one.
Dr. Milind, can you
Hello?
first open your video and then share, please? Open your video, pause, and then please share.
Okay.
I felt I saw his screen somewhere, but
Yep. Just reshare, please. Dr. Milind, you need to share, please.
Yeah. Just a minute.
In the meanwhile, I hope everybody
meanwhile,
else,
I think we can move
Shrutika,
ahead with
Neeraj, and Amit, have
the
the videos on the screen, so we don't waste any time.
Yeah, you can go ahead.
Yes. So, Dr. Shrutika, if you're ready, maybe the admin in the meantime can take access of Dr. Milind's screen and help him out for the next case. But Dr. Shrutika, if you're ready, we'd like to see your
We've
re-desec
got Milind.
challenges.
We've got Milind. We've got Milind.
Oh, we got Milind? Great, great. Great. Carry on, sir. Carry on.
Okay, can I start?
Please do.
Yes, please.
Yeah. So
The timer, please.
thank you,
The
everybody.
timer needs to be on.
So it's an operated case of blowout fracture, 1 month post-op, complaining of diplopia in all case. The CT was advised. You can make out the implant is there compressing the optic nerve. It is fixed to the orbital rim, and look, the implant is going from inferior to the almost mid of the orbit, and the fracture are untouched. So patient was a persistent diplopia with RAPD. So the plan was to remove the implant and take care of its lower lid retraction. So inferior rectus was hook and a bridal suture was passed, so that we see the FDT. You can manage to see that FDT is tight. Lower lid is also stuck to the bony rim. So subciliary incision was planned to release this skin also. It's a post-op case, so we expect some amount of bleeding, which will be more as compared to the normal cases. So blunt dissection was carried out, hemostasis was achieved, and we reached the rim. Once we reached the rim, periosteum was and the reactive tissue was dissected out, and you can make out there are screws by which the plate is fixed to the orbit, and then gentle dissection was done out, releasing each hole from the orbital tissue. The plate was in orbit. The inferior rectus was below the plate, going into the fracture site. So the blunt dissection was done using suction cannula. Inferior oblique muscle, which is trapped in between the implant and the bony orbit, was released. This dissection is carried out up to its posterior edge, so that we can manage to free the optic nerve and whatever the orbital tissue through which it has migrated up. The point we reach the posterior edge of the implant, we decide to take out the screw. This was the posterior edge of the implant. It was a large implant covering entire floor, and it was fixed to the orbit. It was not mobile itself. Now the screws were unscrewed, and implant was gently retracted and taken out. Throughout this procedure, globe was protected using a sponge and lead spatula. You can manage to see the inferior oblique muscle. It was free from the implant, and it was a large implant. It was placed superior to the periosteum. Now the periosteum is open up, and you can manage to see the FDT is now free now. The orbital floor fracture, the content was reposited and silicone implant was put. Later on, the wound was closed and weak tarsorrhaphy was done to take care of lower lid retraction. Even the lower skin is also released from the bone. Let's see in post-op. We were very afraid, but luckily patient get full recovery of its all movements, and there was no diplopia. After 3 months of post-op, even the lower lid retraction and scar was gone. Thank you for the patient listening, and thank you for the opportunity. Thank you, sir.
Excellent surgery, sir. I think it was remarkable. The outcome is there for everyone to see. And over to the judges. Another ma'am.
Dr. Milit, whether this implant was compressing the optic nerve, you don't know?
Yes, sir. It
So
was
what was the vision?
placed compared to the pedestal. Vision was 6/60. There was mild papilledema also present.
Okay. So primarily this implant was compressing the optic nerve, or it has been later displaced from the original place?
So it was not surgery done by me. It was done by another surgeon, maxillofacial surgeon. He has referred it to manage the hypotropia and moment
Okay.
restriction. Yeah.
Okay, and it was compressing the optic nerve, you told. Then was there any threat to the vision of the patient?
Yes, sir. Vision was 6/60, and there is a disc edema also there, along with mild amount of choroidal folds.
Okay. So after
Nice.
removing the implant, vision had got recovered. Okay.
Yes, sir. That was the main concern, and luckily, patient get full recovery of movements. Even the lower lid retraction is also disappears because we release the skin from the orbital ring, and the tarsorrhaphy. Tarsorrhaphy help a lot.
Okay, great.
Thank you.
Milind, so I
Sir.
feel that
Good afternoon, sir.
take home message will be that this sort of cases should be dealt with the oculoplastic surgeon rather than a maxillofacial surgeon.
Sir, I don't say oculoplastic, ophthalmic surgeon. Yeah,
Oculoplastic.
this is our entity. We should manage it. Otherwise, this type of cases you have to manage, and it takes a lot of adrenaline rush throughout.
Definitely, it's very nice surgery
Yeah.
done by you. Definitely.
Thank you, sir.
Well managed. Yeah, great.
Thank you so much, Dr. Milind. I
Yes.
think
Thank you, sir.
we'll move over to the third presentation by Dr. Shrutika about her challenges in redisec. Dr. Shrutika, can you please share your screen? Dr. Shrutika, are you connected? Can you unmute yourself, please?
Do we have Dr. Krishna Bhojwani in the session?
Bhojani sir, can you please start
Yeah.
your video for a minute, if possible?
If you can switch on your video, sir.
Yeah, sure.
Just for everybody's knowledge, and I would like to acknowledge, along with Sumit, Krishna Bhojwani, who is our MMC observer for this particular conference, the midterm conference, which we've been awarded 4 MMC points. So thank you very much, sir, for
Thank you. Thank you so much.
for this
It's my pleasure.
So with this, can we move on to the next video, please, Uday?
Shrutika is unable to connect. So, Dr. Neeraj, if you are ready with your enigmas of astigmatism and cataract surgery, can you unmute yourself, please, and share?
I will share my video. I just want to know if I need to do any changes to make the audio functioning.
Just when you share, after you shared, there is a floating bar on the top.
Yeah.
You have more option or 3 dots.
Which option? Yeah, more option of 3 dots.
Just click on it. You will have share sound or share computer sound option. Just ensure it is ticked.
It should be on mono. It should be on stereo.
Anything works.
Anything works. All right. Fine. Done. Okay. So before I start my video, thank you to everybody for giving me this opportunity. Just a brief 10-second introduction about my video, since it's midterm Young Turks. So a lot of opportunity is being given to youngsters like us. So this video is basically meant for them. And it's called Deciphering the Enigma of Astigmatism in Cataract Surgery. We all know that what astigmatism can do if not treated well. So this video is based on that. I'll start my video now. Thank you.
The authors have no financial interest in this presentation.
Dr. Neeraj, your video is not visible, at least to me. I don't know about the others.
Volume is not audible?
I cannot see the video.
Okay, I'll reshare again. 1 second. How about now?
Doctor, can you please open your PPT, pause it, then share? The PPT will not open once you've shared.
Okay, I'll do that. 1 second.
Just keep your PPT on pause and then presentation on pause and then share.
Got it. Just 1 second. Oh yes, okay. Now it's visible, right?
Yes, the admin will have to reset the timer because there's been a technical glitch. So just look at that, please.
Okay, I'll start the video. Audio was audible.
Audio was great. Carry on, please. Yes.
The authors have no financial interest in this presentation. As days turn into nights, Dr. Holmes bides his time at 221 Baker Street this winter with a sense of utter boredom. He walks up his stairs every evening to his study, waiting for a case so elementary yet so mysterious. Wait, could this be it? Dr. Holmes received an email. A mystery for phacorefractive surgeon is treatment of pre-existing astigmatism, which accounts for almost 87% of patients. Astigmatism, if left untreated, can lead to one of the most dreaded complications, that is an unhappy patient. Cataract surgeons all over the world have multiple questions on how to treat patients with pre-existing astigmatism. Intrigued after reading the email, Dr. Holmes then entered his mind palace. He started thinking of a stepladder approach, which is normally used by all cataract surgeons to manage astigmatism. The first question which was asked is how important is topography in planning toric IOL? To answer this question, let's take a case example of a 60-year-old male with 1.4 diopter cylinder. The toric IOL was planned in this patient by using the online calculator. IOL was implanted at the plane achieved by the calculator. However, it came as a shock when post-operative cylinder was 3 diopters in spite of the IOL being aligned correctly. After checking if all the boxes were correctly ticked, we found that the answer lied in the curvature map. The patient had an irregular astigmatism of 3.2 diopters pre-operatively. Thus, an accurate reading of topography with knowledge of Bellin-Ambrosio display map and the EKR map helps us in planning precise toric IOL implantation. But is topography the absolute answer to all our questions? Here is a case of a 42-year-old female with a PSC cataract and a -2 diopter astigmatism. The topography showed with the rule astigmatism and no irregularity, but on seeing the aberrometry map, it showed higher HOA values. Post-op, the toric IOL was well centered. However, the patient was still unhappy. Residual cylindrical astigmatism of 1.2 diopters was seen post-operatively. On seeing the biomechanics of this patient, the deformation amplitude was at a higher site, that is 1.45, showing weaker biomechanical strength of the cornea. Looking at this example, we can thus infer that biomechanics also plays an important role and should be included in the pre-op workup of toric IOL planning. The next question which was asked is about the importance of posterior corneal astigmatism. In literature, it is reviewed that posterior corneal astigmatism plays a very important role in toric IOL. Till recently, the online calculators assumed a constant ratio. But with the advent of Baylor's nomogram, which took into account the posterior corneal astigmatism and final effective lens position, posterior corneal astigmatism is now included in many of the online calculators for toric IOL planning. If posterior corneal astigmatism is ignored, it can lead to overcorrection in with the rule astigmatism and undercorrection in against the rule astigmatism. A dilemma which we can face is, what if the patient does not want or cannot afford a toric IOL? Thus, looking at this case example of a 58-year-old female with cataract and a cylinder of 1.36 diopter at 177-degree axis, a penetrating OCCI was planned for this patient. Post-operatively, the cylinder on A scan was 0.68 diopter at 108 degrees with a vision of 6 by 6. Thus, a well-performed OCCI reduces astigmatism by 0.7 diopter and can lead to better results. We have a number of corneal incision-based options like astigmatic keratotomy, femto-assisted astigmatic keratotomy, limbal relaxing incisions. We can use number of nomograms which are available online freely and plan the incisions accordingly to manage astigmatism. Thus, Dr. Holmes rightfully solved all the queries of ophthalmologists all over the world. Hence, mystery solved. He has finally deciphered the enigma of astigmatism preoperatively in cataract surgery.
Great video, Dr. Sherlock Israni. I think you should be getting to Hawkins for Stranger Things season 5 before it comes out in December. Looking at your background music. Great video. We'll start with Dr. Anagha, ma'am.
Yeah, great video. I think one of the other mysteries also here would be to look at a pristine ocular surface. Many times there could be dry eye, which can lead to variability in the keratometric readings, and that also can lead to, residual astigmatism or an induced astigmatism post-operatively. So even when we take the readings, that is very important. And then you also need to correlate between various instruments and then see whether there is an alignment between the correlation between the instruments or not. So actually there are so many factors. You have put it very well. Definitely, I know there is a limitation to how much we can do, but you have done it very well shown. In one of the examples, you showed that the higher order aberrations was high, but I think it was around 0.3.
It was, yeah, it was more
Do
than
you
that.
think 0.3 is high?
So HOAs depend. So, ma'am, it was not 0.3. I think it was more than 0.3 because I'll just.
If you go back and see, you had highlighted it. If I'm not wrong, maybe you can just check it. But what I saw was
So it was
0.3.
The RMS LOA was 2.26 and the HOA was 0.359. Yes, correct.
So 0.3 is not very high.
It's borderline. Yes, it's not very high.
I mean, 0.3 is usually. Anyways, but well shown. Well shown. Yeah.
Thank you.
At least she brought on that concept of one should look for an HOA also while planning for an toric. Maybe that's
Yes, that is important.
Yeah. Another factor is that you had said for OCCI, it also depends whether the astigmatism preoperatively is with the rule or against the rule.
Yes.
See, OCCI, even for against the rule astigmatism of 0.75, most of the time the OCCI will not be sufficient, because if you go on a calculator and put it, you'll find that the Barrett will show you a cylindrical power of something around 1.5 also. But if it is with the rule, it definitely up to the -1 diopter of astigmatism, it works. So that I just want to highlight that point. The concept is very nice. I like the video, the way it is presented. So it makes more interesting to the listeners. Thank you.
Thank you so much, sir.
Yeah, and one more thing is all these LRIs and all, they are probably after a few years, it might come back. Plus, you can have foreign body sensation. So, and they have a limitation up to how much they can correct.
Correct.
So, each of these solutions have their own advantages and disadvantages. We cannot really equate them. So we need to see
all
what we do
subjective to the
best for the
patient and the
patient.
data of the patient. Also, one more important point was the marking, which I could not because it's a 6-minute video, uh, which the patient has to actually put the forehead at the slit lamp. Many a times when we are marking the slit lamp mark is not aligned with the lateral canthus. So that was another part. Then there was
Yeah.
another part based on retinal astigmatism. So a lot of other things were there in the video, but because of 6 minutes, we had to cut down on a lot of things.
Agreed.
The next one, yes, so please ask the next speaker to come in.
Good evening, everyone. Am I audible?
You're audible,
Yes, Dr.
Kritika. Can you
Shritika, you're
please share
audible.
your
Please,
video?
please share your presentation.
Yes, thank you so much for this opportunity. So today I'll be presenting a video about repeat
Doctor, you
D-sex
need to
surgery.
Your
share
video
first.
is not visible, Dr. Shritika. You're going to have to share it again.
One sec.
Admin, can you guide her, please, once?
Doctor, can I share from my side, please?
Yeah, that will do.
Thanks.
Yes, thank you.
Can we have the timer, please? Please let the video keep playing.
So this is a case of a repeat D-sex surgery that is performed. First, the cornea, which has a lot of edema, the epithelium is deprived for a good visibility. The previous graft size is measured, and accordingly, 7.5 mm trephine is used. A side port is made, and trephine blue dye is injected, so to stain the endothelium. And now a groove is made with a 7.5 mm trephine. Viscoelastic is injected into the AC so that the AC remains taut during our scoring of our D-sec graft. Now, scoring of the previous D-sec lenticule is done with the help of a reverse Sinskey hook. As you can see, this is a case of already a previous D-sec surgery, so there are a lot of adhesions and fibrosis at the edges. After separating completely the D-sec lenticule, there is the tag that you can see, which can be removed with the help of a scraper. Scleral tunnel is made. At times, you can even make a corneal or a limbal incision. Now the lenticule is removed, but at one point there is an adhesion with the stromal fibers. So with the help of a scraper, it has been removed properly. Or even a microrhexis forceps can be used for this. Once it's completely separated, two side ports are made, and the donor rim is prepared on an artificial anterior chamber, and your partial thickness dissection is started with the help of a crescent knife. Make sure that the donor rim is properly fitted in the anterior chamber, artificial chamber. Now, with very gentle and meticulously, the dissection is continued with the anterior lamella corneal dissector blade. Dissection is completed in periphery 360 degree. Now this donor rim that is prepared, it is dismounted from the artificial anterior chamber. handling of this donor tissue should be very gentle, as it can even lead to endothelial cell loss. There is a lot of manipulation. Now a graft of 7.5 mm trephine is punched out, and separation of the anterior and the posterior flap is separated. Just to make orientation of the surgeon, gentle violin marker is used, but make sure that it does not be put on the endothelial side. It is endothelial toxic. Now this donor tissue is gently placed on a Bucin glide. Viscoelastic is placed over it and is gently pushed forward. Now the side port that we have made inferiorly, from that you can just, with the help of a micro forceps, we can pull the donor tissue into the AC. A large air bubble is injected through side port, and with a sweeping and a massage we have to do over the cornea, so that the interface fluid or any viscoelastic which is remaining, it helps in adhesion of the donor with the host. Now all the tunnel and the side port is sutured so that the air does not leak away, and it helps in good adhesion of the donor tissue. Three-month follow-up, the patient had good visual recovery and the graft was clear, and intraocular pressure was stable. So this take-home message from this is it can be considered if we do a proper preoperative planning and medical surgical execution. And also this case highlights the importance of individualized surgical approach and proper follow-up in such cases. Thank you.
Thank you so much, Dr. Shrutika. I think it was a very well-performed surgery, showing the nuances that are actually required, especially during a resurgery when a previous DSEC has been done. So quick questions from the judges. Anaga ma'am.
Very well done. Nice, nice.
Thank you, ma'am.
Yeah.
Atul sir, any questions? Sir, you'll have to unmute yourself, sir.
Why you have to do again another procedure? The reason for the failure of first dissection?
Yes, sir. The first surgery that was done, it was initially a very normal surgery, and the graft was well. But after some time, the graft underwent decompensation. So it was a primary graft failure. So instead of giving intracameral tricot and IVMP, the graft did not survive. So we had to, we suggested of undergoing a repeat surgery.
These patients needs to be on steroid for a long time, so that the graft should.
Yes, sir. Means for the maintenance of the graft, you can give prednisolone acetate 1% for a longer period, like 1 month, and then you can taper it accordingly. And till 6 to 1 year, we can keep it on steroids.
Thank you. Nice surgery.
Thank you, sir.
Yeah, it was a nice video.
Thank you, sir.
Because it becomes more difficult in failed case to do DSEC. To remove the failed graft in toto, it becomes very difficult.
Yes.
But you have done it very nicely. Great. Please go ahead. Yeah.
Thank you, judges, for your comments. I think we'll proceed with our last video for today, which is Dr. Amit Nene, who will be showing his case series of macular holes in different clinical scenarios. Can we have the timer reset, please? And if Dr. Amit, you can share your video.
Yes, good evening, everyone. So I will be starting with my video presentation. I just want to confirm whether the sound is audible or not.
It's a little low, but it's barely audible.
जिन्होंने हम फाइनल ईयर स्टूडेंट्स के लिए आज ये शानदार पार्टी दी है.
So what cataract surgeons usually have is a NS2 or NS3 cataract for their fellows or for the new surgeons. And for us retina surgeons, a clean macular hole case is the one which we look for. But a macular hole combines with baggage. So I will be presenting a few different scenarios of macular holes. The first case is a persistent macular hole. So for this, a resurgery was planned and the amniotic graft was kept on standby. So as you can see, there is a well-demarcated zone in which the staining has not taken place because of the previously peeled ILM. So I took few bits of ILM from the periphery and I stuffed it in the hole. So there was a good closure. The second case was a case of bullous retinal detachment with macular hole, and surgery was planned. So in cases like this, I usually stain the ILM and I do a partial peel. Then I put PFCL to settle down the retina, and the rest of the peel is completed like a routine ILM peeling surgery. So the third case is a macular hole, which is associated with vascular occlusion. So this was a patient of BRVO for which 2 much sectoral laser was done, and because of that, there was traction, which resulted in a partial TRD with a macular hole. So in this case, initially a vitrectomy was completed, and the traction around the area of lasered BRVO was removed. So I'm doing diathermy to the iatrogenic hole which was there. So in this case, I stained the ILM, but I'm not sure whether this is a ILM or a ILM ERM complex, but I tried to cover up the hole with it. And I did a fluid air exchange. I lasered off the hole. So I got very good results at post of 2 weeks with complete closure of the macular hole. This next case was a female who was operated for retinal detachment. Surgery was done. It was successful. Silicone oil removal was done. But after 2 months, the patient again presented with a macular hole. So to begin with, the patient didn't have a macular hole. But during the first surgery, I did a ILM peeling for her. So this was at presentation. At 2 months follow-up, there was a cyst which increased to a hole. I waited for a month, but the hole enlarged. So I planned surgery for her. So in this case, I'm just staining to see whether a complete ILM removal was done or not. I just did a fluid air exchange for her. And with the help of a soft tip, I just dried up the macula. And that's it. C3F8 gas was put at the end, and you can see a complete successful closure of the hole. The next case was a traumatic dislocated cataractus lens with a RD and macular hole with extensive PVR. Primary vitrectomy surgery was done, but to our dismay, there was an inferior retinal detachment under oil with a persistent macular hole. So again, restained it. You can see the area of peeling done prior. This is a drainage retinotomy which I made. I did a retinal autograft in this case. So retinal autograft is fashioned a size little bit more than the macular hole because this graft tends to shrink over time, and it was placed over the hole in the PFCL. The site was lasered and even the drainage retinotomy was lasered. I put oil at the end and you can see how well the graft has integrated with the retina. This case was a case of trauma again with ball. and the patient had a macular hole with subretinal bleed. So I injected TPA subretinal. You can see the blood coming out from the macular hole. So after 5 minutes of waiting, like a routine macular hole surgery, I created a temporal flap, and the nasal ILM was completely peeled off. So there was complete closure of the macular hole.
बस करता तो ज्यादा टाइम लग जाता सेठ जी, इसलिए फिर मैं रिक्शा में आया.
Thank you.
Great videos, Dr. Amit. Thank you so much for showing the entire gamut of surgeries in macular hole. We'll have quick questions from the judges. Dr. Anagha ma'am, Dr. Siddharth sir, Dr. Atul sir.
Yeah, that was great videos. Especially you should highlight the pre-op and post-op vision in such cases, how much visual outcome each patient had got. And yeah, that's all. Videos were very nice. That's all from my side. Yeah.
So I'll make a comment and then we'll quickly move on to the next. Yes, Dr. Anaga, you have something to say.
No, I think very good collection of all the subspecialties videos that we are able to see today. So good, a nice bunch of cases of macular hole. Good.
Okay. Considering that our judges are not VR surgeons, so I thought I'll make a quick comment and we'll move on to the next speaker because we are short of time. So like everybody said, and we all know Amit is a fantastic surgeon and a beautiful collection of videos. The only thing that I would perhaps differ from all of your techniques is that I would never advise young surgeons never to drain from the macular hole, whether it's a macular hole associated with the reg RD or a mac hole RD. So what happens is it tends to enlarge and the chances of type 1 closure is comparatively less. So that is the only difference. Baki, everything was beautifully covered. I think almost all aspects of different varieties of macular holes were shown. So absolutely phenomenal. Thank you, Amit.
Thank you so
Thank
much.
you, Dr.
Can you
Piyush.
invite the next one?
I would also have to just make one small comment. I think the second last surgery which was shown of the autograft, I think that was great, but my just 2 pointers would be that one, ensure that the ILM is well peeled before going for an autograft. Otherwise, just an ILM peel is usually suffices, and the location of the autograft can be such that that can be your drainage retinotomy as well, rather than making two, retinotomies per se. So that would just be my 2 cents. But otherwise, great collection of videos as always, Dr. Amit.
Have you tried
So-
that? Uday, we have harvesting the graft from the retinotomy area. Have you tried that?
Sorry? Yes, I have. In the upper nasal area.
So we'll talk about this later because we don't have time, and we also have trifines made by Rupakanti Biswas that can be used for refining the retina accurately. So since we don't have time, we'll move on quickly. Huh?
We move on to our last presentation. I'm sorry I missed this. Dr. Pratima has her video, which will be on management of graft preservation and cataract removal in shallow anterior chambers post keratoplasties. Dr. Pratima, please. You're not audible, Dr. Pratima. Your mic needs to be checked. Can you share your presentation in the meantime?
So the audio is not coming through.
Are you wearing a Bluetooth or something? Try increasing the volume from your laptop, or if you're wearing a Bluetooth device, you can try removing it. No, we can't hear you.
We can't hear you. Can you share your presentation in the meantime? We hope to hear the audio in your video. Yes.
So the audio might not come through. So the audio
There is no audio coming in. If you can just test your mic once, I think that would be a challenge.
Doctor, do you have any alternate device, a phone or anything you can connect with?
We can hear you.
We hear something now. Yes.
You can hear me now?
Yes. Please proceed.
Thank
Can
you.
you have the timer on, please?
Opportunity, and I'm starting the video now.
Hello, everyone. Today I will be presenting a case of balancing graft preservation and cataract removal in a shallow anterior chamber post-penetrating keratoplasty. This case involves a 48-year-old gentleman who presented with the following clinical picture. After corneal scraping, we diagnosed the patient with fungal keratitis and initiated antifungal therapy. Although initial improvement was observed, the patient subsequently developed a central corneal perforation. The anterior chamber failed to reform despite TABCL application and anterior chamber reformation. A B scan revealed an anechoic vitreous.
I think your video has gotten stuck, at least. It doesn't seem to move for me. I can't speak for the others though. Dr. Pratima's webcam is also off, so I'm guessing she's having some internet issues. Is everybody else facing the same problem as I am?
Yes, video is not moving.
We have 7 minutes in the session so remaining, so we'll let's see if she can complete it.
Do something.
Dr. Uday, if you have her number, you can call her, no?
Yes, I will just do that. Yeah.
I will speak to her. Internet issue.
Yeah, the lights have been going on and off.
There's lightning going on outside my area at least.
Oh, we had a lot of rain, so my light went off. If you have anyone else in this session remaining, then they can continue.
No, ma'am, she was the last one.
Oh, we'll give her 5 minutes. And we still have time, na, Piyush?
Yeah, she's here. She's here. Dr. Pratima, try again. We're waiting for you.
You'll have to unmute yourself, Pratima, and
Yes, please play your video. Can we restart? Can we continue the timer, please?
we have only 5 minutes in the session remaining, so the moment she finishes.
I'm waiting for the audio to come to start.
TABCL application and anterior chamber reformation. A B scan revealed an anechoic vitreous. Given the scenario, we proceeded with therapeutic penetrating keratoplasty. Following TPK, the anterior chamber deepened and no signs of infection was noted. However, in the weeks following surgery, the anterior chamber began to shallow again. This was attributed to the progressive bulging of the cataractous lens and 360-degree peripheral anterior synechial formation. By the fourth postoperative week, with further anterior chamber shallowing, we planned for cataract extraction. In this case, IOL power was calculated using the fellow eye. We decided to give the patient preoperative mannitol, and B-scan findings remained within normal limits. The anticipated challenges in this case were decreased anterior chamber depth, making surgical maneuvers difficult, reduced distance from the graft endothelium, increasing the risk of endothelial rejection, poor visibility due to graft edema, elevating the risk of posterior capsular rupture. To address these challenges, we decided to perform a minimal posterior vitrectomy to deepen the anterior chamber. First, a conjunctival peritomy was performed, followed by cauterization of the area. A scleral tunnel was created, taking care not to cross the graft host junction. A scleral port was made, and minimal posterior port vitrectomy was performed, which slightly deepened the anterior chamber and softened the globe. The tunnel was then entered. Trifle blue dye was injected and washed off. Viscoelastic was injected and a capsular access was completed. Given it was a soft white cataract, initial lens debulking was done using a bimanual technique, and the denser nucleus core was reported via viscoelastic expression. The posterior capsular integrity was verified using a light pipe. Once confirmed as intact, an intraocular lens was implanted. The tunnel was sutured and the conjunctiva was repositioned. Subconjunctival dexamethasone was administered. On post-operative day 1, the anterior chamber measured 4.5 milliliter in depth. However, due to the inflammatory changes and a zipper-like mechanism, there was a recurrence of 360-degree peripheral anterior synechial formation. By 1 month post-op, the anterior chamber was minimally formed, but the central graft remained compact. The primary goal in this case was to preserve the graft post-penetrating keratoplasty during cataract extraction. Performing a pars plana vitrectomy was instrumental in deepening the anterior chamber. It increased the distance from the endothelium and prevented endothelial damage and graft rejection. It also created space for cataract extraction, facilitating smooth surgical maneuvers. The light pipe played a crucial role in enhancing visualization of the posterior capsule and any residual nuclear fragments or cortex. Although IVL implantation was not ideal in this scenario, pars plana vitrectomy helped strike a balance between graft preservation and safe cataract removal in shallow anterior chamber in this post-peaked case. Thank you.
Thank you so much, Dr. Pratima, for your excellent video. I think in the interest of time, we will not be able to take questions. So thank you to the judges and to all panelists for sticking on time. We've finished sharp on time. So we'll hand it over to the next pediatric ophthalmology session. Thank you so much again, everyone.
So, Dr. Shubhasavar, are you there?
She's there.
Yeah, Malik Madam is also there.
Yes.
So I'll just request Dr. Shubhasavar, who's a member scientific committee in our team, to quickly introduce the moderator, and he can then begin the session.
Yeah.
So we have Dr. Prasad Warimbe, who's going to be moderating the session. We have Chairman Dr. Sunaina Malik Madam and Dr. Siddharth Kesarwani. So over to you, Dr. Warimbe, sir.
Yeah, good afternoon, everyone. Am I audible?
Yes.
Yes, you're audible.
Yeah, so welcome to this wonderful session of Dilemmas in Pediatric Ophthalmology. It's really a wonderful CME, online CME. So without wasting much time, I would invite Dr. Sunaina, the stalwarts in the field of squint and pediatric ophthalmology. We are fortunate to have Dr. Sunaina Malik and Dr. Siddharth Kesarwani. Dr. Sunaina Malik is a well-known, renowned squint specialist and pediatric ophthalmologist from Chhatrapati Sambhajinagar, and Dr. Siddharth is from Mumbai. And we'll be happy to hear their pearls of wisdom after every case. So without going into much details, I would invite the first speaker, Dr. Shilpa Sonar Khan, will be presenting dilemmas in managing MED cases. Over to you, Dr. Shilpa.
Yeah, good evening, everyone. I'm just trying to upload the presentation.
I must congratulate MOS and specifically Piyush and Sumit for sticking to all the time and for the wonderful arrangements. It has been really a treat to hear all these sessions.
Yeah, it's showing an invalid URL.
Shilpa, are you sharing your screen?
We are seeing you.
No.
It's showing an invalid URL. This is the document.
Sunil sir, if you can.
You can take the next one.
Yeah, please go
Yeah,
Dr. Kruti Shah, are you there?
I can see Dr. Sheetal Dahane. She's one of the.
She's here, she's here.
Yes, sir. I'm here.
Kruti, you can start sharing.
Yeah.
Okay,
so
I can
think-
start sharing. Fine. Yes.
Yeah.
Fix your.
Dr. Shilpa, you can stop sharing, and Dr.
Yes.
Sheetal, you kindly to just start sharing.
Started.
Just give me a 1 minute only. Just 1 minute.
It's a request to everybody, all the speakers, that please have your presentations on your screen ready to share, so that it hardly takes 2 seconds to share it.
Ideally, if I may just add to what Piyush is saying, you should have your talk on your desktop. The left hand, your left hand. I think she's starting. Yes.
Yeah. I thought I was second, so I did not start it.
Right.
Yeah, sure.
Right.
Slideshow.
Make it a slideshow.
Yeah, sure, sir. Sure, ma'am. Yeah. So, thank you everyone for such a wonderful opportunity. My name is Dr. Krutisha. I would be discussing a case of thyroid in hypothyroidism. So, thyroid eye disease and hypothyroidism. Okay, fine. Sorry, I'm ready. So, this was an 8-year-old child, a female child, which was referred by a pediatrician friend. The child had complaints of irritation of the eyes intermittently since 3 to 4 months. Her previous medical records, she had consulted a pediatrician for complaints of short stature. That was the main complaint, lethargy and decreased appetite 2 years back. There was no significant systemic history, no significant family history. So investigation reports, this was of 2022, except for hemoglobin, all her CBC report was normal. Blood sugar report was normal. Free T4 levels were marginally increased, but TSH levels were high. So the pediatrician suspected hypothyroidism, and they went ahead with further antibody titers. So they found the thyrotropin receptor antibody was negative, serum thyroid binding globulin antibody was positive, and the TPO, the serum microsomal thyroid peroxidase antibody was positive. So the diagnosis was primary autoimmune thyroiditis or Hashimoto's thyroiditis. The child was started by L-thyroxine supplements, 50 micrograms a day, started by an endocrinologist. So according to the mother, for 2 years after starting the treatment, the appetite had improved and the child also became more active. There was improvement in the height, weight, and the BMI. And also they also maintained a monitoring chart of all the titers. Now, clinical presentation in Jan 2024 when they came to me. So the symptoms, there was irritation of the eyes intermittently. There was staring eyes all the time. No redness, pain, diplopia, decreased vision. So this was her picture, clinical picture. There was proptosis, right eye more than left eye. I did not have an exophthalmometer, so I just used scale. So this could be a little gross, but then yes, there was proptosis. Right eye was 22 and left eye was 20. Increased scleral show, lid retraction, starring look, Stellbach sign was positive. No specs classification, class 3A. But these were the signs of Graves' ophthalmopathy, which was seen in hypothyroidism. So I was really puzzled. And I wanted to have a little more, brush up of my knowledge. So I went to PubMed. And before that, these extraocular movements were all normal. All the anterior segment was normal. IOP was normal. Posterior segment was normal. Corneal reflex, all the strabismus workup, everything was normal. So I just did a CT scan because the patient was not very affording for an MRI. I found a right mild proptosis in the, of the right eye, and the right superior and the medial rectus also appeared bulky compared to the left. So my 2 questions that I had in my head was, how common is Hashimoto's thyroiditis seen in children? And if thyroid-associated ophthalmopathy can be seen in Hashimoto's disease. So I did this review of literature, as I was mentioning. I went to PubMed. And autoimmune thyroiditis is a disease of adults, 40 to 60 years of age, especially more common in women. Though rare in children, it is most commonest cause of primary acquired autoimmune thyroiditis. Its prevalence rate is 1 to 3% in childhood. Speaking of adolescents, peaking in adolescents, more common in females, 4 to 8 is to 1. Growth delay and thyroid swelling are the commonest symptoms. Associated disease include Down syndrome, Turner's, diabetes, mellitus type 1, and celiac disease. Hashimoto's thyroiditis and Graves' disease are considered to be the 2 ends of the same spectrum. The autoimmune disease, the link between the 2 is the abnormal functioning of regulatory T cells. In Graves' disease, TSH receptor antibodies are positive, and these are responsible for acting on the orbital tissue and causing ophthalmopathy. And thus, it can be seen in ophthalmopathy in hypothyroid and euthyroid Graves' disease as well. But these antibodies are absent in Hashimoto's, and so the exact cause of ophthalmopathy in Hashimoto's is not clearly known. There are very few cases of ophthalmopathy in Hashimoto's thyroiditis reported. The prevalence rate is 10.36% globally. Now, treatment that I gave was lubricants, as the patient was not symptomatic otherwise. I gave education, vision abnormalities, inflammatory signs and strabismus, genetic counseling for sibling. And I saw the child again in Jan 2025. Thyroid profile was stable, and there was no further clinical change in clinical features of the eye. So why this case? I just wanted to point out that thyroid eye disease can occur in Hashimoto's disease as well. Prompt recognition and treatment can prevent complications due to corneal nerve involvement and optic nerve compression. And it can also be seen in diseases with Down syndromes and Turners, and thus evaluating them would be further helpful. And diabetes as well, diabetes mellitus type 1. So these are my references, and thank you for this opportunity.
Yeah, nice, Sheetal. Now over to you, Dr. Shubha Zawar, for your comments and any questions.
Yeah.
Dr. Zawar, kindly unmute yourself.
Yourself. Shubha. In the meantime, you can take the other panelist, Prasad.
Yeah. Dr. Tejaswini Kirpekar, are you there? I'm not able to see that over there. Dr. Tejaswini Kirpekar?
Yes, sir.
Yeah.
So, so I think I'm there for the last case.
Yeah.
Okay.
So,
This is Dr. Kruti's case. For
Yeah,
Dr.
Dr.
Kruti's case,
Kruti.
please.
Yeah.
Yeah, so this was a nice presentation, Kruti. I think the expert panelists here are Dr. Rushikesh Mai and Dr. Aparajita Shinde, right?
Right, that's
So
right.
I'm there, Dr. Rushikesh.
you can ask her a question.
Am I audible?
Yes, sir.
Yeah.
Actually, it's a very nice case. I mean, Dr. Kruti, in fact, all of us went to PubMed after, going through this case. It's very rare to have, Hashimoto's thyroiditis. It is rarer to have Hashimoto's thyroiditis in a child. And it is still rarer to have ophthalmopathy in a Hashimoto's thyroiditis in a child. As you, you went through the literature very well. Because Hashimoto's thyroiditis is more common in elderly or middle-aged women, whereas in your case it was a child. I would like to ask one question. Was corticosteroid, systemic steroid treatment considered in your case? Because you did not mention anything about that.
Yes, sir. So no, sir, because there were any acute inflammatory signs, systemically or in the eye. She just complained of irritation. That was it.
Okay.
And even systemically, when I asked, there was no hospital admission and no other treatment given. She was directly started on thyroid.
Okay, because unfortunately MRI could not be done because MRI,
Yeah.
the delayed response in MRI in T2 weighted image that actually points towards inflammatory condition. But in this case, it was a CT scan. There is no clear-cut protocol the way we have for Graves' disease when to start systemic steroids and things like that. That protocol is definitely not there for Hashimoto's related orbitopathy. But I think for many of the cases which have been presented, all the case reports which have been presented in literature, it has always been they have taken the treatment from Graves' disease and applied it for Hashimoto's related ophthalmopathy, which obviously includes systemic steroids. So it's a very interesting case. It's a publishable case actually. You should go.
Thank you. Yes. Yes.
Uh,
There was one thing that I couldn't point out. They had done a thyroid ultrasonography as well, but the mother had lost the report. So I could not read that. That was gone.
Any comment from Dr. Aparajita? Yeah, Malik madam, your comments, please.
Yeah, ma'am.
Wanted to ask that you called the patient back for follow-up after 1 year. Did you notice any change in her staring look when you saw her next?
No, ma'am, same. I had the photographs. I compared with the photo only. It was all same.
Okay, and she did not complain of any symptoms because of the, proptosis?
No. Actually, I had called her I had told her to come after 4 to 6 months, but she didn't come. But in between, the mother said that she was all fine. There was no irritation and they were constantly on lubricants. Like bedtime, she was putting a gel for the whole year.
Good. It was a very good case.
Good.
Thank you so much.
Very good case, Dr. Kruti.
Thank you, sir.
Is Dr. Shilpa, are you ready with your presentation?
Thank you.
Shilpa Sonar Khan.
Dr. Shilpa Sonar Khan.
Oh, Prasad, you can go to the next person.
So we'll go to the third case by Dr. Hemant Anaspure.
He's back.
The case is post-operative slipped medial rectus. How early to intervene? Dr. Hemant?
Yes, sir.
Yeah. So kindly start sharing.
Hemant, your video is not on.
Dr. Hemant, do you have a physical camera cover on your laptop?
What, sir?
Is there a physical cover on your laptop?
No.
Your camera is not coming on.
Your video is not showing it. Can you try sharing?
Add the video, please. Himant, we can't see you.
Can you see the
It's okay.
presentation?
Yes.
Yeah.
Your slides are visible. Go ahead.
Kindly go to this
Okay. Okay.
It's okay.
slideshow mode.
It's okay. Even if
Okay.
he's not there, his slides are showing.
Okay, so I'm presenting a case of slipped medial rectus is known but very disturbing complication of squint correction surgery for any operating surgeon as well as patient. And medial rectus, as we know, is the most frequently
Slideshow,
slipped
please.
medial rectus.
Now,
No,
kindly make a slideshow of this.
Make it
is
full.
it is full screen
No,
or
it isn't. It isn't. You have gone to slideshow, but you have not clicked from beginning. So if you once you do that, it will come full screen. No, go from beginning. Go to beginning. And corner.
The first icon.
yeah, first I'm gone for the first only.
Doctor, can you share again? And this time, please select entire screen. Don't select the presentation. Just select the entire screen when you share. Just click on share screen button once, entire screen, and then the blue button.
I'm sharing the entire screen.
Yes. Yeah. Just click on the presentation, please. Bottom. And make it a slide
Now,
from
is
the
it
beginning. From the
Yeah.
beginning.
Yeah. Yes.
is it visible now?
Yeah, go ahead.
Go ahead now.
Visible. And am I audible?
Yes.
Okay. So, slipped medial rectus is a known but very disturbing complication of squint correction surgery for any operating surgeon as well as patient. Now, medial rectus muscle is most frequently slipped medial rectus because they don't have any facial attachment with the oblique muscle. Now, consecutive exotropia is shown to between 4 to 27% of patients after surgical correction of esotropia. Now, here I present a case of consecutive exotropia due to slipped medial rectus noticed in a very early post-operative period. Now, she was an 11-year-old female with the 6/6 vision in both eyes with a very low hypermetropia. Now, deviation of left eye inwards was since childhood or birth. Cover test showing alternating esotropia of almost 30 plus 40 prism diopters of left esotropia. Extraocular movements in the right eye were full. Left eye was a -1 limitation of abduction. Fundus was normal with no torsion. Now, these are her preoperative photographs with left eye esotropia, which was right was her dominant eye. Now, I diagnosed her as an essential infantile esotropia, advised her bilateral Quint's correction surgery under general anesthesia. My surgical plan, I went ahead with the 6 mm MR resection with lateral rectus resection of 8 millimeters. Now, when she came back on a day 4 post-operatively, I noticed a very large angle left eye consecutive exotropia of almost 50 prism diopter LXT. And I took the limbal approach, and left eye was showing a large angle exotropia. Now, these on the adduction, attempted adduction, her left eye was showing a limitation of adduction was there. Abduction was full. Video I will show later on if it shows, but surgical dilemma, what went wrong? Whether it was a wrong preoperative measurements, because sometimes we go for a outside visit once a month and we call the patient for the surgery. So many times take a very couple of measurements only are taken, whether it was a faulty suture technique or any patient factors. Now, how to counsel the parents now? Because we expect small angle ESO or EXO, we keep telling to the patient that it is expected, but a large angle, it's very difficult to counsel in a very early post-operative period. And now, how early to intervene? Now, mostly answer is going to be immediately. We should intervene as soon as we see, but then there are few things which came as a dilemma in my mind. Is whether the rectus muscle, at what time we expect the rectus muscle to get attached to the sclera so that we can hook it again. If I try to hook the slipped medial rectus, whether it will convert the slipped muscle into the lost muscle. Now, whether angle is going to be unstable because it is a very early post-operative period, and whether the single muscle medial rectus advancement will work in this case, or whether we should operate any other muscle as well. Now, these were my surgical dilemmas. I went ahead with the immediate re-exposure on the 5th day. I found the medial rectus slippage of 2 to 2.5 millimeter behind my intended recession site. Now, I gently sutured the suture with 6-0 double armed Vicryl suture and then disinserted the muscle from the sclera. And then I reattached the muscle to the original insertion site. That was approximately 8 to 8.5 millimeter advancements I did. Now, this was her pre-operative photograph before the second surgery, and this was her photograph 10 days after the second surgery. and cosmetically she was like in very acceptable kind of angle. And after 6 weeks I did another follow-up, which was my last follow-up of the case, and adduction was full from day 10. Now going to the discussion part, Helveston ads are done almost 60 patients they have studied, and Belson studied almost 7 patients, where they shown that probably if we identify early and we reattach the rectus muscle, the good surgical outcome are possible. Justin D. Leon et al. Has studied a 20 patient of consecutive exotropias and concluded that the medial rectus muscle advancement is effectively treatment for the consecutive exotropia, but it is usually associated with the late exodrift. So we should tell the patient and parents that it may go into the exodrift later on. They also notice that for prism diopter correction of exotropia per millimeter of medial rectus advancements, the studies show between the 2 to 5 prism diopters correction is there with the medial rectus advancement. Another one interesting is in IGO, where the JSRP has shown that if there is early postoperative consecutive exotropia, particularly in a very small child, and when there is no limitation of adduction, even overcorrection with -2, they have shown a good postoperative recovery. Now, in conclusion, that early postoperative intervention in suspected medial rectus muscle slippage results in early recovery as well as good postoperative outcome. And probably a single muscle surgery at medial rectus advances is sometimes sufficient to correct even a large angle. In my case, it was almost 50 prism and 8 mm of advancement probably caused a good cosmesis. Thank you very much.
Yeah, good case.
Yeah, can I show the video? Is that video is visible?
Please go ahead. Please go ahead.
Okay. This was a video after first surgery, and right eye the abduction was full, the limitation of adduction was there, and then when I went back, abduction was good in the left eye. And this was after the 10 days after the second surgery. So adduction was full with low limitation. So for the experts, I would like the comments like how they will approach a case of like medial rectus slippage when it is seen in a very early post-operative period.
Yeah, good case. Dr. Preetham, your take on it? Dr. Preetham Bhujbal, please. Kindly unmute yourself and just speak.
He's unmuted. He's unmuted, Prasad, but his audio is not coming. We can't hear you, Dr. Preetham. Dr. Preetham, speak into your mic.
Can you increase your volume, please?
You're not audible. Dr. Preetham, I think someone has to phone and tell him, because I think he can't hear us also.
Dr. Abha, your take on it? Dr. Abha, I'm not able to see her.
I don't. Is she there?
Dr. Preetham, can you increase the volume of your laptop? You're not visible.
No, he's not audible.
Yeah. Malik, madam, your comments on it?
Yes, very interesting case, Hemant. And as he rightly said, it's always a dilemma whether to go in right away because it's immediate surgery. You already done one. First of all, convincing the parents is going to be one big issue. That they're going to ask what happened, how the need for a second surgery. So in such situations, I always tell everyone, all squint surgeons, that in the beginning itself, at the first meeting with the relatives, emphasize that a second surgery might be needed. You never know when it might be needed. So if you've already told them, they're not going to think any the worst of you. Otherwise, they always think that you're doing it for financial interest. So I've learned this the hard way, but I think it was a good decision on Hemant's part to go in right away. Luckily, he found the slip muscle and could reattach it very nicely. The results were very good. Hemant, that you.
Yeah, one more tip on table, if you find slipped muscle, don't fish it along the sclera. You should usually search it towards the orbit. That's one part. And one very important thing which is not usually taught in books is keep your cool. This is part of the game. Sometimes this happens. Just keep your cool.
I think
and don't fish it along the sclera, but you have to go towards the orbit, and it's most there's a fair chance that you might recover the muscle, and you can go and proceed with the same numbers what you have planned. And of course, afterwards, as the good job Dr. Hemant has done, of course, there are other options like VRT and other things also, but the counseling is very important. We'll go to the third case. Dr. Abhilasha, are you ready with your presentation on your desktop? Dr. Abhilasha?
Yes, sir.
Yeah. Can you start sharing the screen and start your case? When one nerve falls, dilemmas in management of paralytic strabismus.
Doctor, in case it's not coming, can you just stop and reshare?
Yeah, the whole screen is.
Your screen is not visible, Abhilasha. Stop and again start. Go back again. In the meantime, has Shilpa managed to solve her issue? Shilpa, have you managed? You are muted.
Yeah. I'll share my presentation if it gets connected.
Prasad, shall we let her?
Yeah. So Abhilasha, you can stop sharing, and Dr. Shilpa Sonar Khan, you can start with your case. Yes, thank you.
From a tech side, if anybody can help to stop share.
Just go to.
Not happening.
You've gone to Zoom actually. No, Shilpa?
Yeah.
Dr. Shilpa, can you minimize this and open your PPT, please? And humble request to everybody who's presenting, please open your PPT first before you share.
Yeah.
Okay, yes.
Please open your PPT.
I'm stopping, Dr. Shilpa. Can you just first open your PPT and then share, because the entire
Okay, sure.
Just
I'll
find
stop.
your PPT, open it, and then come to Zoom window.
Okay, sure.
For other speakers also, this tip is very valuable, I think.
Okay. So can you see my presentation now?
You need to reshare again, please.
Share now. Have you opened your presentation?
Yes.
Huh? Have you? No, we cannot see your presentation open. Now,
Dr. Shilpa, can you just share, please?
One share. I think Sunil help her out.
Yeah.
The green button on the Zoom window, just here.
Maybe Shilpa, you better send your presentation to him, that he can share it for you. In the meantime, who did we have next, Prasad?
Dr. Sheetal is there?
Shilpa,
I think,
Shilpa is
yeah,
ready.
Dr. Shilpa. Yeah, Shilpa is ready. Yeah.
But now make it full screen.
Yeah, yes. Yeah. Okay, is it there now? Can everyone see?
Absolutely.
Right, right.
Okay, so first of all, sorry for this delay, and good evening, everyone, and thank you for Moss for this opportunity. And today's session is dilemma in pediatric ophthalmology, and I'll be presenting on monoocular elevation deficit. The name itself is a dilemma, and right from diagnosis up to choice of surgery, everything is dilemma in monoocular elevation deficit. And so diagnostic dilemmas in MED arise because some patients present with pseudotosis, some have true ptosis, some have limitation of elevation in all abgases, and few have limitation of elevation only in abduction. The Bell's phenomena can be present or absent, and upward saccades can be normal or reduced. So let's start with, I'll elaborate all these things in detail afterwards, but first, let us start with the case. This is the first case. A 19-year-old boy who was who presented with squint since childhood. His visual acuity and anterior segment and posterior segment examination, everything was remarkable. And this is his 9-gaze photo. In primary position, he has 35 ET with 20 RH OT. And chin elevation minus half limitation of abduction. MRI brain and orbit were within normal limits. He had a limitation of elevation in all 3 abgases, supraversion and dextro and levo elevation. FDT was planned and IR was +2 tight and MR was +2 tight on table. And so only MR recession 6.5 mm and IR recession of 5 mm was done. Again, I'll come to the surgical table and guideline for surgeries later. What I would want to, post-op, the patient had a residual 7 prisms of right hypotropia. What I would want to highlight here is sometimes the fixating eye, the patient present with the MED eye is the fixating eye, and there can be hypertropia of the normal eye, whereas some kids present with fixation with the normal eye and they have hypertropia of the affected eye. Another thing I would like to comment here is pseudotosis may get corrected after the surgery, but true ptosis, which is seen in our second case, may persist after the correction of the MED. Now, how to differentiate pseudotosis is just by covering the good eye, and the MED eye will take up the fixation and the pseudotosis may get corrected. Now, this is a second patient who had severe ptosis obscuring visual axis with the left face turn and chin up with Marcus-Gunn jaw winking phenomena, MED and ptosis. She had 25 prisms of right hypotropia in primary position with 10 prisms of exotropia. Anterior segment, posterior segment, and refraction, everything was unremarkable. Intra-op FDT was free for this patient, and IR recession with modified NAPS was done. And post-op, the results were very satisfying. Again, pseudotosis improves completely after surgery, while true ptosis may improve partially and will need ptosis surgery later. This patient underwent ptosis surgery after 3 months. Coming to third case, it was a child, 7-year-old, with history of squint and ptosis since birth, and visual acuity 6 parts with the corrected refractive error. Anterior and posterior segment findings were unremarkable. He had around 35 prisms of RHOT in primary position with 16 prisms of esotropia with poor Bell's and slow upward saccades. FDT was free and he underwent IR recession with modified Nishida's technique. And he had post-op 4 right hypotropia with 6 prisms of ET. Now, why some of these findings like Bell's phenomena, why upward saccades are important? Because here is one case who has limitation of elevation in all gazes, and the other child who has limitation of elevation more in abduction.
Sir, I sent link on WhatsApp.
And Bell's phenomena is poor in one child and the Bell's phenomena is good in the other child. So this will help you in diagnosing and also planning your surgery. So this is detailed workup of MED, and this all I have explained through cases, but if I explain this table, it will take another 2-3 minutes. So I'll skip this part. Coming to the management dilemmas in MED, observation, especially if there is no refractive error, no amblyopia, you can observe the child, close monitoring. Refractive error, you have, if the child presents with refractive error, first correct the refractive error, and if amblyopia, you have to correct the amblyopia. Now, management of MED solely depends, or the most crucial thing is positive FDT test. If the FDT is positive and there is a tight IR and hypotropia of less than 10 prisms, in primary position, IR recession alone is sufficient. If less than 25 prisms of hypotropia, IR recession with modified NAPS is done, and 25 to 35 IR recession with complete NAPS is done. This is my last slide. If the MED is if the FGT is negative and primary position hypotropia is less than 10 prisms, and if there is some SR function, then you can go ahead with SR resection. But if SR has no function, IR recession with modified NAPS is done. Less than 25 prisms of hypotropia in primary position, again same, if some SR function, you can do SR resection, otherwise go for modified NAPS. And 25 to 35 prisms with NAPS or a modified Nishidas can be done. And if more than 35 prisms of hypotropia in primary position, IR recession with augmented NAPS or modified Nishidas with IR recession can be done. In our first case, there was tight IR, so we did only IR recession. In second case, we did modified NAPS with IR recession for around 25 prisms. And for 35 prisms, we did IR recession with modified Nishidas. So based on the FDT and the hypotropia in primary position, we can we can plan the surgery. I would like to thank MOS again for this opportunity, and I'll conclude my presentation.
Nice case, Dr. Shilpa. Dr. Milind Killedar, your take on this, please.
I would like to have one small suggestion. When you are
Yes.
operating inferior rectus along with two horizontal recti, that is either Nishidas or NAP, whether it is modified NAP or normal NAP, please consider inferior rectus recession with vessel sparing, because you are doing 3 muscles at a time. Although rare, anterior segment ischemia can be a complication. So please consider inferior rectus recession on vessel sparing.
Yes, sir.
Dr. Shweta, are you there?
Yes, sir. So I have, yeah.
Yeah, your comments
yeah.
on it? Any questions on it?
Yes, I have 2 questions actually. One is, how long do you observe? Like, what would be the age till the child can maintain a head posture and continue? And secondly is, would there be any involvement, like doing the contralateral SR recession if the IR is not tight on FDT?
Okay, so if the child has good vision and stereopsies, no severe head posture, you can observe the child. Severe head posture, poor vision, amblyopia, and severe ptosis, all these things require early intervention.
Kindly mute yourself. Who is talking?
Can I ask one question? I'm Rushikesh.
Yeah, please.
My
Please,
camera
please.
is not working. Nice case, Dr. Shilpa. I wanted to know your experience with Nishidas. I mean, doing the inferior rectus and Nishidas for, vertical squint beyond 35 prism diopters. How are the results?
So yeah, I have done only when the squint is more than 30, both Nishidas and IR. I have not done for lesser degrees. IR with Nishidas, only I have done 3-4 cases. Only one cases actually went in hyper, but rest of them were cosmetically very good.
Good.
Yeah.
Dr.
Yes.
Siddharth, can
The
you?
results are quite encouraging.
Yeah.
Yes.
Good. Nice case.
Thank
Dr. Siddharth, are you there? Are you able to connect now? Dr.
Yes,
Siddharth?
Yes,
Yeah,
Dr. Valimber.
Yeah, please comment on it. Your comments.
So, nice case, and MED is always a very challenging case because you're not certain what result you will get. As Dr. Killedar pointed out, that 3 muscles when you are tackling, you might have problem with anti-segment ischemia. Recently, we have tried a few cases where we just transport one of the horizontal muscles to the superior rectus, just like your SRT to LR in Duane's. So we did that in few cases, and it gives equivalent results to NAPS. So I don't think that both medial and lateral rectus need to be transposed. You can transpose either medial rectus or lateral rectus, preferably lateral rectus. And if you are trying to correct the horizontal component also, then you can use the remaining muscle to correct that. So you can try this in your cases.
Yeah, even I have done one case where I have transposed only one muscle and there was no ET or XT, only the primary position hypo got corrected and the results were good.
Good, great. Nice inputs, Dr. Milind as well, Dr. Siddharth. Now we'll just go, for want of time, we'll go to the next case. Is Dr. Sheetal ready?
Thank you so much.
And Dr. Abhilasha is here.
She has got some connectivity problems. So,
Yes, I'm here. Shall I
Dr.
share?
Abhilasha, are you there?
Yes.
Yeah, just start screen sharing. First, open your presentation on your desktop or laptop and then start screen sharing.
Are my slides visible?
Not yet.
No, Abhilasha, not yet.
Second.
Yeah,
Yeah, it is visible now. Kindly go ahead.
make it full screen, but yeah, good.
So, hello everyone. Thank you for the opportunity. I'll be talking on when one nerve fails, dilemma in management of third nerve palsy. So, keeping one slide of background, that oculomotor nerve, we all know it supplies most of the extraocular muscles like superior branch and inferior branch. Superior division supplies superior rectus and levator palpebral muscle. Inferior branch supplies medial rectus, inferior rectus, and inferior oblique muscle. Considering a lot of extraocular muscles, there is a different permutation and combination when the patient walks in our OPD. And that's the reason we have to discuss that each case may present differently and one solution doesn't fit all. And we require individualized approach. So here will be a case series of 4 cases of third cranial nerve palsy with a very unique and different approach for each one. The first case is 15-year-old girl with ptosis and squint since childhood. On examination, right eye had incomplete ptosis. As we can see here, right exotropia and right hypotropia was there. Along with that, there was a little lid lag and inverse Duan sign was present. PCT was 45 exotropia with 18 to 20 L by R in primary gaze. As we can see, extraocular movements were right eye adduction and depression was -2 and elevation was -4. Visual acuity was 618 in right eye and 6.6 in left eye. Wrist anterior segment examination apart from ptosis was normal. So here we did, in view of aberrant regeneration, we did right eye modified Nishidas and left eye LR resection and MR resection. It was very, very difficult to counsel and convince parents that normal looking eye, we should operate on that in view of aberrant regeneration. So we did right eye modified Nishida, MR and LR towards SR. As we can see, post-op day 1, the eyes were nicely aligned. Coming to case 2, 4-year-old child with squinting since birth, we have a video and picture consent by the parents to share for the purpose of publication and presentation of academics. Uneventful perinatal history, no history of trauma, and never done imaging earlier, never done patching earlier. So we advised that visual acuity in right eye was 6/60. That means definitely there was amblyopia, strabismic amblyopia. A pupil was involved. There was anisocoria, anti-segment. There was minimal ptosis in the primary gaze. So we advised. So these are the videos. I can show one or two. So as we can see here, child is looking to the right. As looking towards the left, eyeball is going up. That shows tight lateral rectus. And there was a minimal lid lag as well. Ductions were also same. So I'll move to the next slide. Hirschberg was right exotropia and right hypertropia, 35 exotropia with 15 R by L. So here we advised neuroimaging. Until the time neuroimaging happened, we advised doing patching also. Child has very minimal refraction of +1 in the right eye. Intraop FDT was moderately tight for superior rectus. So we did go for the right LR recession, which was maximal, that is 12 millimeters, along with superior rectus transposition to medial rectus. And as we can see, this was the POD1. And this is the recent, I had put earlier 6 months old post-op, but this child visited recently. And she's nicely aligned even after 1 year. And the good part is her amblyopia is improving. So initially she was 660. Now with the alignment and patching, she is 615. And I think what else we need as a pediatric ophthalmologist. Coming to the case, 350-year-old male with complaints of drooping of left upper lid and no movement of the left eye. History presented with idiopathic onset, mostly ischemic origin, but we couldn't find any diabetes or hypertension on investigations. And hence we ordered imaging. Though age doesn't justify, but there was no systemic illness. Hence we ordered the neuroimaging. And there was 45 degree of left exotropia, as we can see. So on examination, vision was 6/9, 6/12, and rest examination was normal. On Krimsky, it was more than 95 prism diopters of exotropia. As you can see, eyes are as if wall-eyed and kind of strabismus fixus of the left eye. So for this patient, as eye didn't cross midline, we planned this split LR to MR, that is split lateral rectus to medial rectus. The first image is very oversimplified illustration. Coming to the next image, this is the above the globe approach diagram, and this is the below the globe. That is under the rectus and under the oblique also. And this is our own Dr. Saxena's article in the video. And as you can see, this was the POD 1 month and patient, and we all were very happy with the outcome. This is the last case, 4-year-old female child referred for the surgery with diagnosis of right eye congenital oculomotor nerve palsy. Rest perinatal history was uneventful. This is the primary gaze. Child had 636 and 615 vision in right eye and left eye. Rest examination, apart from ptosis, was normal. But the frontalis overaction was there, and mother mentioned drooping of other eyelid in the past. And whenever she has fever, it gets aggravated. Old photographs were seen, suggestive of full ocular motility. This is, at this moment, I feel like a Sherlock Holmes when we are going through their mobile. So patient had full adduction, and this was basically a case of ocular myasthenia gravis where we did that eyes test, and there was a weak trial of neostigmine test was positive. Hence, neurologist suggested that we should give a trial of prednisolone. And this is the child after 2 months of the treatment, where she improved nicely. So each case is different. Each case has approach is different. So third nerve palsy, this is the management. Congenital, it can be congenital or acquired, can be partial or complete.
Dr. Abhilasha, can you conclude, please?
Yes.
You overshoot your time.
Sure. So this is my last slide, that complete or partial. So how do we go that if ductions are past midline, we can do large recession resection. And if ductions are short of midline, then we can definitely go ahead with the transposition procedures. What I learned from this, that each case requires different approach. Always remember, mimickers like ocular myasthenia gravis are there, but let me humbly accept that satisfactory ocular alignment still remains a challenge for an ophthalmologist in third nerve palsy. Thank you.
Very nice bouquet of cases, Dr. Abhilasha. I congratulate you for that. Dr. Vaishali, madam, your comments on it? Any questions?
Yeah, at the outset, I should congratulate Dr. Abhilasha for wonderful cases and the various presentations. And I really sometimes just now we discussed about MED, and I find both MED and third nerve palsy to be so much complicated. We have horizontal deviations as well as vertical deviations, and managing each, like you have rightly said, you have to tailor-made it for each case. And yes, supramaximal and recession and resections do work very well. And like you mentioned also, periosteal fixations also helps a lot. So what I liked about the last case was that yes, we should keep in mind about ocular myasthenia also, that that confusion might be there. And amazed to see the senior citizen also having a total third nerve palsy. So congratulations, very nice presentations.
So much.
Yeah, Dr. Renu, your quick comment on it? For want of time, I think we'll go to the next case. That is the last case by Dr. Sheetal Lahane.
Not unmuted.
Yeah, very nice cases, Abhilasha. And of course, the last we already had ocular myasthenia discussion in the neuro session as well. So obviously that we need to keep in mind. Only one question was the third case which you presented. The patient, I guess, was a senior citizen, must have been for quite some time and had a complete ptosis. What was your, why did you operate the third nerve palsy when he had a complete ptosis? So why that decision of operating the patient?
Thank you for asking this question. I couldn't incorporate this. Believe me, patient said, he's suffering from this since 1.5 years. And after operating, so he went to 2-3 hospitals where he was denied surgery in view of fixed globe. So we decided to operate after explaining all the possibilities. And after operating, after 1 month, he said that my grandchildren, they get frightened to look at me or to come at me, and that's the reason I want to do this first, and then I want to lift the like lid also, and that is the only goal he has in his life. And I was like, okay, this is something enlightening for me also, that this is a very different purpose.
Something was done for the ptosis as well after that.
So we are planning for the ptosis also, because ptosis surgery is due. So it is just like a 3 months post-op. We operated in, I think, February, and definitely we are planning for the.
Yeah, good discussion. Good discussion. Now let us go to the last case by Dr. Sheetal Lahane. Dr. Sheetal, are you ready? Yeah.
Yes, sir. Good evening, everyone. Am I audible?
Yes, yes.
Please.
Yes. Visible and audible. Okay, ma'am. Okay. So I'll be presenting a case. Not moving. So 18-year-old female came with squinting of right eye since childhood. Her best corrected visual acuity of right eye was 6.6 and 6 with refraction, and left eye also 6.6 and 6. This was her pre-operative picture. Like we can see, right eye exotropia. On examination, Hirschberg was right exotropia. She had around 35 prism diopter of exotropia in all the 3 cases. In near, it was 40 prism diopter exotropia. Extraocular movements were full and free. Worthford dot test showed right eye suppression. So anterest, anterior and posterior segment examination was normal. So like a normal squint case, my surgical plan was right eye lateral rectus resection 7 mm with medial rectus resection of 5 mm under local anesthesia. Surgery went uneventful. So on post-operative day 1, this was her clinical appearance. Like her vision of right eye was 618. There was minimal exotropia on Hirschberg. Conjunctiva was well opposed and sutures intact. So on POD 7, on post-operative day 7, she presented like this. And patient complained of right eye diminution of vision since last 3 days. Her vision of right eye was 660, which was not improving further. On clinical examination, this was her slit lamp picture. Like we can see, dense DM folds and large epithelial defect. So my dilemma was, is this anterior segment ischemia or viral keratitis? Since this was definitely a first case of post-operative squint, which I have seen like this. So on examination, like we can see, there are dense DM folds along with that large epithelial defect. Anterior chamber was quiet. There were no iris abnormalities, and pupil was normal, central reacting to light, and pressure was normal, 14 mm of mercury. But corneal sensations were decreased. So like it basically, if pupil reaction is normal, there is no iritis and anterior chamber is quiet, it rules out anterior segment ischemia, and geographical ulcer, diffuse endothelial involvement and reduced corneal sensation, it falls into picture of viral keratitis. So cornea opinion was taken and she was diagnosed of having viral keratitis, geographic ulcer with diffuse endothelitis. So steroids were stopped. BCL was implanted and she was started on topical antivirals, antibiotic and lubricating eye drop. And like we were following her very closely. This is after 2 days, like we can see, defect is reduced and so as DM folds. So, topical steroid were restarted after resolution of epithelial defect. Slowly, steroids were tapered. Like this is the clinical picture. Here we can see total resolution of epithelial defect and DM folds. This is post-operative day 2 months. So there was mild stromal haze and her vision improved till 6-9 part. And post-operative day after 6 months, her best corrected visual acuity of right eye was 6-6 part with refraction. So then I went into review literature to assess the impact of strabismus surgery on corneal endothelium in children. There was one study which was done by Dennis et al. And they found out that strabismus surgery cannot result in statistically significant decrease in endothelial cell count. There was one case which was reported by Shetty et al. They reported a case of 33-year-old male who developed filamentary keratitis after undergoing uncomplicated strabismus surgery. There was one more case which was reported by Tasmin Berman et al. And they found bilateral herpes simplex keratoconjunctivitis following uncomplicated 7 millimeter bilateral lateral rectal recession in a 3-year-old child. So, what we need to keep in our mind is possible development of herpetic epithelial keratitis even in patients with no clinical history of disease, as we are giving steroids very frequently post surgery. So take home message is that viral keratitis is close differential diagnosis to anterior segment ischemia. Viral keratitis recurrence can happen irrespective of prior history. If patient has pre-existing corneal opacity, especially with vascularization, we need to doubly careful about recurrence of viral keratitis. Thank you.
Yeah, Dr. Sheetal, very interesting and nice case. Dr. Tejaswini Kirpekar, your comments and any question on it? Dr. Tejaswini?
Yes, sir. A very interesting case. I think for anterior segment ischemia, it's important to mainly focus on anterior segment reaction, hypotony, and pupil if it is mid dilated or irregular, which wasn't there in this case. But important to keep in mind that viral keratitis is also a possibility, even if no previous history is there in a patient.
Yes,
And in case of other infective etiologies, I think posterior segment involvement should be looked for. We should also, in
Fundus was
non-viral
normal.
cases, it was
Yes.
normal. Okay.
Yes.
Yeah, nice input. Dr. Shubha Zawar, please, your comments.
Sheetal, very nicely presented case.
Thank
So, other than corneal sensations, any other investigation that you would like to do to confirm this anterior segment ischemia, which is, of course, a rare complication in such a like a two muscle surgery?
Yes.
Else you would like to go ahead with? If suppose the patient presents with just corneal folds or DM folds like that. So I believe these days OCT angiography, OCT is being done to find out the iris blood flow, and that might, confirm your diagnosis. So that's it. And of course, you had a clear-cut large geographical corneal epithelial defect as well as reduced sensations. So as you said, very well said that yes, any pre-history of some redness in the other eye or the operating eye or some previous opacities and vascularizations of the cornea, we should be very careful. Yes, good presentation.
Thank you, ma'am.
Yes, good. So overall, it was a very interesting and good bouquet of all clinical cases. And I would like the comments and the concluding remarks from our chairman, Dr. Siddharth Kesarwani. Are you there, Siddharth? You're just left.
Yes, sir.
Yeah.
It was
So your comments and your concluding remarks, please.
Yeah, so it was a nice seminar because a lot of interesting and difficult cases were presented in a very small time, and excellent results people have shown. And like even in the last case, these kind of surprises after post-op are you need a lot of presence of mind to deal with it. Sometimes a similar picture with corneal involvement can happen if the bandage is not proper, and the child keeps the eye open inside the bandage, and next day the cornea is desiccated and epithelial defect is there, and
look scary sometimes. So, one of the important steps of surgery is to how to close the surgery. You put a proper bandage because many times all these corneal problems are because of an incorrect bandaging of the eye. Nothing more to add because everybody was very elaborate and gave a lot of explanation of their cases and good seminar.
Good. Thank you, Siddharth. Dr. Sunaina Malik, madam, your concluding remarks as chairman.
Particularly for Sheetal's case, or in general in all squint cases in children, I would recommend before you close, put in some ointment. Instead of just putting in drops, put in some ointment which will lubricate keep the eye lubricated, because children, you never know when they're going to rub the eye. The parents cannot keep a check on children all the time. So put in some ointment, then close the eye. So that it becomes a added precaution, so to say. When you open the next day, you're not going to get any unpleasant surprises. Hopefully not. But you never know with surgery. It's surgery. Anything can happen anytime. So very good cases, but all the presenters were excellent. And I think it's my good fortune to be chairing this session where such lovely cases have been shown. Thank you so much.
Just
Yeah.
one
Thank you,
remark,
madam.
because I have joined actually, I saw all the cases, but it really needs a heart of a lion when you see a case of slipped muscle on third or post-op day. So to face the patient, and as Dr. Prasad had said, that you have to be very calm and quiet. So it is difficult to be a calm and quiet, but you have to practice yourself. And we do get this, prevention is a better cure, but we do see some type of these cases, and all the cases were really very nice. I have seen all the cases, but couldn't comment on the first case on the Dr. Hemant Anaspires. Okay, sorry for that, and thanks for the opportunity.
Prasad, just one,
Yeah, please go ahead, madam.
Pretty long back, I think, I had a case where on table I realized that I've gone through and through the sclera because I could see the choroid while I was suturing, and I was horrified. I didn't know what to do, and it was a child, and my heart was in my mouth. Then, and I was hoping for the best, and I didn't know what to tell the parent, so I didn't say anything. I said, "Let's wait and see till tomorrow what happens," because it. And I realized it as soon as I put in the needle, and immediately I withdrew. And I was hoping against hope that nothing had happened. There would be no paralysis, nothing, no detachment. And I was very lucky that I escaped with nothing going on. But I tell you, these things can give you real sleepless nights. So, as Abha rightly said, you have to stay calm, know when to react, and when just to keep your cool. So, that's about it. We all face these problems. You know, say the only surgeon who has no complications is one who doesn't operate.
Yes.
Just I'll just make
thank
a comment in a lighter note. The moment you have a complication in a surgery, the next day when you see it, first thing you do is you tell everything to the patient. So what happens is then you stop worrying and he starts worrying. Otherwise, if you try to hide something, then you are worrying all the time and he doesn't know what is going on.
Yeah.
You share the stress.
Yeah.
Yeah,
So it
you
was
share
a
the story.
really,
You have to be point blank, take a deep breath, and tell everything to the patient. Okay, this is the problem. This happens rarely, but unfortunately, it has happened. Now let us focus on the solution. Let us not focus on the problem, and take them into confidence and do the needful. The problem happens when you are trying to, hide or something like that. Yeah.
Cover up.
Yeah, Siddharth, I'll just add one thing.
100% guarantee.
So,
That is also not good.
let me interrupt
You
everybody.
have to all the time
So
tell that
let me just stop.
it
So
will be
this is
corrected,
I'm so
but
sorry.
10%
Dr.
error
Abha.
I'm so
chances are
sorry.
there.
I'm so sorry. I cannot allow
Yeah.
anybody to speak
Okay,
anymore.
okay, yeah.
So thank you all speakers and
The
thank you all
problem over
expert
here was that
panels.
the session has gone too long. The solution is we have to move
Thank
to the
you
next
for
session. So thank you everyone for being over here. With this, we move on to the next session, which is a very important medico-legal session. And Aarti Hedia, my fellow young ophthalmologist, is the one who's going to run the show over here. So over to you, Aarti.
Thank you so much. So good evening, everyone. So without wasting time, let's talk about the medico-legal aspects in ophthalmology. So as we know that this is a very important topic and we are generally not taught this during the residency and fellowship. And we happen to learn this by our own experience. But now the scenario is changing, and we are very lucky that we have seniors with tremendous knowledge in this topic to guide. So I invite Dr. Anandesh Pandey sir and Dr. Prakash Marathe sir as chairpersons and panelists for this session. The other panelists are Dr. Manoj Mathur sir, Dr. Chaitra Jayadeva, and Dr. Himanshu Mehta sir. So welcome everyone. I now invite Dr. Nikhil Nasta to start with the first talk. He's going to talk to us about essential aspects of consent taking. Dr. Nikhil, you are there? So maybe till that time, we'll hear some comments from our chairpersons, Dr. Anandesh Pandey sir.
The thing is that the medical legal is not taught anywhere. I agree. But we have to learn it by experience, is actually suffering and learn. Instead of that, there should be some opportunities where we can learn it. And for that, we are thinking to start with the course is ready from the AIOS to start a course of my own medical legal certification course of the AIOS. And if that starts earlier, that will be a boon to the all doctors, because all conditions will be covered in that. And a medical legal knowledge will be given to all the people who are there in our AIOS, because that will be the AIOS activity, and that is very, very good activity where various speakers on medical legal will be speaking. Another thing is that there is a course now available, that is a executive MBA for hospital administration and management. And it is not the only hospital administration and management, but the medical legal and management. So that course is very, very good course, which is available for all the people, though it is a government university, that is the Maharashtra National Law University course, which is online and specially drafted for the doctors. And if we could do that, is very important. And we go experience with the conferences, and we go with this knowledge and everything. So I think the person is available now, and she is going to produce something. So I will stop talking.
Yeah, so till the time Dr. Nikhil Nasta gets prepared for his presentation, I am supposed to be second in the list, but I'll start this session. So at the outset, I would like to thank Dr. Sumit and team MOS for this opportunity. The topic today for discussion is how to handle the medical legal issues. We get in the medical legal problems due to factors, few of which are in our control and few are not, like perception of the patient, unrealistic expectations of the patient. When the patient starts comparing the outcome with someone else, poor pre-op counseling, and so on. Now, patients can send a legal notice through himself or through an advocate or a civil court, consumer court, MCI, state medical council, through police station, which is called as FIR, criminal court, which is called as warrant, or other agencies such as health services. Once you get the legal notice, basis of protection will be facts, circumstances, supportive documents, records, clinical references, and case laws. Now, facts that can be of help to you include fact that the patient attended OPD, got admitted, and got operated. Points that are not accepted by the complainant, but they are not supported by any document, and other facts that are supported by the documents and the hospital records. Now, court will also consider various circumstances like whether the patient has come of his own for planned primary treatment, or came as an emergency patient, or was referred from other hospital with complications, or referred to a higher center for second opinion, or whether the patient has come of his own because of complication or unsatisfied treatment at somewhere else, or if the patient has reached in a very bad condition. You cannot refuse a notice, because even if you refuse it, it will be taken as granted that you have received it. The importance of the notice is to inform you that something has gone wrong somewhere and there are some allegations against you. So it's assumed that you know that there are some allegations against you. If a patient or the advocate sends a notice, it is not mandatory to answer. Other notices can be answered with the help of medical legal consultant or an advocate, as we know that doctors are not well versed with the law. Now, if in case you receive a legal notice, first and foremost, do not panic. Just consider this as an opportunity to respond and resolve certain allegations which may not be true. Now, don't try to communicate with the patient directly, as this may backfire you. If you get a notice through police, talk to your lawyer and discuss what can be done. Now, highlighting the importance of indemnity insurance, inform your insurer as soon as possible and get the written acknowledgement for the same. Try to collect all possible health records related to that particular patient, like case papers, certificates, consents, time to time what patient or the relatives have given in writing, investigation reports, hospital records. This will help you make your case strong and put you at peace. Just remember one important thing. Under Consumer Protection Act, the doctor or hospital is sued for the negligence and not for the complications which are mentioned in the textbook. Now, under Consumer Protection Act, civil liability for negligence is different in solo practice and corporate. Why is it so? Because of the Supreme Court's decision, which says that whenever a patient lands himself in a hospital, private or government, his direct contract is with the hospital and not with the attending doctor or staff. Moreover, a patient does not know which of the doctors or staff will attend him. So therefore, the direct relationship is between the patient and the hospital. Now, the Supreme Court says the patient, once they are admitted to such hospitals, it is the responsibility to satisfy that all the possible care was taken and no negligence was involved in attending the patient. In fact, it is the hospital who engages the treating doctor. Therefore, it is their responsibility. So the doctor is giving his services to the hospital and the hospital is giving its services to the patient. So it's a triangle. So in such cases, even if the doctor is sued, he can be saved very easily. We all know prevention is better, cheaper, and predictable than cure. So it is very important to maintain medical records, take proper consent, proper OT notes, and good indemnity insurance. Please note that the complication is not the negligence, but not knowing the complication has happened, not taking proper step to rectify it, not referring or not taking help of proper specialist, leaving the patient on unqualified or underqualified subordinate is what is negligence. Now, just to summarize some take-home points, inform consultant or the insurer, your medical legal consultant, lawyer, and legal cell of the societies. Do not contact the patient. Prepare diligently. Check the health records, previous case laws, and so on. Do not blame anyone. So, well-prepared reply can close the matter at its root. Be thorough and meticulous. Take help of AIS legal team or seniors if at all you have to. So I would like to acknowledge my team here. Special thanks to Anandesh Pandey sir for sharing these few of the slides of this presentation. So problems are bound to happen. How we face them and how we overcome them will make us a better surgeon. Thank you so much.
Aarti.
So
Aarti.
Yeah.
Yeah, hi. I want to add one point if I can. Can I add?
Sure, sir. We will take Dr. Anand Deshpande's sir's comment for this presentation and we'll move on to your comment. Is that okay?
Yeah,
absolutely. Yes, of
So
course.
I will say this is an excellent presentation. Actually, you can be called as a medical legal consultant at present. And there is nothing which is lacking behind. Whenever the notice come, only the thing where you are working is very important. Whether you are a solo practitioner, whether you are in a corporate hospital or in trust hospital, that matters everything. From a criminal for criminal, it is just the same whether where you are working. But when you are working, when a case is in the consumer, that is totally different liability, and that is most important. And she has tried her best to reveal it nicely in front of you. Thank you very much, Varati.
Hello, thank you. Hello,
Thank you
hello.
so
May I say something? Am I supposed to say something?
Sir, we will come for your turn, sir, soon.
Dr. Prakash Marathe.
Okay, because my name was written
approve
in
this on
front of
this
your
topic.
talk. Okay, no problem. No problem.
Oh, so, I think I then
Yes.
I think I misunderstood. I was supposed to ask Marathe sir instead of Anand Deshpande sir. So
Yeah,
over
yeah.
to you for your
No,
comments.
no,
Doesn't
Deshpande,
matter. It
Dr.
doesn't
Deshpande
matter.
sir has said. So I'll take 1 or 2 minutes. I think it was the perfect presentation. And most of the times when the medical doctor gets that particular notice, people are getting depressed and they don't want to answer. Basically, not to answer is not a good thing. You have to prepare yourself. Getting a notice is not the punishment. It is not a crime. It is not that you have been awarded some punishment, but you get some time. But whenever you are answering to the notice, you have to write the perfect sequence. And one more important thing I'll tell you here, it is not the lawyer what you should appoint. You should appoint medico-legal consultant, medico-legal lawyer, the person who is doctor as well as lawyer. He's the perfect person, though he doesn't appear in the court because he's practicing most of the times. But if he's practicing in the court of law, probably he will present himself. Or if the lawyer is presenting, he should take help of medical legal consultant like Dr. A. Deshpande. So that is the important thing one shouldn't forget, because most of the nomenclature, medical nomenclature is not, it's not known to the lawyer. It is known to only medical legal consultant. And whenever such terminologies are used in the court of law, probably even judge and other lawyers, they feel that this is something little bit more complicated. What medical legal consultant is telling is probably correct, and probability goes in your favor. So that these are the precautions you have to take, and all the points were very well covered by Dr. Aarti.
Thank you so much, sir. So Dr. Nikhil, over to you for your comments, and simultaneously we'll start your presentation as well.
Thank you so much, Aarti. Thank you, Manoj sir, Anand sir, Prakash Marathe sir, for being here and for your valuable comments. I'm sorry I joined in 5 minutes late. I had a glitch in the Wi-Fi. Aarti, recently I had operated a cataract patient in a case of retina. तो guarded prognosis लिया था, सब किया था, everything explained, surgery went beautifully, but they were unhappy and they sent me a notice. ठीक है? And in the notice it was written that nothing was explained and I've lost my vision. Now I knew that this is something for defamation, so I contacted my lawyer and I sent a notice back and I filed a case on them for defamation. And I not only had a good settlement, but it was a loud and clear message for everybody that you cannot mess in this way with a reputed doctor. क्योंकि ये बहुत होता है. They come, they sign everything, and then they come and sort of intimidate you, threaten you. So मेरे lawyer ने बहुत अच्छा मुझे दिया था. I'll just share it with you. उसमें लिखा था कि everything was explained. These are the consents. This is everything. And now neither you nor your family, not now, not in future, not ever, will be liable against Dr. Nikhil or his family members or associate doctors or his hospital. ऐसे उन लोगों ने एक बहुत ही concrete and exhaustive summary बनाया था. And then we had filed it, and they then came to us for a settlement कि नहीं जाते court में, we'll do an out of court. We did not agree for that. And that's how we literally scared them off, because why should doctors always be scared? So I always feel, and I want people to understand that your best friends will be a lawyer and a CA. So we must make good friends with people from outside our community as well. White coat ko black coat bachayega. What do you all feel, Dr. Anand? What do you feel? Sir,
There is now in Consumer Protection Act a special provision clause is there in which you cannot put like these clauses which are against the consumer. So this is called as a clause against the consumer. You cannot say that you cannot do anything, you cannot that anything and take it in writing, because that authority is with the district, state commission and national commission to remove that clause and make it null and void. So that is of no use in actually the consumer courts. Neither it is useful in the criminal courts also. Criminal code now 101, 106(1). There is a special provision for RMPs. RMPs mean all doctors who are registered under the Medical Council Act. So there is a special provision. If you take a best consent, informed consent, you are neither liable for anything criminal activity nor even the death. So that is more important, to take a consent which is informed consent, and that should be with the thumb impression also, because patient can deny his signature. And secondly, it should be under the surveillance of the camera, so that they cannot say that it was not told to us.
Agreed. So with that, can I go on to my topic, which is on consent?
Please, with
Okay.
without any
I will
delay.
share my screen now.
Yeah.
Okay.
Yes.
Can
we have the
are you-
timer? Someone is there from the numerotech, if in case. Yes, Dr. Nikhil, your presentation is visible. We are good to go.
Okay, so I'm talking about essential aspects of consent. I recently completed my IIM from Indore, in which all this consent and law was a special, a whole session for us of 3 months. Okay, so I cannot reiterate the importance of that. The objectives of consent will be to understand the legal and ethical importance. The topic we're discussing is to understand the legal and ethical importance of informed consent. We want to recognize the key elements of valid consent, to explore the practical challenges and the best practices in obtaining consent for ophthalmic surgery, and to discuss emerging concerns like AI, digital consent, language barriers, and other things. Why is consent so important? Before I start my presentation, I'm supposed to ask you, can I begin? Can I ask you a question? That's an implied consent, right? When a patient walks into our cabin, we just start touching them, everting their eyelids. We can't do that. Although they have come for a checkup, we need to explain to them, sir, I'm going to touch you now. Sir, I'm going to evert your eyelids now. Sir, the machine will come close to you now. We keep talking to them. These are also forms of consent, right? So consent is very, very important. It's a legal safeguard for patients also and for the surgeons also. It's an ethical obligation. It's a respect for patients' autonomy. There are medical council guidelines for consent, and consents prevent litigation, like sir was highlighting, and it improves the trust also कि मैंने आपको सब बताया है, consent लिया है और फिर ही मैं procedure कर रहा हूँ. So what constitutes a valid consent? There should be a full disclosure. Full disclosure of what is the procedure that I want to do, what are the other procedures which are available, alternatives क्या क्या है, इस procedure का benefit दूसरे के क्या है उसके options, tell them the pros and the cons, explain to them the risks. Do not try to oversell, try to tell them the facts, but don't scare them also. They can be alert but not alarmed. So you tell them, and if they ask you, you can also give them some statistics, but don't make false promises or false claims, or use words like best and wow and things like that. Give it a very doctorly, objective sort of a feel. Then capacity, the person who you are explaining the consent to, they should be mentally competent to understand this consent. If it is a child, consent to valid ही नहीं है, the guardian or the parent has to consent for them. If it's a person with a little mental incompetence, then you need someone to sign for them. If it's a very elderly person who's not in his senses, तो भी आपको कोई जिम्मेदार इंसान चाहिए जो वो consent sign करेंगे. Then there should be voluntariness. You cannot force them to sign the consent. ये पेपर है, आप साइन करिए, फिर मैं ऑपरेट करूंगा. ऐसा नहीं हो सकता है. It is not a form. It is a proper procedure, right? एक डॉक्यूमेंट है. तो आप उनको वो देंगे, वो पढ़ेंगे, फिर उनके मन में सवाल आएंगे. They will ask you all that, and then only voluntarily they need to sign it. They should understand. So you must ask them, if it's in English and they are of another local language, explain in the local language or get a translator and make sure they have understood what you are trying to tell. Okay. Sometimes even a simple thing like you tell your peon, go get me water, and he may not get it. वो होता है ना miscommunication. So in this, there should be no miscommunication. It should be crystal clear what you are saying in your consent form. It should be proper form on your hospital letterhead, which should be signed and dated. It's a good idea to give the consent a day earlier कि आप जाके पढ़ के sign करके लेके आइए. That is also a practice in many places. Now, unique challenges for ophthalmic surgery is that we are a special sense organ, and we have things can go very wrong and they can have very emotional impact because it's the vision at the end of the day. There are complex surgeries, so you must have a risk benefit discussion with them, like guarded prognosis, nil visual prognosis, or need for glasses after surgery, or need for putting drops after surgery. Everything should be very well explained to them. If you are doing under a sedation or a GA, तो वो भी आपको समझाना है. Pediatric and geriatric cases have some. Everything should be explained very, very nicely, slowly, and that they comprehend everything. Another challenge with ophthalmic surgery is it's usually a bilateral surgery, right? So during the second eye, they just sign it without even understanding. You remind them again. Same risk is there for this eye also. Not that the first went very well, so this will also go very well. They are individualized. Things can go wrong here also. So this is a separate operation completely, and it can have a permanent effect on their vision. Special consideration, like I told you, for people with cognitive decline, dementia, parental consents, when there are language barriers, avoid very hi-fi medical jargon and make it a little simple. But it should be meaningful. It should not be simple कि उसका meaning ही escape हो गया. If they are low vision patients, then you can do an audio, explain to them in audio, use a large print. And like Sir was telling, it's also good to have a video consent, record your consent sometimes, you know. Now, what are the essential aspects? Same what we spoke about. It should be comprehensive. It should give them alternatives. It should explain all the pros and cons and everything in great detail. It should be an informed consent. It should be tailored to your procedure. There'll be a different consent for a multifocal, different for a monofocal, different for a retina. Your communication style is very important. तो आप उनको intimidate नहीं करोगे, casual भी नहीं होगे. You will put in facts, let them brood over it, come back. Documentation should be very thorough. NABH we have, so we have a very thick form. वो आपको देखना है. Consent is at the end of the day a process. It's not a form. Special, just few more seconds. Special scenarios like we use off-label use of anti-VEGFs, right? Clinical trials we do. They will need a special consent. Now, informed refusal. Patients have a right to decline their treatment. Then you write properly कि patient has refused, just like you do a dharma. तो वो आपको सब लिखना है so that ethical and legal issues are not there. In digital era, AI era, you need consent for putting their posts on media, putting their pictures, putting their testimonials, or any data privacy concerns that they have. Okay, whatever you click belongs to your hospital, and you ideally can use it. But उसमें भी थोड़ा gray zone है. I'll ask Dr. Anand sir to just highlight on that for us. And these checklists you got to do. So the takeaway is that we can discuss real world dilemmas in surgical consent, and this is a consent form link. Actually, I don't know how to share it with you all. I'll put it in the chat box, but this has all languages, all procedures ka ophthalmic ka consent. This is from the AIOS. I'll try to share it here. Okay, thank you so much.
Thank you so much, Dr. Nikhil. Anand sir, would you like to comment something in a minute?
The thing is that we have published a booklet of consent, and it has been transformed in many languages. So better to follow that. They are best the consent forms. You can read to the your computers, get it printed out, and if they are in own languages and get the side. Secondly, the clinical trials, he said, it is not sufficient to take the consent for the clinical trial. For clinical trials, so many things are there. There are so many committees, there are so many departments through which clearance should be there and permission should be there. You should be valid for that. Your hospital should be registered, and that should be valid for the clinical trials. And there is so many complications. Even we can put a lecture on this in UC. That much is there. So with this, I will finish my comments.
Thank you so much, sir. So next, I would like to invite Dr. Dipanshu Agarwal to give a talk on Insure to Assure, the role of professional indemnity insurance in practice. And to comment on this, we'll invite Dr. Manoj Mathur, sir. So over to you, Dipanshu.
Am I audible and visible?
Yes, you are.
Thank you, MOS and Dr. Sumit, for giving this wonderful opportunity to present in this Moscon Mid-Term conference. So my topic allotted is the role of professional indemnity in practice. Why should we be insured to stay assured? So in today's world, basically, why are we so burdened while we are practicing? But there is certain burden which we feel because
the cost of technology is very high in today's medical practice, specifically in ophthalmology. There is increasing competitive environment and social demand with respect to the treatment that is being given, that is being done, and there is a progressively high pressure to lower the cost to consumer as well. And in order to keep the cost down, there is tendency to do as many surgeries as possible. Somewhere in between these, we'll end up doing some complication, or there is some unwanted complication that takes place, and doctors land up facing a medical legal lawsuit. Before diving into the professional indemnity specifically, I would like to highlight few cases that have been filed against the doctors, and that will help us in understanding that what is the magnitude of these cases and what all for what all reasons the cases can be filed for. So this case happened in Madurai in 2018, where 66 cataract surgeries were operated in private hospital, and 61 patients lost vision due to following cataract surgery due to development of endophthalmitis. And compensation of total of 22.5 million was awarded for the victims. And the remarks given by the Honorable Court was that there was no approval to run the hospital. Consent was to operate was not taken from the State Pollution Control Board. There was no proper design and maintenance of the operating room. There were no anesthetist, pharmacist, or facility to pre-operative laboratory test. No formalin which was intended, despite it being out of stock. So these were the remarks given, and that's why the compensation was awarded to the victims. In another scenario in Kurja, 35 years back, a total of 88 eyes were operated in a mega camp surgery, and all eyes developed endophthalmitis. Government awarded a compensation of nearly 17,000 back then, and the remarks given by the court was that there were only the qualified experienced ophthalmic surgeons should be registered with MCI, should be operating, and the camp should not be used as a training ground for postgraduate students. There should be a pathologist available to examine preoperatively, and all medicines to be used should be of standard quality. In another scenario, in cornea subspecialty, which the case was filed in Delhi in 1993, there were post-operatively, doctor had advised mitomycin C, but unfortunately, doctor did not mention for how long the patient should use it and what should be the dosage, and patient continued to eventually lost the vision. A 50,000 compensation was awarded because of the only limited medical negligence that was seen in this case scenario. In another scenario, as we have seen that retina has seen a very steep rise in medical legal lawsuits, ROP being the subset where a lot of medical legal cases are being filed because of the negligence. So in Chennai in 2015, the case was filed against the government hospital pediatrician as they failed to inform the parents about ROP screening, and it was detected later in few months that patient developed stage 5 ROP. A total of 1.8 CR of compensation was awarded, considering the past medical expenses, future medical expenses, and the compensation for mental agony and annual interest from the day the child was born till the day final compensation was awarded. In another scenario, where in Hyderabad, where patient developed endophthalmitis following Avastin injection, 5 lakh of compensation was awarded, and remarks given by the Honorable Court was that it's a single-use vial without preservatives, and gross negligence was administered off-label. It was labeled off-label. So, a compensation of 5 lakhs was awarded in this case. In Ernakulam in 2016, 9-year-old child underwent squint surgery, but patient subsequently expired in ICU. The remarks given were the routine consent, and it was not a really informed consent was taken. Abbreviations used were inappropriate, and full terminologies should be used while mentioning the data in the notes post-operatively. Another scenario in Panipat, where patient developed intraocular hemorrhage, complainant finally lost his vision, but 35 lakhs of compensation was awarded. Delhi Medical Council and Medical Board formed by Maulana Azad exonerated the doctors, but court disagreed with both the reports, and compensation was awarded. In another scenario, I'll skip the few of the scenarios in want of time. So, in another post-cataract surgery, a coolie was not explained the proper post-op care, and he developed corneal injury while working in the field. So a compensation of 55,000 was awarded, and the court remarks mentioned that the patient should have been instructed the post-operative care and follow precautions, but the medical record were devoid of such instructions. So we can see that it has ranged from 1,000 to crores, and the compensatory amount can be very high, and therefore we need indemnity insurance in current scenario, and it is a must. We should not avoid it. So we did a survey a couple of years back, and when we asked the respondents that how many of the respondents were aware of the entity called professional indemnity insurance, only 82% were aware of it, and out of that, only 54% were actually possessing the indemnity insurance. If we when there are multiple companies, there are two aspects to it. That one is the insurance company that provides the amount that is being awarded by the quote to the patient, that is being compensated by the insurance company. So when we ask the respondents, ICICI Lombard and other United India Insurance were the most preferred. Other insurance companies were National Insurance, Oriental Insurance, and others. Another aspect to is legal service providers. These companies basically help you in getting to the lawyer, doing all the paperwork on your behalf. They charge a minimal annual fee, which is less than the insurance premium. And out of these, the famous or the predominantly acquired ones are the AMC, IMA, Apex Consultants. Others are MOS, MEDEF, and Medico. So we can take help of these companies, and you can actually continue practicing without wasting time in running behind the court paperwork. When we ask the respondents,
can you
was
summarize
about to finish. Yeah. Ideal amount of legal or insurance cover of the respondents, what should be the more than nearly 50% of them said it should be more than 1 CR or more. It should be ideally 1 CR or more. So, Consumer Protection Act, in its definition, had excluded a free service from purview of Consumer Protection Act. Honorable Supreme Court decided that the doctors providing free service also would be covered with the purview of Consumer Protection Act. This decision has never been reviewed thereafter, and implications of free medical and ICAMs are being realized belatedly and very slowly. Recently, there is increase in number of cases, and there has been an exorbitant penalty. So I would like to conclude by saying that counseling and consent is must. Clear instructions should be given pre-operatively as well as post-operatively. Documentation is the key. Even if you have not said it, if it is mentioned in the file, that will probably save you in the court of law. And a good indemnity cover is very a must in today's scenario. I would like to thank my team and also the senior panelists for giving me this opportunity. Thank you.
Thank you so much, Dr. Dipanshu. Over to you, Mathur sir, for your comments.
Yeah, Dipanshu summed up nicely, giving instances of various instances where compensation was awarded by the court. What is important for us to know, like if you are an active surgeon, the most mandatory thing that is required in the current day scenario is to insure yourself adequately. You are supposed to provide medical aid to the patient, and the like insurance companies will protect you. What happens is, like if you have a good professional indemnity cover, immediately the moment you get a notice, you can approach the broker, and they allot you a expert panel. Expert doctors consultation is very important before to set right all the documents in order, and then the role of the good lawyer comes, which the company provides, and this gives you that kind of a protection, that kind of peace of mind whenever you get a notice. What is also important is that the hospital, wherever you are working, you must have your individual indemnity, and the hospital should have its own indemnity because of the vicarious responsibility the hospital has towards the thing. Like if something goes wrong, even the hospital is responsible because you are working for the hospital and the hospital has employed you. If something happens to the patient, both the hospital and you are important. So a personal professional indemnity, the hospital indemnity, and nowadays the social media intimidation, the defamation that one has to undergo by if something unforeseen happens, that also needs to be taken care of. There are some policies where even the social media intimidation is also covered. So all in all, you need to have a good and proper professional indemnity. And in this aspect, AIOS has come up with the policy of AIOS Suraksha, which provides all these three covers at a basic minimum rate. And for doctors who intend to have their professional indemnity separately and not as a group, for example, with AIOS Suraksha, like AIOS Suraksha rates are almost 1/4 of what you would pay if you take that policy individually. So what is important for you to know, like one company may come and offer you a X rate, other company may come and offer you a Y rate. The whole thing depends on two aspects. AOY means any 1 year, AOA means any one accident. a particular company may say, for 1 crore, I give you the premium of 10,000 rupees. AOA is 25%. That means even if you are having a 1 crore indemnity cover, for one accident, you are entitled to only 25 lakhs. That is the reason why the insurance premium is less. Whereas another company, they will say AOY 100, AOA 100. That means if you have a 1 crore indemnity cover, you are entitled to 1 crore cover even for that one accident. So these are the things that you need to understand before you finalize your insurance indemnity, both for your person, and if you are a eye care center owner, you need to have a separate hospital indemnity for yourself. Nice summary, like Dipanshu gave different instances where the compensation range from just 15,000 rupees to even 1.8 crore rupees. So all the proper documentation, the proper medical legal expert help, and a proper legal lawyer help is very essential. And as far as AI Suraksha is concerned, we have a panel of 500 medical legal experts all over the country who are ready to provide immediate help to in case of a, God forbid, any eventuality. And after that, the AI's Cover You has a panel of 10,000 legal experts from High Court to Supreme Court level, and they provide 10,000 experts, and you have a choice to select your own lawyer also, and they give you adequate cover. And for your peace of mind, you absolutely need a good and proper indemnity cover, both for yourself as a personal indemnity, and if you're a eye care center, a insurance cover for your hospital.
Thank you so much, Mathur sir. So next I invite Dr. Kaushik Tripathi to talk to us about how to respond to a legal notice. Over to you, Dr. Kaushik.
Thanks, Dr. Aarti. Thanks to the MOS leadership team for having us here. Very nicely organized conference. So I take this opportunity to thank our mentors, Dr. Anand Deshpande sir, Dr. Manoj Mathur sir, and Dr. Prakash Marathe sir, who have been guiding us from the beginning. So I am grateful to my colleagues, Dr. Aarti Heda and Dr. Dipanshu Agarwal, for all the things which we have done together. So I'll discuss why this legal notice can come, who sends legal notice, and what is there in legal notice, and how to respond. So why do we have legal notices? Because what you do doesn't matter, how the patient perceives you matters. Like, patient's perception about you should be correct, and if there is a mismatch of expectation to result, if I have over promised and under delivered, then there is a problem. If the patient compares with the other eye, with the other surgeon, if the patient thinks that you have a lack of compassion, and if there is a poor chair time before surgery, and there is professional jousting like this doctor, who we are like wrestling among ourselves to show ourselves superior. So that creates a conflict, and that actually makes the person make a case against you. So they are mostly, there are optometrists or ophthalmologists who actually suggest the patient to file a case. So how do you prevent? You have to prevent with care, compassion, competence, communication, courage, and commitment. So who can send you a notice? An individual can send, which can be a patient, a lawyer, regulatory bodies, including medical council, other statutory bodies, including clinical bodies which have been established by Clinical Establishment Act, and courts, various courts, including consumer courts. So they can be sent by email. Usually they come by post, and there is a deadline for you to respond. So how do you respond? So there are few terms which you need to understand. Patient is complainant or plaintiff, or victim or claimant. Doctor or hospital is called opposite party, or OP, or accused, or respondent. Complication, we have to understand that complication or failure of therapy is not negligence. Negligence is when the standard care is not followed. How do you respond? You should not panic. You should try to respond and resolve. Stop any communication with the patient, because this can be used against you. So avoid out of the court settlements, because it shows that you have done some guilt, or you have done some wrong. Talk with your medical legal consultant or lawyer. As Prakash sir suggested, medical legal consultant is always better. And it matters whether you are a solo practitioner or a institutional practitioner. If you are solo practitioner, then the liability is on you. But if you are working in an institute, the liability is primarily with the institute, because The agreement of the patient is with the institute and you are just providing service. How do you respond? You have to notify the medical indemnity insurer in writing as soon as is possible. You have to get receipt of the communication. As Manoj sir said, we have AIOS has a good plan. AIOS Suraksha EOC is also providing to its members a very reasonable plan, which is in association with Policy Bazaar. You have to collect health records, indoor papers, case history, OPD papers, investigations, consent. Do not manipulate the data, and you have to consult lawyer and medical consultants. We have a EIOS legal team, as you have seen Dr. Anand Deshpande sir, he is chairing that thing, and you can contact him. He is very approachable, and be thorough and meticulous. You can get a written opinion from independent senior ophthalmologist. You have to mention that standard protocol has been followed and there was no negligence or deficiency of service. These terms are very important. So this is the medical legal committee, and all of the seniors are very approachable. Whenever you are in trouble, you can actually contact them, and they have the positive goodwill to solve your problem. So you can take a screenshot of this. And how do you respond? You have to respond point wise. You can agree or deny to the points. Be constructive and positive. Do not blame. Do not be in a blame game. Be prepared. And if your reply is very well prepared, then it can close the matter at its root. So take home points. Whenever you get notice, consult your insurer, consult medical legal consultant. Try to contact AIO. You can contact AIO's legal team. Do not contact the patient. Prepare diligently and keep all the records, because sometimes the records can be stolen also. So I take this opportunity to invite you all to the EOCCon 2025 conference, which is happening in Delhi, India Heritage Center, from 5th to 6th September 2025. And we have been doing this kind of webinar on various medical legal aspects. You can scan this QR code and you can visit our EOC YouTube channel, which is YouTube EOC. And we have already conducted 31 webinars on various medical legal aspects, and you can get good insight from that. Thank you.
Thank you so much, Dr. Kaushik. So Dr. Chaitra was not able to join us for some personal reasons. So we'll move on to the last talk, and then we will take the discussion. So I invite Dr. Manish Sharma sir to talk about tackling assault against doctor.
Thank you so much, Aarti. I'll share my screen. Am I visible?
You are, sir.
All right.
You can put it on the slideshow mode, and then
Yeah. Okay. Is that okay? Am I seen well? All right. All right. Good evening, everybody. So I'm going to be talking about tackling assault on doctors. As we all know, this is a big problem, and I'm sharing some data given out by IMA, which shows that almost 50% of us are fearing violence, and that is causing so much stress in the community. And almost 1 in every 4 of us fears being sued for this. So it's a big problem which we need to recognize. The causes of violence, well, mob mentality, low literacy about health issues, great vulnerability of the small and medium healthcare establishments, poor communication on part of us sometimes or the staff, and a proper lack of security are the main causes of violence. This does have a huge impact, basically by means of increasing stress, reducing our confidence. Subsequently, we can increase errors and eventually leading rise to financial losses as well. So typically what we try to do is we need to provide an actionable protocol so that we can prevent this. And if at all this unfortunate incident is to happen, what do we do to respond to it? How do we tackle it? The primary thing would be to have a lot of security. So we need to ensure that we are employing trained security personnel. There should be a restricted access to sensitive areas like your operation theater, like your the place where if there is a death or something where the body is kept, those areas need to be kept separately, and we need to have regular security audits as well. Now, there's something interesting I'm sharing, which people in Mumbai would know. The Association of Medical Consultants had partnered with an agency called as TOPS. These people would, within 8 to 15 minutes of being contacted, send out security personnel who would come to you on a bike. So you would be able to get access to security within 15 minutes. Having something like this all over Maharashtra, maybe, or all over India would be a fantastic idea. We need to have excellent surveillance. That is by means of installing CCTV cameras in critical areas. There are some places where there is a panic button system. I have a friend who has, he has buttons. When he presses that button from his cabin or from the ICCU, directly the security who are there outside the hospital are alerted and they're able to come into the hospital. We also need to train our staff and document any untoward incidents properly. Also, wherever we are installing security TV cameras, we should be displaying boards which are prominent, which say that you are under electronic surveillance. A lot of times, putting out boards like this is a deterrent to the untoward incidents happening. People are aware that they might be trapped and later on be made accountable for the same. One very important thing next is to have thorough insurance. Now, this just does not mean your indemnity insurance. We need to have a good amount of indemnity insurance policy. We need to have group accident and life insurance for us and the staff as well. We need to have hospital property insurance, which should include vandalism, and we should have coverage for legal assistance as well, so that we are completely covered on all aspects. Well, what are the safety protocols? If we are dealing with difficult cases, it's a good idea to be working as a team. We should be avoiding arguments and confrontation with the patients and relatives. If there are any threats, we should escalate it to our colleagues or to higher authorities in the hospital. And we should always maintain an emergency contact list on our phone as well as on our desks, so that in case we need to contact them, we are able to get to them as soon as possible. So these helpline numbers, which should include something that is called as a rush team contact, which I'll talk about, local police numbers, your legal aid services and medical association numbers should be handy with your reception as well as with you on your tables. Okay, now another good idea is to have a local rush team. This is something that we have done in Indian Medical Association Chembur, the local area where I practice. We have a rush team which has 10 people, and most of these people are senior colleagues. And if one of them is contacted by us, they contact the other 9 people, and all of them try to rush to the spot where the untoward incident has happened. In fact, what we were told was that it's a good protocol in the event of a death that we declare it once this rush team has arrived, so that they are also able to talk to the relatives and try and diffuse the situation. Another important thing for this is that the main talk should be done by the doctor concerned. The rush team is present there and they interfere only if the communication is taking a wrong turn. And how should we behave? These kind of situations are very, very stressful. So it's important that we present a calm and caring attitude. We do not match the threats by giving more threats. We do not order the patients around. We should be sympathetic, acknowledge their feelings, and avoid any kind of behavior which may be interpreted by the patient or the relatives as aggressive. If they are coming close, we should stay back. And if they're agitated or aggressive, it's better to stay an arm or 2 arms length away from those people. Kaushik sir is smiling. I think it is important, sir. We need to watch out for verbal cues. Whenever we are having somebody, these could be raised voices, swearing, threatening tone. Sometimes it's the body which is giving us signs, clenched face, heavy breathing, pacing, giving us fixed stares, aggressive posturing, a sudden change in behavior. And sometimes there are relatives who come intoxicated. These are really dangerous. So they can, precipitate an assault. Now, if the event happens, what do we do? Well, it's extremely important that we click photographs before anybody messes up with the site, because this evidence is going to be important for us to submit to the police as well as for insurance claims, and if there's a court battle there as well. We need to have a medical response protocol. If any one of us is injured, whether it is the doctor or the staff, then they need to be attended to. And all of these injuries, this has to be done at another hospital, not at the primary hospital, because otherwise they will, consider it as a conflict of interest. And there has to be a proper documentation. All the clothes, treatment records, as well as photographs that have been taken need to be documented. And we need to have what is called as injury certificates medico-legally, wherein there is a proper certification. And if possible, the police personnel who's at the site also countersigns the injury certificate. Another very important thing is to avoid politicians. A lot of times, these people bring in
Sorry to interrupt,
politicians.
Manish, sir. Can you summarize in a minute's time?
I'm finishing, Priya. We need to avoid politicians as well because they, in fact, insist the mess. Do call the police. Do not give any kind of DC. Insist on a post-mortem if there is a death. I've already spoken about this. This is the Maharashtra Medicare Services Act, which we need to keep copies of us with and share with the police if required. We need to be wary of the reaction of the police also. If they are not registering an FIR or arresting the culprit, talk to the higher authorities. Seek legal help, extremely important. AMC and IMA, they are often able to help and guide you in this. I'll run through this. So once again, once the event has happened, please do not, issue loose statements. It's better to issue formal written statements, notify your associations, and have a designated spokesperson to talk to the media. So these are the do's and don'ts. Stay calm and composed, be alert, document everything, inform management, file FIR. Do not retaliate the threats. Do not retaliate physically. Don't delay the FIR. Don't share unverified information, and do not confront the relatives alone. Institutions should be supporting in these ways, having SOPs, train regular staff, form crisis team, and liaise with the police station. Medical associations can help a long way, which I have stated further. So all in all, we also need government to do something for us so that there are reforms which desist people from doing such things. I'll skip this. Finally, prevention is critical. Legal, administrative, and emotional support is essential, and institutional readiness can save a lot of lives and careers. Thank you, Aarti.
Thank you so much, Dr. Manish, for a very informative talk. Do we have with us Dr. Himanshu Mehta, sir?
He's there. I just saw him. You just stop sharing, Manish.
Yeah, I'll do that, sir. Yeah.
So, Himanshu, sir, if you're there, we would like to take your comments.
Good evening, Chief.
I think sir is not able to join.
He was.
Maybe
He
so.
was.
Yeah. So I'll invite Dr. Prakash Marathe, sir, to give the closing remark and also comments on Dr. Manish and Dr. Kaushik's talk.
I think all the youngsters, they have been doing wonderful job in medical legal committee and medical legal aspects in ophthalmology. Basically, this was the neglected topic over the years, and most of the youngsters were not taking care about this particular aspect. But coming to the present scenario in medical practice across the globe, in India, Maharashtra, and many more places who have been experiencing this particular violence issue and not tackling the aspect in a proper way by medical profession also. Doctor-patient relationship has gone so much of problematic, is becoming problematic everywhere nowadays. So you have to be careful. What Manish has told in his talk, at Pune also we have been doing this. We have formed the rush teams. At various parts of Pune, there are WhatsApp groups where that particular area doctors are connected with each other. And whenever such untold incidents happens, probably that WhatsApp group is given that particular message. And we try to connect with the local police authority so that they also can be added in that group. And if something happens, probably they know the incidents. And about breaking the news, what you have talked about, probably that's very important. Senior doctors, they play important role. There are medical legal experts like Dr. Jayan Navrangi, who is there in Pune, is helping a lot. People like Dr. Deshpande, they are there everywhere across the state and across the country. Probably we should take help of those people. AIOS has been doing wonderful job. Even MOS has been doing wonderful job. And each and every city has to take care of this particular aspect. It is not only consulting practice and surgical practice and investigations and doing your own practice, sitting in the ivory tower and saying that I am very safe, I am very clever, and I am very sincere. I am not going to face this thing in future. The days are gone. You have to face the reality, and this is the sad part of medical profession, which everybody has been facing. You have to be careful. I think handle with care. That should be your mission. And be careful. You must be united under the banner of Maharashtra Ophthalmological Society, IMA of the local branch, then the state branch, even headquarters. They have been working on this issue. And this particular Maharashtra Medicare Act, what Manish was talking about, probably was passed in the past in the Maharashtra state. But probably other professions like lawyers and even police and government officials, they were expecting the same law to be applied for them. which was not possible for the government. So government is not taking this law to the central level, and it is not getting passed. IM is after them to pass this particular law at central level. And if it is getting passed, probably it will be very helpful to all the medical profession. I think it was the wonderful presentation by all the presenters. And I'm very happy to see that youngsters are coming forward in the form of UC and MOS. And this form, MOS has given the opportunity to youngsters to present. And we are there just as observers, moderators, and few comments are being taken by us. Thank you. Thank you so much for the opportunity.
Thank you so much, Marathe sir. We have 3 more minutes, Dr. Piyush. Dr. Manoj sir wants to comment.
I just want to announce one thing. Dr. Deshpande sir raised the issue of medical legal course. It is all prepared and all the 10 topics are prepared, and we are new to finalize a few speakers. So now currently the finance management course is going on behalf of AIOS. Another two and a half months time. Once this course gets over, then we are going to start the medical legal certification course from AIOS. So I am sure under the guidance of Dr. Deshpande sir, this will be a good platform for all the AIOS members to get to know in detail about all medical legal aspects and obtain a certification from AIOS. Thank you.
Thank you so much, sir. And thank you, Deshpande sir, Marathe sir. So nice to see Kaushik and Dipanshu, Manishal sir. So we have Namrata Sharma madam also joining in. Welcome, madam. And Viral sir, are you there? Dr. Viral?
Hello. Yeah, good evening, please.
Yeah, good evening. Good evening.
Welcome, Namrata Sharma madam.
Thank you. Thank you so much, Dr.
We will move on to the next session, which is going to be
Piyush, just 1 second before that, you all thanked everybody. I think on behalf of all of us, a big thank you to all the office bearers of MOS, and to you and to Sumit for doing such a wonderful job. Thank you so much.
Thank you, everybody.
So much, Piyush. Over to you for the next session.
Very nice session. Thank you, everybody.
Thank you, sir.
So, Namrata madam, if you can rename yourself on the.
Rename myself. Okay.
Yeah.
Good evening, madam.
Of course, man, nobody in the civilized world in ophthalmology needs, the moment madam's picture face comes in, we know who she is. But depending on the link, पूरा नाम नहीं, हाँ आ गया मैम.
No, I have renamed myself.
Good evening, madam.
Good evening. Good evening. Good evening.
Hello, Divakant. Welcome.
Yeah.
Good evening, Lahani sir.
Good evening. Good evening.
Good evening, sir.
Good evening. Good evening, madam. Good evening.
Good evening. Good evening, Dr. Lane, sir.
Good evening, Lane sir.
Sir, good evening.
Good evening. Good evening.
Good evening.
I hand it over to Secretary Viral Shah, sir.
Yeah, we have got a couple of minutes. I will just wait if somebody more joins. Couple of Dr. Parthav sir's flight has been preponed. His flight has been preponed, so he's already at the check-in gate. So let's see if he will join. And I will just check with Dr. Santosh Honor, and we will start in a couple of minutes.
Santosh is joining. Santosh is with me. He is joining.
He has already reached, sir?
He is there. He is joining in 1 minute.
Okay, sir. Okay, so we can start. If Sunil is there, Sunil Latawa, he can make the host.
Yes, sir, I'm there.
Yeah, please, can you make the host? We'll start sharing the screen also. Is the screen visible now? Yes, sir.
Yes, sir.
So, Shirish sir, shall we start?
Yes, sir.
So, good evening, everyone. So, to this inaugural ceremony of MOS Midterm 2025 online conference. This is the third edition of this online conferences. and basically it is taken for our members, young members, MOS members. They get a platform to present their show their cases and discuss cases and show their presentation. So welcome everyone to this inauguration ceremony. I welcome our guest today, our patron, Professor T.P. Lahane sir, Chairman Scientific Committee of All India Ophthalmic Society, Dr. Namrata Sharma Madam, President of Young Ophthalmic Society of India, Dr. Divakant Mishra, Secretary, General Secretary, Honorary Secretary of AIS, Dr. Santosh Honor is joining us soon. Dr. Partha Biswas sir has his flight has been reported, so he's at the airport and may not be able to join. So I will request our dignitaries Namrata Sharma Madam, T.P. Lahane sir, Divakant and Santosh sir to please officially inaugurate the conference by clicking on the button, your enter button if you can click. So request Namrata Sharma Madam and Lahane sir to officially declare the conference open and inaugurated. Madam, please.
I think sir will do that first, sir.
Yes, our patron, Padma Shri Dr. Lahane sir, please.
Thank you very much, Viral, Siris, Namrata, Divakant, Santosh, and everybody from the MOS for this midterm conference. I think this conference is, I declared inaugurated, and I am very happy because this conference, they are giving the chance to the budding ophthalmologist to present the case, to discuss the case, and I think that is what required. So this conference is inaugurated.
Thank you, sir.
You
Thank
very
you so much. So, and I request our President MOS, Dr. Shirish Thorat sir, to please give his welcome address.
Thank you, Viral bhai. Good evening, all. Friends, as the President of MOS, it is my pleasure to welcome you all for this inauguration function of midterm viewers. My special thanks and welcome goes to Dr. Partha Biswas sir, Dr. Santosh Honawar sir, Dr. Namrata Sharma madam, our patron T.P. Lahane sir, UC President Divakant Mishra, and MMC observer Dr. Krishna Bhojwani. Friends, let me say proudly that Maharashtra was the first state to have online midterm conference during our tenure in COVID lockdown period. This was an idea of Dr. Ragini Parekh, the scientific committee chairman that time, who had a summer symposium of MOS and BOA that time. And I'm happy to see that the subsequent MOS teams have continued the trend. Friends, these online platforms serve our aim to bridge the geographical gaps and provide training and technology to the ophthalmologists of the smaller town and the periphery. And this program, let me say, is a perfectly curated program by our scientific committee on all subspecialty. There are interesting case-based discussions to solve dilemma in difficult situations, symposium, practice management tips, guidelines regarding insurance and TPA services, and above all, online cultural program too. If time permits, I'll say a few words about MOS activities further. But let me thank our scientific committee chairman Piyush Bansal and our scientific committee secretary Dr. Sumit Lahane for tremendous hard work to get it conference happen. My special thanks to all scientific committee members, my managing committee members, Dr. Viral Shah, Dr. Shon Chunchule, and everyone. And I'm sure that with the help of everyone and with the senior guidance of senior and international faculties, it's going to be a great academic feast for everyone. Thank you. Thank you all.
Thank you so much, sir. Thank you, sir. So before the chairman scientific committee, Dr. Piyush Bansal addresses, we welcome Honorary Secretary of AIS, Dr. Santosh Honar, who has joined us. Welcome, sir.
Thank you so much.
So over to Dr. Piyush Bansal for his address as Chairman Scientific Committee of MOS regarding this conference. Sir. You are muted, Dr. P. Yeah, please.
Thank you very much, Honorary Secretary Dr. Viral Shah sir. Very good evening, everyone, and thank you for tuning in. So with a lot of pride, I would either rather say a lot of humility and a dash of pride, we present to you the third midterm conference of the Maharashtra Ophthalmic Society, which is going to be conducted over 2 days, that is the 21st and the 22nd of June. Now, the conference comprises of 14 hours of academic discussions and 2 hours of cultural extravaganza. The theme, as Dr. Viral has pointed out, is going to be dilemmas in ophthalmology, where we present cases by various young ophthalmologists in 9 subspecialty sessions, which is going to be followed by discussions on those cases by a panel of senior as well as junior experts. Now, as the first day of this academic program comes to an end, we had over 1,500 registrations at the start of the day, with over 500 ophthalmologists joining in on this Zoom platform and practically maintaining that in almost every session, and even more people joining in on Facebook Live as well as YouTube Live. We had over 90 panelists and speakers from all over the state. It gives me immense pride that majority involvement was from the state of Maharashtra, with a few sessions which had invited faculty from all over the country. We had a medical legal session just before this. Tomorrow we plan to have the YOSI session and an insurance and practice management sessions. This is from apart from having all the academic sessions that we've had so far. We also had a competitive video sessions today. And for the first time, in addition to having a free paper session in the annual conference, we had a free paper session in the midterm congress, where papers were read by ophthalmologists from all over the country. Now, all this would not have been possible without the efforts and hard work of the members of the scientific committee, especially my secretary of the scientific committee, Dr. Sumit Lahane. And I must, of course, thank very wholeheartedly the enthusiastic members of the subspecialty committees. All of them have poured their heart and soul into making the program, selecting the ophthalmologists who would be presenting the cases, as well as the expert panel, the chairman and the moderators of the session. So I would like to thank them. I would also like to thank and acknowledge President Dr. Shirish Thorat sir, Honorary Secretary Dr. Viral Shah sir, Honorary Treasurer Dr. Shon Chinchole for their enormous support. And I would like to thank NTOD and Mr. Sunil from the IT team for their constant academic support and expertise. Last of all, I would like to thank all our dignitaries who've taken the time out, despite all of them being busy and traveling to various parts of India. Professor Dr. T.P. Lahane sir, Dr. Namrata Sharma madam, Dr. Santosh Honavar sir, and my dear friend Dr. Divakant Misra. We miss Dr. Partha Biswas sir amongst us right now. So thank you everyone to be over here. So to everybody tuning in, learn, share, and have more fun at the Moscon Mid-Term Conference. Back to you, sir.
Thank you so much, Dr. Piyush. Now, as we all know, this midterm conference is for our young members of Maharashtra Ophthalmic Society, and we always collaborate with Young Ophthalmologist Society of India. So today we have got with us the president of YOSI, Dr. Divakant Misra with us. So Dr. Divakant, if you can please give your address to this meeting.
Thank you so much, sir. And it's a great pleasure and an honor to be part of the activities of Maharashtra Ophthalmic Society. And the whole leadership that I see, Lahane sir, Viral Shah sir, Dr. Thorat, Dr. Chinchole, my dear friend Dr. Sumit, and of course Dr. Piyush Bansal. They've been great supporters of all the activities of young ophthalmologists in general, and YOSI in particular. So we are very excited to be collaborating on this event, and very surprised to see the great participation. Almost I think over 350 people are joined right now, and various other people on various other platforms. And all these sessions have been very well designed, and the participation has been wonderful, considering now the participation is going down in terms of online meetings. But this is a huge success. So thanks to the leadership and everybody who is here, Dr. Namrata ma'am, Dr. Santosh Honavar sir, and everybody who have supported young ophthalmologists like anything. So thank you all of you, and look forward to the rest of the meeting as well.
Thank you so much, Dr. Divakant. Now, we have got with us the path-breaking Chairman Scientific Committee of AIOS, Dr. Namrata Sharma Madam. who has joined from her busy schedule for this conference. Madam, please if you will give your blessings to us.
Thank you, Viral. Thank you so much for having me. Professor T.P. Lahane, sir, the patron of this conference. Dr. Shri Thorat, the president of Maharashtra State Ophthalmic Society. Dr. Viral Shah, the secretary. Dr. Piyush Bansal, the chairman scientific committee and very dynamic scientific committee member of my own team, that is the AIOS. Dr. Shon, who is again a very good friend. Dr. Bhojwani, Devakant, who's always been the torchbearer for the young ophthalmologists, and of course Sumit, and our very dynamic secretary, Dr. Santosh Honawar, who's again always very supportive of the young ophthalmologists. It's very heartening to see, one, that you are doing a midterm conference, and it takes a courage in this era when you don't know what is going to work, whether virtual platform is going to work, physical will work, or hybrid would work. So Piyush, hats off to you for thinking that online would work, and it is actually working because there are 350 plus people already there. And I think I like the theme of your conference, which is dilemmas. Dilemmas not only for young ophthalmologists, but also for senior ophthalmologists and panelists. And I'm sure you would have the recording of this, and that would be again uploaded for people to learn and to educate themselves. Also important to know the fact that free paper submissions you've opened. So again, that is very useful for the young ophthalmologists. And you also have CME credit points. So I think it's a complete package on its own. And whatever you may say, the students, the postgraduates, the residents, the fellows find it hard to take leave or to travel from one place to the other to arrange and organize for their stay, travel tickets, etc. So I think this is a very well thought of format and very well thought of theme. So many congratulations, and thank you for having me, Viral. Thank you so much.
Thank you so much, madam, for always inspiring us as always, and thank you for taking the time from your busy schedule. So now I invite our dynamic honorary secretary of All India Ophthalmic Society, who seems to be in all the places at the same time, and we don't know how he manages it. So Dr. Santosh Honawar, sir.
Thank you, Viral. Patron Dr. T.P. Lahane, sir. President Shirish Torat, sir. Secretary Shah, dear Piyush and Sean. I think we have a very dynamic mix of young and experienced in Maharashtra Ophthalmological Society, and that is actually playing towards benefiting all the members. I think involving Yossi and Divakant, of course, very dynamic young leader of Yossi, has added to the quality of the scientific program. And the program I have seen is very beautifully designed. Piyush, congratulations. You have done a wonderful job. Of course, Sumit must have helped you a lot because I see some of Sumit's flavor there. It's really wonderful that you have thought of this. And Maharashtra Ophthalmological Society has always been a trailblazer. In fact, the first largest midterm meeting was conducted online by MOS even before AIS thought of doing it during COVID times, I remember. So wonderful initiative as always. And looking at the number of people who are logged in, even for inauguration, it speaks a lot about the enthusiasm of MOS members. It's the largest ophthalmological society in India, and I think you're leading from the front. Thank you so much.
Thank you, sir. Thank you so much for your kind words and finding time to join here. Even though you are traveling, and it was cut to cut whether you will make it or not, but you tried your best and you are here. Thank you so much, sir. It means a very big thing to us to have you here. So now I invite our patron, Padma Shri Professor T.P. Lahane, sir, to give his blessings to this conference. Lahane, sir.
Thank you very much, Viral, Series, Piyush, for this shown for wonderful organization. The thank you very much to the Namrata, Santosh, as they have joined Divakant for this, and Divakant is also taking part here. The theme of the conference I have also gone through. It is a very good theme. It may be for the young ophthalmologist or for the senior ophthalmologist. And this idea of the midterm online conference is very good. Piyush and Sumit has done good work for the scientific program. And I think this definitely will help the young ophthalmologists and also the ophthalmologists to guide whenever there is a problem in the cases. And as all our seniors have joined from AIOS, I want to tell them the Maharashtra Ophthalmological Society is a very good society, and they are working for the academics also, they are working for the patients also. And Maharashtra Ophthalmology Society is taking much more interest in the patient's care, and also for the poor patients, they are definitely doing so much of the social work. So I really appreciate their work, and they all are together. So my best wishes to the conference. Thank you very much.
Thank you, sir, so much. Thank you so much. You are always our guiding light, and you always guide us on how to solve the problems and how to approach things. Thank you so much, sir. Now, we have got some announcements from the scientific committee. Partha sir is not there, so I think he's already in the flight because the flight is preponed, and he has sent his message of apology. So we'll now skip to some announcement from scientific committee. I think Dr. Sumit Lan is not there. Dr. Piyush Bansal, if you can announce the winners of the today's free papers or videos.
Would you like me to announce them?
Whatever
Sumit
we
is not
sure
there.
you can. Sumit is not there, sir.
So the results are out, and traditionally we would like to make the announcement of the winners either in the valedictory function. So
Okay.
we'll skip the announcement of the winners,
Okay.
but the winners are out of the video competition as well as the free paper competitions. I congratulate the winner and the runner-up, and to everybody who took immense effort and the courage to present. First of all, so thank you everyone, and congratulations, many congratulations to all. We shall be felicitating all of you all at Moscon, Goa. We'll be making the announcements tomorrow. Back to you, Dr. Viral.
Yeah. Okay. Thank you so much, Dr. Piyush. So we'll be announcing all the winners and the of the competitions tomorrow at the valedictory, and they will also get their mails, and we will broadcast the results also. So before we give the vote of thanks, I think Dr. Shirish Thorat sir is there. Shirish sir, you wanted
Yes, sir.
to say something about Moscon 2025 at Goa also on behalf of the organizing committee, and some points about MOS, sir, if you want to put.
Just
Shirish
time is
sir?
perfect. Yes, yes, yes. Let me take the advantage of these online platform to describe and to explain some of the activities what our managing committee is doing for the MOS. Apart from our PG activities, our PG quiz, our district CMEs, LDB program, some of the international webinars and specialty programs that is we're taking on every Friday, thanks to scientific committee. So apart from this, we are having a non-clinical activities like we have started a simulator training program for PG students and young ophthalmologists. We have our own grievance cell committee to address the issues of the trades. We have a committee of 3 past presidents there. We have formed the ethical committee of around 16 people to resolve the issue amongst ourselves and some of the charity hospitals and quacks. And we are collaborating with the different institutes of India and some of the international institutes also. We have our own sports and cultural committee who is taking care of the sports activities and the cultural programs. And we are planning to reach out around 2 lakhs students of underprivileged areas of Adivasi area and ashram schools. So I request all members of MIS to step into the activities of MIS. You are all our pillars of strength. Your ideas and guidance are most welcome. And I really thank all the past president and our governing body for helping us in these issues. Thank you.
Thank you so much, sir. Thank you. And before and now it's time to give my vote of thanks so good evening everyone. On behalf of Maharashtra Ophthalmical Society, it is my proud privilege to extend a heartfelt vote of thanks on this momentous occasion of the MOS Midterm 2025 inaugural ceremony. At the outset, I would like to express my deepest gratitude to our esteemed guests, Dr. Santosh Honawar sir, Dr. Namrata Sharma madam, Dr. Divakant Misra, and all our advisors whose encouragement and support continually guide our society forward. A special thanks to our patron, Dr. T.P. Lahane sir, and esteemed seniors and past presidents of Maharashtra Ophthalmical Society who continue to inspire generations of ophthalmologists in Maharashtra. To our president, Dr. Shirish Thoras sir, thank you for your visionary leadership and for nurturing academic excellence with such clarity and compassion. I also wish to acknowledge our dynamic treasurer, Dr. Shon Chinchole, for his ever-dependable support and smooth coordination. A huge note of appreciation to Dr. Piyush Bansal, Chairman Scientific Committee, and Dr. Sumit Lahane, Secretary Scientific Committee, and the whole Scientific Committee of Maharashtra Ophthalmic Society. What a brilliantly curated academic feast. You have set the bar high with this theme, Dilemmas in Ophthalmology, offering young minds a meaningful platform for learning and interaction. To all our sessions moderators, speakers, panelists, and participants, thank you for contributing your time, talent, and insights to enrich this forum. Our sincere thanks to Entod, our industry partner and sponsor, whose backing has always been vital in bringing this vision to fruition. And finally, to all the attendees from across Maharashtra and beyond, thank you for being here and making this conference truly vibrant and inclusive. Your engagement is the real strength of Maharashtra Ophthalmic Society. Let this weekend be one of reflection, innovation, and camaraderie, and as we take ophthalmology forward together. Thank you once again. Jai Hind, Jai MOS, and see you all in Moscon, Goa, 2025, 3rd October to 5th October. Right, Piyush sir?
Thank you.
Yes, sir. So thank you. Now we'll be starting our next session, that is our cultural event, where all the 5 zones of Maharashtra have made some dhamal. And to take this show forward, we have got a couple of minutes more to start the program. So to take this forward, we have got Dr. Karobi Lahiri madam and Dr. Nikhil Nasta with us. So thank you everyone for joining us. Thank you Dr. Namrata madam, Santosh sir, Lahane sir, Divakant, who have joined from where they are traveling.
Really appreciate it. Thank you, Santosh sir. Thank you, Namrata.
Thank you. Thank you for having me.
Thank you. So, I think I will stop sharing my screen.
Thank you.
Well, we do have some couple of minutes, I think.
Yes, a couple of minutes we have got. So
maybe Nikhil can raise the excitement levels of what is going to happen now.
So Piyush, Viral sir, everybody on the panel, Lahane sir, namaskar, how are you?
Karobi madam, you have to rename yourself. You rename yourself on the panel, please. We are not able to see.
The mentor and the ma of all the cultural, shown all of us. Actually, there is a big surprise which is planned. I don't think any of you all know about it. This theme, this time we have 5 zones which are competing with each other. And we also have some celebrity guests which we have invited. 3 of them are joining us online. 2 of them have sent us voice messages because they are in a shoot. They are all very famous and they have taken time out to attend this Maharashtra Ophthalmological Association cultural event because it's such a huge one. And when we showed them the previews, okay, these are doctors who are performing, they were even more enthusiastic. Okay, we have to come and we have to see. And बहुत धमाल होने वाला है, बहुत ही मजा आने वाला है. So please stay till the end. This whole thing is curated by Karobi ma'am. And yeah, let's hear what she has to say. Ma'am, over to you.
You're muted, Karobi ma'am, you're muted. Can you unmute yourself?
Hi, everybody. I think we are all ready for the cultural event of today. I was having a little troubleshoot with my laptop. So I was juggling between the laptop and the phone. But luckily, we've sent everything to Sunil. So he's going to relay it from there. So that's a big relief, you know. We have a few surprises for you all. But it's only 7:20 now. Do you want us to start at just now or at 7:30 sharp? Because the judges will be, I think, joining in at about 7:30.
Let me 7:30 shift time.
Yes, we can have a drink break.
Yeah, you can have your drink.
You can have a drink, yes.
Just another 3 minutes, so we'll have to make it a quick one.
Good evening, everyone. Great start. Hello, everyone. Good evening, Dr.
Hi,
Good
Anaga.
evening. Good evening, Anaga madam, President-elect of MOS. Welcome. I see also many past presidents, Dr. Sunaina Malik madam, Dr. Prakash
Good
Marathi
evening,
sir.
ma'am. Good evening, everyone.
Good evening.
Good evening, Karobi. Piyush, congrats to you and Sumit for a wonderful academic session. And I was so happy to be part of it.
Thank you so
We
much.
always need you there, madam. We can't do without you.
Thank
Good evening, Lane sir.
Everybody's program, ma'am. All of us. So everybody, there are so many people who work behind the scenes.
Karobi, best wishes.
Thank you, sir.
You will be number one.
You belong to Maratha originally. Don't say that.
Madam is irritated by that statement.
I will not have it. He's
No. So काय करणार? BOA आहे. Okay. What shall we do? Nikhil, have those people joined in?
Ma'am,
judges?
Veena Prabhu ma'am is already here.
Ah,
I
she's
don't
here,
see
yeah.
the others yet.
Yeah.
And I don't even see our cultural people here yet. So
Yeah, I know. I think
let's
everybody
hear
joining
something
in.
from
What
Veena ma'am.
one
Let's
of
see
you
what
can
she
do
has
is
to
just
say.
give them a call.
See, this is Mrs. Veena Prabhu. She's one of our celebrity judges.
Yeah,
A very
madam,
august
madam,
person.
yeah, if you please
Say hi,
request,
raise your hand, Veena.
yeah. If you please request Dr. Veena to please rename herself on the screen, so on the webinar they will be able to see that she is Dr.
वीणा ताई तुमचं नाम चेंज करायचं तिकडे.
वरते 3 डॉट्स आहे तिथे म्यूटच्या बाजूला 3 डॉट्स.
काय लिहिणार तुम्ही आता?
काय?
Okay,
नाव लिहिणार
we are going to officially introduce her later, but
Yeah.
Veena is a fabulous singer and she runs her own food chain. She's got 2 cafes which run very well, and she herself is an excellent cook. And she's called the Annapurna in her circles, and the other name for her is Veena Tai. So
Yes.
the thing is that where's Veena? Where did you disappear?
1 मिनट मैं ज्वाइन हो रही हूँ. मेरा ये नेटवर्क की वजह से मैं ज्वाइन हो रही हूँ वापस.
अच्छा, okay, ठीक है.
So, ma'am,
that
Veena
means-
is also a pageant winner. She has won the Mrs. Dadar competition in the golden category, and she is a never say never woman. Anything you tell her, she does with full enthusiasm. She has unlimited interviews with Malishka on Red FM, and yes, she's all over the place. She's a duplicate of you, ma'am.
Oh my God.
Yeah,
At least our white smile is the same.
निखिल के लिए कभी भी कुछ भी.
So it's officially 7:30 and the cultural extravaganza can begin.
If you can, please, before we start, Sunil from the technical team, if you can please make Dr. Nikhil and Dr. Karobi as the host and co-host. Dr.
As
Nikhil
what?
Nasta, host. Dr.
Host
Nikhil
and
Nasta.
co-host.
Okay.
Yeah, that's it.
He said host, ma'am, not ghost.
I would prefer if he said go. It's nice to frighten people.
Right.
Hi, Manish.
Hi.
Our cultural team should be slowly coming in.
Sumit is not online yet, ma'am. I don't see him.
Sumit was busy just now. If there is anybody from the Vidar team over here, is there anybody from the Vidar team?
Okay.
Nobody is there. I'll call them, ma'am.
Nobody's there.
Please not there.
I can see Triloki ji also over here.
Yeah, I
Triloki ji,
can't
kaise
see
ho?
Poonam.
Hello.
Hello.
Hi.
Usha
I
is
don't
next
see
to
Poonam
Triloki.
yet. Huh? We'll just wait for her to join.
Yeah.
I'll just call with our people.
So, ma'am, in the meantime, Karobi, ma'am.
Yeah, just a moment. Okay. I think we are ready to start. I think we're ready to start.
I think Nikhil, we should start now. It's 7:32
Okay.
already.
So we will start. We have the cultural event planned today. It's an online thing. You'll have attended the offline ones always, and this is going to be equally damdar and dhamakedar. At the outset, I want to invite Dr. Shirish Thorat sir to please welcome everyone and to say a few words about the conference and the cultural event and to invite all the participating zones online. Shirish sir. I don't think he's here. Can I request Dr. Piyush to please say a few words about the conference and about the cultural program? They all want to get their drinks. Ma'am, you say something.
Nikhil, Shirish is there very much.
No, ma'am, I can't see him.
He's here. He's muted.
Okay, I can't see his video, so I'm not sure if he's gone for a break because they were attending non-stop, right?
Yeah, right. Absolutely.
Nikhil, can you see and hear me?
Yes, I can.
Okay. Because I just changed the laptop, but the one which this was not opening up itself. Shirish is not here.
Ravi, take your laptop a little down. We can't see his face. Yes. Yeah, that's better.
Okay. We would like to have a few words from Shirish, if he's around.
Yes, I'm very much here.
Shirish, go ahead.
Thank you very much. Thank
Over
you
to
very
the
much.
president for his.
Yes, sir. Good evening, everyone.
He's the first man today.
After exhaustive day and a rigorous academic, let's have a wonderful evening of cultural programs. My special thank goes to Dr. Karevi Lahiri Madam and Nikhil Nasta, who have taken lots of effort to make this evening fulfilled and interesting. We have with us celebrity performer Veena Prabhu, Poonam Chandrika ma'am, and Trilok ji. I would like to extend my heartfelt gratitude for giving their precious time. And of course, our own star performer of MOS or zonal coordinators. I thank you everyone. So let us relax, sit back and enjoy the cultural evening. Over to Karu madam.
Dr. Piyush, I'd like you to say a few words about the conference and its planning and how were you finding it from day one? Piyush, are you there?
She's gone for a break, Ravi.
Okay. I would invite any other office bearer. Anaga, if you want to say a few words.
Yes, of course. Yeah, a very good evening to one and all. And we have had a great beginning to this midterm MOS online webinar. And we just had the inauguration now, and already we have started rolling the academic program. So we have been a part of it, and they were really, truly splendid. So we have had so many academic sessions, and now we are looking forward to this great cultural program too. So I think MOS can do it all, whether it's academic, cultural, and sports. So kudos to all of you and welcome to this great session. And thanks to Dr. Shirish Thorat and his entire team who have done a great efforts they have taken. So kudos to you. Looking forward to a great program.
And all the best for your presidential year ahead. Anaga?
Thank you.
Yes,
What about you, Viral? Would like to say something? He's been working very hard.
Good evening, everyone. Welcome to this Dhamakedar cultural night by the members, of the members, for the members. And I think we should start the battle. Let's set the better and we'll watch more action and less words. Over to Karuvi madam and Nikhil sir.
Okay, any other office bearer who wants to say a few words is welcome to do so.
Dr. Shon Chincholi is there.
Dr. Shon?
Dr. Shon.
Yes, I think we need a member like Karu madam, Nikhil Nasta, who are behind everyone to get it done. Dance, karo, dance, karo, dance. Karo. Yes, yes, yes.
Nikhil
Kudos
and
to
Nikita
you,
will
Dr.
dance.
Surprise mat
Kumar,
boliye,
Dr.
surprise mat
Nikhil.
boliye.
Yes, yes.
Okay, let's
Okay,
get
thanks.
down to brass tacks. See, at the outset, I am going to repeat the rules and regulations which are there. I have allotted 18 minutes to each zone. 18 minutes is 3 minutes of introduction time and 15 minutes of the act. But I had given the leeway if somebody wants to cut down their introduction time to 1 minute, they could use 17 minutes to do their act. Or if they want to devote the entire 18 to their act without saying a word for introduction, that is also okay with me. So we are counting it as 18 minutes from start to the end. The timing is very crucial because the same timing has been given to all the 5 zones. Now, the zones which are participating are the Vidarbha, Marathwada zone, the West zone, the North zone, and Central zone. And I think everyone knows which areas the zones comprise. So I'm not going to into nitty-gritties of that. As I said that these zones will be participating for 18 minutes. There is a panel of 3 judges who's going to be judging whatever the performances are. These performances will be adjudged on the fineness of their act and the presentation and how good or bad, good they are, not bad. Bads will be left behind. So that's going to be the thing. And they are going to be marking individual. Then they will be having a conference of their own between the 3 of them to decide whom they liked and who should win. And at the end of it, then they're going to declare whoever is the winner. So in the winners, in the categories that we have put forth, because there are a lot of singers, we have kept 3 prizes for singers. And these are not 1, 2, and 3. They are all good. So there are 3 at equal par. Similarly, we have kept 2 for dancing. We've got 2 prizes for instrumentals. We've got 1 for any mimicry or mime act. And we have got 1 for poetry. Because at this time we had said that there was no skits. So we have not added skits in this program.
Okay.
So whoever
Okay.
gets, and the surprise gift is now for the best team. The best team is going to be adjudged on a certain criteria, like how the presentations are, how everyone has dressed up, how well they have performed on the punctuality. That is the first thing. That is, they have
Yeah.
to adhere to that 18 minutes time, and also how fine the acts are. And the rest, I leave it to the judges because they are such prolific people in their own field that we really don't have to tell them how to judge or how not to. So that is
Thank you.
about.
So, madam, from what I understand now, is that this is probably the only place where during the act competition from amongst the different regions, not only is the finesse and how you've dressed up, is whether you finish maturely or prematurely, but not post-maturely.
Not
You'll be
post-mature.
awarded on that.
Post-mature means you're out. And now, I just had a small word which I wanted to share. We had been repeatedly asking everybody to submit their things to, and since the last 3, 4 days, we have been constantly saying that the presentations have to be given to Sunil at Zaryotech because Piyush and Sumit had too much on their hands. I've written it on all the groups and sent it. But the thing is that we have got the entries from 4 groups, but Vidarbh had sent it probably to Sumit, and they have sent one, but I did not have Dr. Rafat's Khan number, and it got desperately lost somewhere. So it was only today that I saw that he had sent me the presentations. I sent him several messages in the afternoon to consolidate it and send it to Zaryotech because he wanted to show it as a single file. He said it won't be possible for him to do individual acts. So if they could do it, they can just combine it and send it to him. He will run it from that sector. And if they're going to take some time doing it, we can put their act class so that they get some time to sort of this. And suppose they can't do it, then I would request them that one of them sit and the individual acts are shown by one from their end itself. Is that okay? Is there anybody from Vidarbha over here?
That is okay, ma'am.
That's okay. Fine. Okay. So with this, I think we go ahead. Now we come to the important event of sort of introducing our judges. So at the outset, I'd like to introduce our first and senior most judge. This is Triloki Prasad ji. He is a prolific singer, and his wonderful voice hypnotizes all the music lovers. He is a ghazal king, and he is a ghazal singer for all types, that is traditional, light, or classical or Bollywood. And the thing is that he comes from a background where his parents were also Sunil, can you run the slideshow? Yeah.
It's
The
on, ma'am.
next slide.
It's on. It's on.
Next slide. The next one. He hails from a musical family where his father and uncle were known as Jaipur Wale, and they excelled in music and music choreography, and they were the king of Thumri and Dadra over there. And he has an album called Rahat with the famous singer Sadhna Sargam. He's won some of the best awards for sound designing, and he has an album for which he was sort of commemorated in 2012 by the ERA Awards and Lakshmikant Pyaralalji. He is a he has traveled globally for music performances abroad, done live concerts, featured on national and international television. So he's got a lot of credit to himself, and we are very, very pleased to have him amongst us as one of our judges, because we feel blessed that he's come and he's here with us. So welcome, Trilokji. Our next this I'll ask Nikhil to, because he just loves this person, because he loves her personality and he speaks so much about her. So I'm going to ask Nikhil to do the honor.
So this is Veena Prabhu. She's Veena Tai for me, or I fondly call her Mitra. She is one energetic, full of life, crazy woman who has a dashing personality. She is a singer. She loves doing karaoke. We have karaoke nights, and she is a phenomenal chef as well as an artist. Her passions are singing and food. She's very artistic. She's the owner of Veena Prabhu Kitchen and the Mumbai Vibe Cafe. During COVID, she was an Annapurna and she has serviced so many people by giving them food. We together also donate a lot of food to an NGO called Barefoot Foundation. A lot of birthdays, a lot of events we celebrate there with the people at Dadar Full Market. She has featured on many shows on so many channels for cooking programs, and it was Sanjeev Kapoor's privilege to feature her on his food channel as well. She is a very, very close friend of Malishka and comes very regularly on her show. She has conducted innumerable recipe shows on channels like Z, Colors, Food Channel, Master TV. She recently won a pageant also, which was the Mrs. Dadar in the golden category. And she is, I think I can on and on. So with that, I will end here. She's a very, very dear friend. And ma'am, this is for you. This is our trademark, what we always do.
Thank you, Mitra. Thank you so much.
I know one line written by her. मला गायला आणि खायला आवडतं.
गायला आणि खायला आवडतं. Yes.
Wow.
Two passions in life. Now, let's come to our third judge. Can you advance the slide, please? Look at the third. She's a regular hottie. Absolute hottie. Okay. When I asked her to send her photographs to me, because I didn't know how she looked like, she sent me 4 of these. She said, choose from here. Je kai lagel. I said, sagda lagel. Because I said that I'll take all the photographs. They're so good, and it's a treat to watch her face. So advance the slide. And if you see her accomplishments, even I reeled over. I was almost going to faint. She's an actor, anchor, voice artist, Reiki Grandmaster, Tarot Card Reader, Angel Card Guide, Crystal Healing, and NLP Counselor. So if anybody needs help in or any of these things, please contact Poonam. And she has won 7 major awards for being the best actress. She's won the Achal Awards, and she had a movie called Paglia, where she got the Best Actress Award. She features in a lot of TV serials, films, digital ads, print campaigns. She's done promo shoots for all the channels on TV. ZTV, Colors, Prava. I didn't add the remaining. It was too long, you know. And she's featured in more than 90 TVC for top brands. She's featured in print and hoarding ads, featured in web series. She's participated in workshops, anchoring, judging. She's given live interviews on Doordarshan radio. She's played a major role in Star Prava TV serial Kuthe Kai Karte. And she has a YouTube channel on her own where she deals with crystal healing. So with all this, I said that I must sort of minimize it because she had a very, very long resume. And looking at her, she looks so young. I don't know where she's got the time to do all this in this life of So can you advance the slide? So welcome, Poonam. It is our pleasure to have all you 3 judges with us over here. And we are really honored that you all have accepted our invite and come over here.
Thank you. Thank you so much. Thank you.
Okay. Can you advance the slide?
Madam, can I interrupt for a minute?
Yes.
We have with us Dr. Partha sir. We welcome him. Partha sir, welcome to the program.
Welcome, Partha sir.
Partha, welcome.
Good evening, Partha sir.
Thank you very much. Thank you.
Pleasure to have you, Dr. Partha.
We missed you in the inauguration. Glad you could join the cultural event.
Partha sir is extremely colorful, like all our judges over here. Apart from being the president of the
Partha, you'll have to
Ophthalmic
sing an
Society.
offhand Bengali song for us. Only if you promise to do that, we'll let you be on the show.
Oh, come on, ma'am. He's the president of the All India Ophthalmic Society. Please do.
That
No
is it.
conditions. No
Partha is
conditions.
Partha.
Anything is.
President, yeah, Badme. I know the Partha.
Hey, Piyush, no conditions, nahi. Terms and conditions apply always.
Yes, terms and
Correct,
conditions
ma'am.
apply.
Thank you for joining. He's still probably in the cab.
अगले जन्म में जरूर करेंगे.
अगले जन्म में मैं इसी साल में कराती हूँ आपको.
Good evening, sir. Good evening.
Thank you for joining, sir.
Thank you very much. Thank you, but I'm really sorry that I missed the opportunity. Yes, I'm on my way to Chennai airport right now.
So you like South Indians better than Maharashtrians, huh? Looks like.
Karubi, you're there to take care of Maharashtra. Let me take care of Chennai.
I need another Bengali to boost me up.
But
Anyway.
nevertheless, thank you very much. Have a great conference. Have a great time, please.
And you have a safe flight. You're not traveling Air India, no?
11A. Air India, 11A.
Okay.
Kya baat hai? Be safe, sir.
Good luck, sir.
Thank you so much for joining in, Partha sir.
Thank you.
Okay, since we've now addressed all our judges, we just want our judges to come on and say a hi to all the people who have gathered here to this. And starting with the junior most, we'll say Poonam, just say hi and a few words if you want.
Can you hear me?
Yes, we can.
First of all, Sarana, thank you. Namaste. And I'm very happy कि मैं आप सबके साथ यहाँ पे हूँ. First of all, ये सब इतने बड़े-बड़े लोग हैं आज मेरे सामने. कहते ना कि वीणा ताई, डॉक्टर निखिल जी ने सही कहा, मित्रा माझी सखीच आहे ती. आणि एक्चुअली मुझे सिर्फ स्टार्टिंग में थोड़ा सा ये कहना है कि ऐसा कहते हैं ना कि दिल तक पहुंचने के लिए पेट से जाना पड़ता है. तो वीणा ताई है जहां से हम लोग पेट से निकलते हैं, मतलब अच्छा फूड वो देगी. और पंडित त्रिलोकी प्रसाद सर जो कहते हैं ना दिल तक पहुंचने के बाद उनकी गजल सम्राट, गजल सुनने से मन भर जाएगा वैसे. और कहते हैं कि आपकी दृष्टि अच्छी होगी तो आपको सृष्टि अच्छी लगेगी. तो आप सबको इतनी अच्छी दृष्टि देने वाली ही सारी डॉक्टर्स मेरे सामने हैं. तो और क्या है. तो थैंक यू सो मच कि मुझे यहाँ पे इन्वाइट किया है. थैंक यू सो मच.
थैंक यू पूनम. वीणा जी, मित्रा.
हॅलो.
काहीतरी म्हण.
हो, ऐकू येते?
ऐकू येतं.
नमस्कार वीणा प्रभू हियर. निखिलला मित्र म्हणते तसं आज करवीला पण मैत्रीण म्हणीन मी. का म्हणजे ती एवढी गोंडूस आहे आणि इतकी छान असते की आज तिच्या हसण्यावर मी फिदा झालीये. आज आज हे कॉम्पिटिशन नाहीये, आमच्यासाठी स्वतःसाठी स्पर्धा आहे. का म्हणजे तुम्ही एवढे मोठे डॉक्टर्स आहात, तुमचं सगळ्यांचं आम्हाला ऐकायला आणि बघायला इतकं अमेझिंग वाटेल आणि मी खूप एक्सायटेड आहे. प्लीज माझा वेळ न घालवता मी लवकरात लवकर कॉम्पिटिशन सुरू करण्याच्या मागे तुम्हाला सांगणार आहे.
आपकी
थँक्यू सो
इच्छा
मच.
पूर्ण हो. And last but not the least, we have our own Triloki Prasad ji, who's Usha's mentor, and he's a fabulous singer. He teaches her singing, and I want Triloki ji to say a few words. Follow it up with the Ganesh Vandana, which he's agreed to sing for us.
Oh, wow.
सर आप म्यूटेड हैं, अनम्यूट कर लीजिए.
माइक ऑन करना है सर.
माइक ऑन कर लीजिए.
नहीं सर.
इधर हो.
आपके स्क्रीन
नीचे
के
नीचे
वहाँ पर एक
स्क्रीन में
ऑडियो
होगा
बटन
सर.
होगा.
ऑडियो वीडियो.
ऑडियो
लेफ्ट कॉर्नर में.
ऑडियो
जो ऑडियो वाला है उस पर एक लाल लाइन, हाँ लाल
नीचे
लाइन होगी,
लेफ्ट
उसको
कॉर्नर
ऑन
में
कीजिए.
सर.
आ गई आवाज?
अभी आ रही है
यस
सर.
यस अभी आ रही है.
ओके. सभी देखने वाले और सुनने वालों को त्रिलोकी प्रसाद का नमस्कार, आदाब, और ईश्वर से यही प्रार्थना करता हूँ कि एमओएस के जो कल्चर इवेंट है ये बहुत खूबसूरत हैं और बहुत खूबसूरत हमेशा रहें. तो एक शेर है आप लोगों के लिए पहले, क्योंकि आपने गजलों के बारे में इतना जिक्र किया है.
इरशाद.
कि मुझे गम नहीं है इसका कि बदल गया है जमाना, मुझे गम नहीं है इसका कि बदल गया है जमाना, मेरी जिंदगी है आपसे कहीं आप बदल ना जाना.
वाह.
क्या बात है.
One thing, just keep 5 things ready with you, na?
शाम की शुरुआत
Picking up of the lots. नहीं,
शाम की इब्तिदा शुरुआत.
And when I tell you draw the lots, you
आप
just
सब लोगों की फरमाइश है कि मैं गणेश वंदना गाऊं,
the presentation.
तो उसी से शुरुआत करते हैं.
The first got
और
this.
बिल्कुल सही है, किसी भी कार्य को आरंभ करने के लिए गणेश जी का आशीर्वाद होना बहुत जरूरी.
No, but he's not central as a file. It's like
Ka-
visual acts.
करोबी मैम, जस्ट
Yes.
म्यूट योरसेल्फ. यू आर हर्ड हियर. हाँ. Yeah. हाँ
शुरू
सर.
करें गणेश?
हाँ सर प्लीज.
जय जय सब में श्रेष्ठ गणेश, जय जय सब में श्रेष्ठ गणेश, जय जय. तीन लोक में चर्चा करते, तीन लोक में चर्चा करते, ब्रह्मा विष्णु महेश, ब्रह्मा विष्णु महेश, सब में श्रेष्ठ गणेश, जय जय सब में श्रेष्ठ गणेश, जय जय. एक दंत दया पंत चतुर्भुज, एक दंत दया पंत चतुर्भुज, हंस हंस नाचे उमेश उमेश, हंस हंस नाचे उमेश उमेश, सब में श्रेष्ठ गणेश, जय जय सब में श्रेष्ठ गणेश, जय जय. अब की लाज हमारी रखो प्रभु, अब लाज मारी रखो प्रभु 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 अब की राज हम अब की लाज हमारी रखो सबकी राखी हमेश हमेश सबकी राखी हमेश हमेश सब में श्रेष्ठ गणेश जय जय सब में श्रेष्ठ गणेश जय 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 गणेश शंकर शंकर पुत्र गौरी के गौरी के नंदन गौरी के
Very nice. That was very, very,
Very
very
nice.
nice. After this, we since Shirish is not here, he's busy with
He's there.
something. He's there?
Yeah, he's there.
No,
He's
I
right
would
here, ma'am.
request
He's right here.
Anaga or Shirish, one of them. I would like them to draw the lots to tell us which zones would be
Ma'am,
participating in
we
which
have
order.
forgotten the two video introductions.
Oh, yes. So let them do the lots, then we'll do the
Yes.
video introductions.
Okay.
Shirish, are you available? Or Anaga, you do it.
Yeah, I have it with me. Yes.
So I think you do the.
Yeah.
Tell us who goes in first, second, third, fourth.
Okay. I'm just taking one.
Ma'am, Shirish sir is there.
Shirish sir is there.
Shirish is there?
Yeah.
Because he was busy with Dr. Rafat, so I thought he's
Yeah.
not there.
He's there.
Honestly, this is one of the few times that I've seen Dr. Anaga where she's free before 10 p.m. She's
Shirish sir
working
can
right
tell me
now.
the-
She's got a battery of bodyguards behind her.
Dr. Shirish, you have to take the lots.
And when I saw her at her son's wedding, it looked like she's the bride.
Oh.
She was looking so young and cute.
Who is to take? I or Dr. Shirish? Dr. Shirish, na?
He's asking you to do it.
Actually, you do it, Anaga.
Okay. I was waiting for him. Okay. Vidarbha.
Vidarbha is first. Oh my God, but they have to go
No,
last.
do it last.
Change it.
They'll be last. They'll be
They'll be
last.
last. They'll be last.
They'll be
We
last.
need to give them time.
Okay.
North.
North.
Oh, north.
West.
West.
Go west.
Central.
Go central.
Central. Yes.
Vidarbha is last.
Now Marathwada will be there.
Marathwada is fourth. Yeah.
Yeah.
Okay, so can you repeat the order? North, West,
West,
Central, Marathwada,
and
and
Vidarbha.
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 Yeah.
So
Okay,
all the
judges?
participants, the zone heads, you all have taken cognizance of this?
Yes.
Yes. Okay, good. Now,
You can put it in the chat so that we'll remember.
Yes.
But I don't see videos of the zonal people.
Reference of the judges who don't know the MOS zones, I would suggest you just elaborate a bit, or let Shirish
I
or
think let Shirish do it.
Yeah.
Or madam, you do it, no problem.
no,
Really, you do it.
the office bearers do it. They are the-
Thorat sir. So,
Ma'am, you can do it. Ma'am, you can do it.
अरे, मैं भूल गई हूँ
Shirish sir, आप ही बोल दो.
Shirish, आप ही बोलो.
Yes. For judges, our Maharashtra Athletic Society, we have divided ourselves into 5 zones, like Vidarbha zone, Marathwada zone, a central zone, west zone, and east zone. Like in Vidarbha, there are 11 districts of Vidarbha. In west zone, it starts from Pune, then Sholapur to Sangli, Satara, Kolhapur. And he's it's like Jalgaon, Ahmednagar, then Nashik and all, and Central is Bombay. And Marathwada is from Aurangabad towards Nanded. Yes.
And Central is Bombay. Yes.
Central is Mumbai.
Yes. Sunil, can you show the video bites, please? Nikhil, you and
first,
Manish, go ahead.
Yeah. Sunil, please play that PPT again. We have 2 slides over there we need to show. The one you were playing before. Yes. Yes, this one. Can you click on that? It's a video. Ye bajega. No. Okay.
Hi, Namaskar. Maharashtra Ophthalmologist Association.
सुनील जी बंद हो गया.
Do you want me to play it?
You can just कर दो screen share निखिल आप.
हाय नमस्कार. महाराष्ट्र ऑप्थॉल्मॉलॉजिस्ट असोसिएशनचे आणि आजच्या कार्यक्रमात सहभागी होणाऱ्या सर्व डॉक्टरांचे मनापासून अभिनंदन. तुम्ही खरंच खूप छान कामगिरी तर करतातच आहात तुमच्या करिअरमध्ये, पण आजच्या या कार्यक्रमातून तुम्ही सगळ्यांना एक एंटरटेनमेंट करून मस्त आनंदही देणार आहात. सो त्यासाठी तुम्हा सर्वांना खूप खूप शुभेच्छा.
So this is my dear friend Tejaswini Lonari, or we call her Teju. She was one of the winners of Big Boss Marathi. She is an actress par excellence, a youth icon, and she is so beautiful. She has featured in so many Marathi shows, movies like Aflatun, shows like Ata Haude Dingana 2, Ata Haude Dingana 3, and many more. The second slide over there shows all the work she has done, and she has graciously agreed to send a soundbite, although she was not able to join personally. This is another friend. Yeah, this is all the work she's done, some of it. This is another friend of mine. He is Madhav Devchakke. He also has acted in so many movies, TV shows, Big Boss Marathi 2. He is now coming up with a movie called Aboli. He has done so many songs. He is a brilliant person, and he also comes from a doctor family. He graciously agreed to also send a voice note for all our participants. So let's hear what he has to say. He has a sound bite. Sunil.
Sunil, play the second video bite, please.
हॅलो नमस्कार, मी माधव देवचके, महाराष्ट्र ऑप्थोमॉलॉजिस्ट असोसिएशनचे आणि आजच्या कार्यक्रमामध्ये सहभागी होणाऱ्या सर्व डॉक्टर्सचे मनापासून खूप खूप अभिनंदन. तुम्ही तुमच्या करिअरमध्ये तुमची कामं खूप छानरित्या नेहमी करतच आलात, पण आज तुम्ही या कार्यक्रमामधनं लोकांना एंटरटेन करणार आहात, त्यांना आनंद देणार आहात, यासाठी तुम्हाला खूप खूप शुभेच्छा.
So thank you so much to both our participants who couldn't join online. They only joined in spirit, but I thank both of them from the bottom of my heart. With
Nikhil,
that, we
what
can
is
move
this?
on, ma'am.
Nikhil, what is this? Hey, these people, these office bearers of the MOS, they keep telling us, do cultural, get this one, get zones, get people, put the acts together, show it. All this kind of things they are asking us to do, and they make us dance so much to their tunes. Why don't we make them dance to their tunes? What have you done? I told you that day, you make them dance to our tunes. What did you do, Nikhil?
आपका हुक्म सर आंखों पर, आपने बोला तो मैंने नहीं, सबने किया है. एंड फॉर यू ऑल द पीपल इन दिस कल्चरल प्रोग्राम, ऑल आवर सीनियर्स जूनियर्स, सब लोग इतना डर गए आपकी डांट खा के कि उन्होंने इतना परफॉर्मेंस किया है, इतना ढासू, सब गुलाबी साड़ी पहन के एकदम धमाकेदार परफॉर्मेंस. मैं आपको अभी दिखाता हूँ.
लेक्चर के साथ भी किया डांस.
Your wish is everyone's command.
My feathers are ruffled, feathers are smoothened now.
Are you guys able to see the screen?
Yeah.
Yes.
So I'm going to start. Be prepared. Chalo, start.
I am also seeing this for the first time. There is a little lag between the sound and this.
There is no sound.
We are not getting a sound. Not getting a sound.
Can you stop?
Not getting a sound.
No, not getting a sound.
Not getting a sound.
No, we want to hear the sound.
You can't hear it. Okay. Let's try it again. Why can't you hear it? I'm trying to play it again. Check. Now?
Nope.
नाही साऊंड येत नाहीये.
What? You can't hear the sound?
ना.
This sound, camera, and then action.
Arey, what's going on? Why is the sound not playing? Manish, tell me what to do.
Your audio should be not from your external speaker. It should be from your laptop. That is why it's not playing. You are using an external speaker. Choose you have to in your Zoom. No, your speaker का उसमें आपका audio choose करो. Let it be the machine का speaker, not the external one.
Okay, where do I do this? Sorry, where?
Zoom में audio input रहेगा ना, उसमें जाओ.
Audio
you click on your left
okay,
side का audio.
okay.
हाँ वहाँ पे डालो. उसमें ना you will have options.
Microphone, same as system. Speaker, headphone, same as system.
You use your same as system, no?
जाता हूँ एक बार फिर मुझे बता.
Use same as system. Don't use the microphone.
Okay, let's try.
Sunil sir.
Yeah. हाँ बोल. Sumit बोल. Sumit is.
No. Sunil sir can help out with that.
Nikhil करना. I think this should happen. Otherwise,
Okay,
Sunil sir आपके पास है क्या?
Let's try one more time. एक minute, just give me 1 second.
This always happened with upcoming stars.
क्या बोल रहे हो?
Sir, established star है.
Established है वो.
अरे stress में मत डालो अभी. Wait, let me play this first. Where is it gone?
Piyush has company.
Piyush will beat me up, yeah.
She's come specially to see this.
Okay,
Yeah.
chalo, I'm starting it again. Hopefully it works. Fingers are crossed. Yes?
No audio.
No audio.
No?
No.
I think let Sunil play it.
Let Sunil play, no?
Sunil को play करना दो.
Okay, which
So,
one?
okay, I'll have to
देखिए,
mail it
तेरा
to
latent
Sunil.
period बहुत ज्यादा है.
Hello.
Latent period ज़्यादा है. Okay. Sunil, आपका mail बोलिए.
Sir, I'm just dropping in the chat.
Yeah. In chat. Oh God. Just tell me now.
Sunil at radiotech.in.
AD.
I'm just
at
zadeotech.in.
.in.
Sunil @ zadeotech.in.
Yeah.
TCH.in.
Oh, okay. It's embarrassing. ठीक है.
No, don't worry.
It's only us.
ढंग से करेंगे.
This is one Dhasu act. I can wait for it. There's no problem. And everybody can wait for it.
Two broken
You know
bones have
what?
done
This
this
act
today.
edit has happened
Broken
abhi,
fourth and fifth rib.
like 10 minutes back, because the guy who was doing it could not, and then my staff have done it, and they've done it very well.
No. This is thanks to Piyush because
This
he
thanks
sent
to
it
me.
last.
Yeah,
This is
Piyush
thanks to
said
me,
everything
100%.
Piyush ma'am. Very bad.
100%. The only thing was I had to do it with two. I have a fourth and fifth broken rib, but
Nikhil,
Yes.
सुन वो जब तू शेयर कर रहा है तो शेयर विद
That's
ऑडियो वाला
Piyush's
ऑप्शन
wife
क्लिक
in
किया
the
है कि नहीं?
background. Hi.
Just try that. When you're sharing, no, you are.
Shared as a link. I've shared as a Google
No,
Drive link.
but
Can
right
I-
now,
can
no.
I-
Just try playing
can I
again.
guide? Can I
Share
guide?
करो and share with audio देखो.
Can I guide?
Please.
Guide.
Just click on share button once.
Yeah.
You have an option on the right hand side which says share sound.
हाँ, share sound. Say share with audio. That's
Okay,
it.
okay.
Ensure it is
Okay.
checked, right? Beneath that there is something called share Zoom.
Yes, there is. Okay.
Don't do the Zoom window. Just the share sound option.
Share sound. Okay, I've done share sound and I'm trying it again. Okay.
Ji.
All the best, Nikhil.
Okay.
Yes,
Yay!
we did it.
बढ़िया.
You can clap and give reactions, huh?
Hey, Dr. Rajesh Joshi.
काजळ लावणे आले मी आज असं नका बघू अहो येते मला लाज केला शृंगार आज घातला असाच दिसते मी भारी जणू अप्सरा मी खास नखरेवाली कुठे निघाली घालून साडी लाल गुलाबी पागल करते तुझे मोरनीशी चाल गुलाबी साडी आणि लाली लाल लाल दिसते मी भारी राजा फोटो माझा काढ गुलाबी साडी आणि लाली लाल लाल दिसते मी भारी राजा फोटो माझा काढ झाला क्लोज आता वाईट मानवरती ओके राईट फोटो काढतो असा होणार ज्याने वातावरण ताईट मस्त खुशी मध्ये बायको माझी करीन पिलो फाईट माझा होऊ दे पगार गिफ्ट करतो रिंग लाईट नको मला चहा खारी आता जेवण करून जाईन सेलिब्रिटी तू मी तुझा पीए बनून राहीन येणार सेल्फी साठी क्राऊड मला फील होणार प्राऊड जाशील इन्स्टावर लाईव्ह आणि मी कमेंट करत पाहिन करीन कष्ट माझ्या पैशाने घेणार मेकअप किट राजा होणार मी इन्स्टाची स्टार हाय गुलाबी साडी आणि लाली लाल लाल दिसते मी भारी राजा फोटो माझा काढ किती मी क्यूट किती गोड किती छान दिसते मी भारी राजा फोटो माझा काढ आता माझी सिंपल नसले जरी डिंपल हिरोईन दिसते मी हिरोईन थोडे दिवस थांब अशी लाईन लागेल लांब मी पण बनूनच दाखवीन हिरोईन माझी चाशनी तू माझी खास मी तुझा समर्थक उद्या पण आज मी बोललेलो किस मी ती बोलली आज नाही बनू नको म्हणे इम्रान हाशमी माथ्याची टिकली पैंजण बांगडी हिऱ्याची अंगठी मारुती कारवी चांदीचं कंगण सोन्याचं गंटन करेन गिफ्ट हा करत मजाकनी पुरी करीन तुझी हर एक विश नको करू शंका ना सवाल हाय गुलाबी साडी आणि लाली लाल लाल दिसते ती भारी म्हणे फोटो माझा काढ गुलाबी साडी आणि लाली लाल लाल दिसते ती भारी म्हणे फोटो माझा काढ
Oh, wow.
Wow.
Did you like
Very
it?
nice.
That is
Very
the
nice.
best of all
Yes.
the performances.
Yeah.
It's really nice.
Very good, very good, very good.
Good
very
work,
good.
Nikhil. Now I'm very appeased.
So thank you everyone who took part
Very
on it,
good.
and really apologies for pestering you all so much. But ma'am, you saw the emotions. कितने दिल से सब लोग ने डांस किया है, and the
बहुत बढ़िया,
boys have
बहुत
to outshone the girls this
दिल खोल
time.
के डांस किया.
बिल्कुल.
Thank you, everyone. Thank you.
तर बरीच डान्स केली ग.
पण याच्यामध्ये निखिलला जास्त स्कोप नाही दिलात हा तुम्ही.
नाही मुद्दामून
तो
निखिलने
स्वतः नाही
स्वतःहून
घेतला.
स्कोप घेतला नाही, तोच डायरेक्टर होता मॅम. तो बोला सगळ्यांना करू दे.
और मैम आपके डर से एंड में सुमित पर्दे के पीछे चला गया.
बहुत बढ़िया, बहुत बढ़िया.
त्यांनी जर डान्स केला असता तर आम्हीचा डान्स कोणी बघितला असता.
यशवंत चांगला डान्स केला.
नाव इट्स इझी
खूप छान, खूप छान.
नाव इट्स
खूप सुंदर केलात सगळ्यांनी.
कमाल केलाय खरंच कमाल.
कमाल.
सरप्राइज गिफ्ट है तो
सरप्राइज गिफ्ट है.
मुझे लगता है अभी हर एमओएस में एक क्लिप जानी चाहिए.
जानी ही चाहिए. ये हम लोग गोवा में प्ले करेंगे.
In fact, the
नहीं,
thing is
naturally.
that,
Sorry.
in fact, when I was asked to sort of do the cultural event for Maharashtra, there is so much of talent in all the zones of Maharashtra, na, that for one person to assimilate everything becomes really tough. So that is the reason why we have made it into zones, and each one handles his best talent because we've given them a limited time. So they have to showcase their best talent in that. So
Very
here's for a fiesta of lovely acts. I hope the judges enjoy it as well as judge it. Nikhil, over to you.
So ma'am, I think now we should go ahead with the zones as discussed, and they should start presenting because
Okay, before we
do.
start, Sunil, there is a little bit of lag between the sound and the this.
Oh,
Is there some?
performance.
Yeah, performance.
Video.
Yeah.
Yeah.
Video.
Was that because it was played on my Wi-Fi? Maybe on his it's better.
No, even the earlier part, there was a little lag because even Trilokiji's song, na, it was coming a little this because He was singing it so nicely,
वो
but
भी
there was
सर का भी ना मैम कनेक्शन शायद होगा. I think Sunil must be having a faster connection, so hopefully these files would play seamlessly.
no, but Sunil.
सर का भी
Okay,
अपना
so
नेटवर्क
Sunil,
होगा
please take
शायद.
care of that before we go ahead. And as discussed, our first zone is the North zone. So, ma'am, please invite them.
1 second. Next time, I'm saying for Anuga, please ask the advisors also to dance now. Why were we
Yeah. I know.
Done, ma'am. Done.
Hold your ears. Senior
Apologies.
most madam is
Not
telling
you,
you, and
ma'am.
what is this?
I have to hold my ears.
Next time he meets you, madam, he will do like he'll kneel down and give you an apology.
Ma'am, if you remember last time, there were two people dancing in the background with you. That one of them was Nikhil and the other one was me. So we enjoyed your dance so much there.
You were dancing with me.
Yes, you were dancing with me.
Yes.
She is evergreen, madam, and she's own green also today. Just love you, Sunaina ji.
Don't call me G, please.
No, Sunaina, madam.
If Sunil is ready, he can start
Sunil,
the.
come on.
I think first you should let the zone head.
Yeah, where are the zone heads for the north, please?
I'm here, ma'am. Dr. Darshana.
Oh, yes, Darshana. How are you?
Yeah. I'm
Nice to
fine,
see
ma'am.
you.
Thank
We are
you.
waiting to see all your dhamakedar performances. So if you want to say a
Right.
few words, say it and we can start with your.
Yeah. There is a small intro followed by a small poem, comedy poem, which I have presented, and all the performances according to the list I have given. So do enjoy it. It's bit 1.5 to 2 minutes longer than what you said. So if you feel, I will stop it at 18 minutes. Let us go ahead with the presentation.
Sure.
I've forwarded.
Let us go
Thank
ahead.
you.
All the best.
Thank you.
All the best.
Hello friends, I'm Dr. Darshana Shah from Jalgaon Vivekanand Netralaya. I present in front of you iTalent North Maharashtra. We are Khandeshis. Don't call us from Bhusawal, Jalgaon, Dhule or Nashik. We are part of Golden Triangle and we are so famous for our bananas, grapes and bharitwangi. We have so much rich culture that dance, music, mimicry is just a small part of our culture. I present in front of you doctors from Jalgaon, Bhusawal and Nashik who are here to just show you jhalak of our immense eye talent. My one-eyed love. I have fallen in love. I don't know why. I have fallen in love with a girl with one eye. I have fallen in love with a girl with one eye. I knew from the start, I was plain to see that this wonderful girl had an eye out for me. She is charming and witty and jolly and jocular. Not what you did expect from the girl who is monocular. Of eyes, at the moment she hasn't full quota, but that doesn't change things for me, even one iota. It must be quite difficult if you are bereft, if your left eye is gone and your right is to the left. But she has made up her mind. She has made up her mind and she has made up her decision. She can see it quite clearly in 10/20 vision. She will not leave me waiting, not left me in the church too. If she looks slightly sideways, she will see me in the church. I will marry the true love who is gentle and kind and thus prove everyone that love is not quite blind.
वाले नखरे वाले नखरे वाले देखने में देख लो है कैसी भोली भाली अजनबी ये छोरिया दिल पे डाले डोरिया अजनबी ये छोरिया दिल पे डाले डोरिया मन की काली वो तो कोई और भी जो आंखों से समा गई दिल में डिगड़ी डुडू
वाटते मला की अजूनही चांदरात आहे सुन्या सुन्या मैफिलीत माझ्या. कळेन मी पाहते कुणाला, कळेन हा चेहरा कुणाचा, कळेन मी पाहते कुणाला, कळेन हा चेहरा कुणाचा. पुन्हा पुन्हा भास होत आहे तुझे हसू आरशात आहे सुन्या सुन्या मैफिलीत माझ्या. तुला भेटतील माझे तुझ्या घरी सूर ओळखी.
दिल दीवाने पूछूं तो मैं जरा हर लड़की है या है जादू खुशबू है या नशा पास वो आए तो छुके मैं देखूं जरा रुक जा ओ दिल दीवाने पूछूं तो मैं जरा देखे वो इधर हंस के बेखबर हमके दिल हम खड़े हैं गुमसुम सी नजर उसकी है मगर होठों पे शिकवे बड़े हैं बात बन जाए तो मैं बात छेड़ू जरा रुक जा ओ दिल दीवाने पूछूं तो मैं जरा है लड़की
सूरज निकला था कुछ पारा पिघला था एक आंधी आई थी जब दिल से आह निकली थी दिल से रे एक सूरज निकला था कुछ पारा पिघला था एक आंधी आई थी जब दिल से आह निकली थी दिल से रे 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 दिल तो आखिर दिल है ना मीठी सी मुश्किल है ना पिया 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 ना पिया जिया 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 ना जिया दिल से रे 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 दिल तो आखिर दिल है ना मीठी सी मुश्किल है ना पिया 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 ना पिया जिया 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 ना जिया दिल से रे
हो, बड़ी सुंदर दिखती हो, क्या खूब लगती हो, बड़ी सुंदर दिखती हो। फिर से कहो, कहते रहो, अच्छा लगता है, जीवन का हर सपना अब सच्चा लगता है। क्या खूब लगती हो, बड़ी सुंदर दिखती हो, क्या खूब लगती हो, बड़ी सुंदर दिखती हो। तारीफ करोगे कब तक, बोलो कब तक, मेरे सीने में सांस रहेगी जब तक। कब तक मैं रहूंगी मन में, हाँ मन में, सूरज होगा जब तक नील गगन में। फिर से कहो, कहते रहो, अच्छा लगता है, जीवन का हर सपना अच्छा लगता है। क्या खूब लगती हो, बड़ी सुंदर दिखती हो, तुम प्यार से प्यारे हो, तुम जान हमारी हो। खुश हो ना मुझे तुम पाकर, मुझे पाकर, प्यासे दिल को आज मिला है सागर। क्या दिल में है और तमन्ना, है तमन्ना, हर जीवन में तुम मेरी बनना। फिर से कहो, शपथ तुला दिल्या घेतल्या वचनांची, शपथ तुला मनातल्या रसाची, शपथ तुला दिल्या घेतल्या वचनांची, शपथ तुला।
Thank you so much.
बहुत अच्छे, बहुत बढ़िया,
God,
बहुत
North has
बहुत
really
बढ़िया,
taken it.
बहुत ही बढ़िया.
Bhai, West, Central, everybody has to buck up, huh?
Very
बहुत
good.
बढ़िया, बहुत बढ़िया.
बहुत ही बढ़िया, very nice.
Very nice. Do the judges want to make some comments?
ऐसा लगता है कि नॉर्थ साइड में सब सिंगर वहीं पे है. अपने अपने रफी साहब भी वहीं पे है, आशा ताई भी वहीं पे ही है. हाँ, ऐसा किशोर कुमार भी वहीं पे है, लता जी भी वहीं पे है. ऐसा लगता है कितना आज 6 सिंगर ने गाया है. ऐसा तो
सभी बहुत
बहुत बढ़िया.
खूबसूरत
और सबने दिल से गाया है.
दिल से गया. और उन्होंने कभी मतलब चाकू सुरी छोड़ के माइक पकड़ा है उनको. तो इतना बढ़िया उन्होंने किया है परफॉर्मेंस. सच में ग्रेट है यार. लय भारी,
खूप भारी. आणि फर्स्ट ऑफ ऑल वो सारे एंजॉय कर रहे थे. और फर्स्ट ऑफ ऑल वो खुद एंजॉय कर रहे थे गाते टाइम, यू नो, डांस करते टाइम. ऐसा लग ही नहीं रहा था.
बिल्कुल,
सुपर.
बहुत बढ़िया, बहुत बढ़िया.
और चौधरी साहब तो गुजराती सर तो खाते सही गा रहे थे, खाते इसमें.
हाँ, अरे हाँ, मुझे लग रहा था कि खाना हम लोगों को डिस्ट्रैक्ट करने के लिए रखा हुआ था उन्होंने.
नहीं, मुझे भूख लग रही थी.
वो कहते हैं पहले गाना फिर खाना.
वो मेरे पार्टी में है, वो मेरे पार्टी में खाना और गाना ये दो.
व्हेरी नाइस, व्हेरी नाइस.
आई आम्ही सगळे येणार बरं का.
नक्की या, नक्की या.
Announce the West Zone now.
एक छोटी मैफिल तिथे होईल डायरेक्टली आपली कॅफेवर.
भरी शेवभाजीची पार्टी.
क्या बात है. West Zone has come.
Yeah, can we request? ये नॉर्थ जोन था.
North Zone, yes.
Next is West, right?
Yeah, can we request the West Zone representative to please speak? Who's the leader from West Zone? Zonal head. The zonal head.
Good evening, everyone. I hope I'm visible, audible.
Absolutely.
Hi, so my co-coordinator, and of course, she's been the main instrumental person getting all this together, Dr. Monica. You are on? And Dr. Ashwini Mehta, if she's there. Okay, till they join in, I'll just give you a small. I think she may be joining. So, so we are really so happy to put all this together for all of you. And I can see the wonderful talent that is just flowing around from all sides. And we have made our effort as well. We've made a little, clip together. We have actually compiled it. I'm sure it's with Mr. Sohar. And can we have it?
Good luck.
Thank you so much.
All the best.
All the best.
Thank you. It's lovely to see all my friends around on this.
Yeah.
Same
Vajanti is part of the gang.
Yeah, and where's Monica? Tell her to come
Always.
also.
Anytime for art. And today is World Music Day. So wish
Monica,
everyone
we can't hear
very happy International Music Day.
Yeah, happy Music Day.
Monica, I can hear your voice, but I can't see your face.
Oh, it's there.
Yes, we can hear you.
Yes.
Yeah, there she is.
Good evening, MOS members. I, Dr. Monica Naik-Nimbarkar, along with Dr. Ashwini Misal and Dr. Vaijanti Kadre, bring to you a bouquet of performances from our very own talented members from West Zone, Maharashtra. At the outset, let me thank Dr. Shirish Turat, MOS President, and his wonderful team, and also Dr. Kairobi Man for giving us this opportunity. I am sure the performance of our participants will enthrall all of you. Let me give a short introduction of all. We begin with the baritone and melodious voice of Dr. Sachin Athare. One wonders what he is doing here, when he could have given a background score to many Bollywood movies. By the way, he is a talented cornea surgeon. Dr. Mandar Paranspe, past president of POS, voices his reflective thoughts through his poem, Dodi. Laughter is the best medicine. I know that the anecdotes of Dr. Subhash Bijrani sir, who needs no introduction at all, will tickle a funny bone in all of us. Mind well that you understand the finer nuances of his jokes to get the full impact. Dr. Rujita Machwe, past secretary of POS, dances with agility and grace to the numbers Aja Nachle and Morini Bagamme. The fluidity of her movements and vista of expressions, I think, would put Madhuri Dixit to shame. The next performance by Dr. Sameer Datar, a mimicry, will make us wonder whether the late actor Ninu Pure has come back with us. Dr. Sameer Datar is a cornea surgeon from Pune. Dr. Rupali Abhyankar, a practicing ophthalmologist from Vai, renders a tribute to her late husband, Dr. Shantanu Abhyankar, through the well-penned poem Kokila. I'm sure this will strike a chord within all of us. Nightingale of Pune, Dr. Vaijanti Kadre's song is a treat to one. She is a multi-talented persona. Lastly, Dr. Shrutika and Dr. Vardhaman Kankriya's song will rekindle romance in all of us, I'm sure about it. They are the directors of Asian Eye Hospital, Pune. I hope you all find our performances to mark and enjoy it. Thank you.
Let's go, West Zone.
मैं कोई ऐसा गीत गाऊं कि आरज़ू जगाऊं अगर तुम कहो। मैं कोई ऐसा गीत गाऊं कि आरज़ू जगाऊं अगर तुम कहो। तुमको बुलाऊं ये पल के बिछाऊं कदम तुम जहाँ जहाँ रखो। ज़मीं को आसमां बनाऊं सितारे सजाऊं अगर तुम कहो। मैं कोई ऐसा गीत गाऊं कि आरज़ू जगाऊं अगर तुम कहो। मैं तितलियों के पीछे भागूं, मैं जुगनुओं के पीछे जाऊं। ये रंग है वो रोशनी है तुम्हारे पास दोनों लाऊं। जितनी खुशबुएं बाग में मिले, हाँ जितनी खुशबुएं बाग में मिले मैं लाऊं वहाँ पे कि तुम हो जहाँ जहाँ पे। एक पल भी ठहरो मैं गुलसिता बनाऊं अगर तुम कहो।
आपल्याला जरी कविता आवडली तर जरूर शेअर करावी.
ऐकत राहावं
कवितेचं शीर्षक आहे दोरी. दोरी कुणाची कुठवर कुणास ज्ञात नाही, श्वास कुणाचा किती काळ ज्ञात नाही. गूढतेच्या कुशीत लपलेले प्रश्न अनंत, जगण्याची आस प्रत्येकात आहे ज्वलंत. एका क्षणाचा खेळ सारा असतो तरी, प्रत्येक क्षण अमूल्य जपावा खरी. विचार मृत्यूचा का करावा सदा, जगण्याचा आनंद का हारवावा कदा. दोरी घट्ट करूया सबळ सार्थक विचारांनी, वाटूया उमेद उल्हास आनंद उत्तुंग आचारांनी.
In those days, there used to be camps where we used to enter knife section, intercapsular, 1 or 2 stitches. So there was this one particular camp which was done in one of the places in Shirur Taluka. और मैं अकेला ही था वहाँ पर इंचार्ज ऑफ द कैंप. ऑफकोर्स इट वॉज अ प्राइमरी हेल्थ सेंटर. तो मेरे सामने एक बुढ़ी औरत थी जो काफ़ी हिल रही थी, आवाज़ें कर रही थी अलग अलग, और मुझे चिड़चिड़ापन हो रहा था बिकॉज आई वांटेड टू जस्ट फिनिश एंड गेट बैक होम. सो आई जस्ट लुक डाउन एंड टोल्ड हर, मावशी जर तुम्ही शांत राहिला नाही तर मी तुमचा डोळा काढून हातात देईल आणि घरी पाठवेल. चुप बैठली. आय फिनिश माय सर्जरी, वेंट एड, एव्हरीथिंग वेंट फाईन. ॲट द एंड आय जस्ट टोल्ड हर, मावशी ऑपरेशन झालं, चला जायचं आता. नीचे से नो रिस्पॉन्स. आई सेड, मावशी काय त्रास झाला का तुम्हाला? नो रिस्पॉन्स. मेरी बच गई यार, मुझे लगा पहुंच गई ये ऊपर. देन आई शुकर अ लिटिल बिट एंड ऑल. मावशी कसं आहे तुम्ही? मी छान आहे. मग तुम्ही काय बोलला का नाही? मी विचारलं. हो डॉक्टर, तुम्हीच तर बोललं मला काय बोलू नका म्हणून मी शांत राहिले. हे राम. आय एम श्योर दीज थिंग्स मस्ट हैव हैपेंड टू ऑल ऑफ यू ऑल्सो सिमिलर, बट ये होता है. देन देयर वाज दिस अदर इंसिडेंट. It was a young girl, a Maharashtrian girl actually. Patients come to us for various problems, and also she comes in and she looks down and says, डॉक्टर साहेब हे फार मोठं आहे, मी कसं घालणार, मला फार भीती वाटते हो. नाही मी कधी ह्याच्या आधी कधी केलंच नाही, हे माझ्या जाणारच नाही. असं तुम्ही घ्या, फार सोपं आहे, घालता येईल तुम्हाला. नाही मी कधी केलं नाही. नाउ इमेजिन वो सारा बाहर बैठा हुआ बंदा, द वॉल्स वर क्वाइट थिन, यू मस्ट बी थिंकिंग क्या चल रहा है अंदर ये सब. मैं उसको नहीं काही त्रास नाही आहे, तुम्ही करा, मी तुम्हाला पाहिजे हात धरतो. सो आय हेल्ड द हँड अँड पुट इट इन. शी सेज, ओ डॉक्टर साहेब ते तुम्ही घातलं तर किती सोपं होतं, मला अजिबात केलं आलं नसतं. तुम्ही हे आणि तुम्ही कॉन्टॅक्ट लेन्स कधी आयुष्यात कधी घातलेच नाही, म्हणजे मला इतकं कम्फर्टेबल वाटतं आणि सगळं छान पण दिसतंय. सो यू कॅन इमॅजिन दिस मिसअंडरस्टँडिंग. वो बाहर सोचता रही ना अंदर क्या चल रहा है. आई मीन it can be interpreted in each way. And there was this third incident which I would like to tell you. This patient who had come in, she's looking at me and says, डॉक्टर साहब आपको बहुत छोटा है, जरा ऊपर करो तो मुझे दिखाई देना. एक तो यहाँ पर पूरा अंधेरा है, मुझे कुछ भी दिख नहीं रहा है. छोटा है, ऊपर करो. So, हाँ ऊपर करो, मुझे कुछ दिखाई नहीं रहा है. So I just looked at her. I took my status chart up and she says, हाँ अभी देखो मुझे अच्छी तरह दिखाई दे रहा है ना. So these things happen in the OPD. You guys have a great time. Enjoy. All the best.
Thank you.
मेरा दुपट्टा उठा के लाया यार वे, जोगी जाता बरेली के बाजार में. मैं तो ठुमका लगा के शर्मा गई, बोली घूमकर बता दे के मैं आ गई. मुझको लगा के नाचने मेरी यार,
कैटवॉक वाली बेबी है तेरी चाल, बैकलेस सूट विच लगदी कमाल. ओ किथे चली जांदी है, ओ किथे चली जांदी है. तेनू पुछना है कोई सवाल, ओ दस दे कुमारियां किस दे तू नाल, क्यों दूरों दूरों जानी है, जान कद जानी है. एने मेरा खरे तू करना सोनिए, एने मेरा खरे तू करना सोनिए. दिल मेरा तेरे लिए धड़के नी, अज फिर किथे, अज फिर किथे, अज फिर किथे चली है. मोरनी बनके, मोरनी बनके, अज फिर किथे चली है. मोरनी बनके, मोरनी बनके. संडे तो लेके सैटरडे तक, संडे तो लेके सैटरडे तक, करते वेट तेरी खटके नी. अज फिर किथे, अज फिर किथे, अज फिर किथे चली है. मोरनी बनके, मोरनी बनके.
एवें चली मोरनी बनके.
वेरी गुड, बहुत अच्छे, बहुत बढ़िया.
Wow.
अरे वा वा, आमच्याकडे आज निळू भाऊंचा यायचा योग आलाय. वा वा, अलभ्य लाभ, अलभ्य लाभ. या या बघा. अरे संध्याकाळचे 7:30 झाले, यायला लागू असा विचार आला, डायरेक्ट तुमच्याकडे आलो. हो अरे वा वा. हो ऐकलं का, प्यायला लागू असा विचार डोक्यात आला आणि आपल्याकडे आले. हो म्हणजे बहिणी कोणतरी महापुरुष म्हणले, पिता 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 व्हायचं, म्हणून आम्ही पितो, आमचं काही नाही. हो हे बाकी बरोबर बोलला तिळू भाऊ. पिता पिता चांगला पिता होता येणार. चला तर मग प्यायला लागू आणि फुले. पिता होऊ चांगले, चांगली होतील मुले. हो अगदी.
माझे यजमान डॉक्टर शंतनू अभ्यंकर यांची कोकिळा ही कविता मी सादर करणार आहे. वरवर पाहता ही एक ग्रामीण बाजाची भाबडी निसर्ग कविता आहे आणि खोलवर पाहता यामध्ये झाडांच्या पानांमध्ये लपलेली मनाला हुरहुर लावणारी ही कोकिळा आहे. ती एखाद्या न दिसणाऱ्या दूरवर असणाऱ्या सुखासारखी आहे, ज्याचा पाठलाग आपण सगळेच सदैव करत असतो. तर कोकिळा. कोकिळा बोलाची रायना अन मला कोकिळ घावना. कोकिळा बोलाची रायना अन मला कोकिळ घावना. कोकिळा कुहूक बोलिते कोकिळा नावानं बोलाविते. कोकिळा कुहूक बोलिते कोकिळा नावानं बोलाविते. उन्हात मृगजळ कोकिळा अन मला कोकिळा घावना. कोकिळा बोलाची रायना अन मला कोकिळा घावना. कोकिळा बोलते रामाच्या पारी कोकिळा बोलते सांजेला दारी. कोकिळा बोलते रामाच्या पारी कोकिळा बोलते सांजेला दारी. जीवाची तगमग कोकिळा अन मला कोकिळा घावना. जीवाची तगमग कोकिळा अन मला कोकिळा घावना. कोकिळा बोलते मंजुळ गाणी कोकिळा गाण्यांच्या राण्यांची राणी. कोकिळा बोलते मंजुळ गाणी कोकिळा गाण्यांच्या राण्यांची राणी. मधात चांदण कोकिळा अन मला कोकिळा घावना. मधात चांदण कोकिळा अन मला कोकिळा घावना. कोकिळा लावते जीवाला पिस कोकिळा मनाचं करते हास. कोकिळा लावते जीवाला पिस कोकिळा मनाचं करते हास. म्हणूनच गाते कोकिळा अन मला कोकिळा घावना. कोकिळा बोलाची रायना अन मला कोकिळा घावना.
तकदीर से बिगड़ी हुई तकदीर बना ले. तकदीर बना ले अपने पे भरोसा है तो ये दाव लगा ले. लगा ले दाव लगा ले. तकदीर से बिगड़ी हुई तकदीर बना ले. तकदीर बना ले अपने पे भरोसा है तो दाव लगा ले. लगा ले दाव लगा ले.
क्या बात है.
डरता है जमाने की निगाहों से भला क्यों. निगाहों से भला क्यों. डरता है जमाने की निगाहों से भला क्यों. निगाहों से भला क्यों. इंसाफ तेरे साथ है इल्जाम उठा ले. इल्जाम उठा ले अपने पे भरोसा है तो ये दाव लगा ले. लगा ले दाव लगा ले. क्या खाक वो जीना है जो अपने ही लिए हो. अपने ही लिए हो. क्या खाक वो जीना है जो अपने ही लिए हो. अपने ही लिए हो. खुद मिट के किसी और को मिटने से बचा ले. मिटने से बचा ले अपने पे भरोसा है तो दाव लगा ले. लगा ले दाव लगा ले.
Very nice.
ये रातें ये मौसम नदी का किनारा ये चंचल हवा
ये रातें ये मौसम नदी का किनारा ये चंचल हवा ये क्या बात है आज की चांदनी में ये क्या बात है आज की चांदनी में कि हम खो गए प्यार की रागनी में
ये बाहों में बाहें ये बहकी निगाहें लो आने लगा सितारों की महफिल ने करके इशारा कहा अब तो सारा जहां है तुम्हारा
मोहब्बतें जवां खुला आसमां करे कोई दिल आरज़ू और क्या
ये रातें ये मौसम नदी का किनारा ये चंचल हवा कसम है तुम्हें तुम मगर मुझसे रूठे रहे सांस जब तक ये बंधन न टूटे
तुम्हें दिल दिया है ये वादा किया है सनम मैं तुम्हारी रहूंगी सदा
ये रातें ये मौसम नदी का किनारा ये चंचल हवा
कसा वाटला आमच्या तुमचा परफॉर्मन्स
खूप
मंडळी
छान
आमचं
खूप
नेटवर्क
छान
असलं तरी आमचं टॅलेंट फास्ट आहे हे तुमच्या सगळ्यांच्या लक्षात आलंच
Very
असेल
nice. Very nice.
थँक्यू
Very
एव्हरीवन
very nice.
आणि हा प्लॅटफॉर्म आम्हाला दिल्याबद्दल महाराष्ट्र नेत्रतज्ञ संघटनेचेही वेस्ट झोनचं कोऑर्डिनेटर या नात्याने मी मनापासून आभार मानते पुन्हा भेटूया पुढच्या वर्षी टिल देन स्टे कनेक्टेड स्टे एंटरटेन्ड अँड स्टे
Very
सेफ
nice. Very good.
Thank you so much.
Super,
Thank you for the
super.
patient listening and the appreciation. Thanks a lot.
All the performances were very good.
मूवी बघतोय असं वाटत होतं
Yeah.
एक व्हिडिओ बघतोय
It was
अच्छा,
really
बहुत
well
बढ़िया,
coordinated, huh? Judges, any
Thank-
comments?
Yes.
थँक यू सो मच
बहुत
थँक
अच्छा,
यू
बहुत ही बढ़िया और बहुत अच्छा टेम्पो और पूरे इमोशंस को वो लफ्जों के जो बयानात है वो उसे बहुत अच्छी तरह से वो कर रहे थे
थँक्यू सर थँक्यू
नहीं
सर
था कि थोड़ा सा लॉन्ग शॉट थे लेकिन वो बहुत अच्छा लगा
तुमचं पॅकेज
Welcome.
होता म्हणजे पूर्ण पॅकेज मिमिक्री आलं त्याच्यामध्ये पोयम
हो.
आलं जोक्स आले डान्स आले गाणं आलं
Yes.
फुल पॅकेज होता तुमचा खूप खूप अभिनंदन तुम्ही डोळेने आता दिल का डॉक्टर बन गए आप
क्या
लोग.
बात आहे थँक्यू सो मच हाऊ काइंड सगळे सुपर होते म्हणजे आता शेवटचा डान्स बघताना पण असं वाटत होतं की आपण एखादा टीव्हीवर एखादा लाईक से एकदम सुपर कसलेले कलाकार असतात ना ते करतायत
फ्लोलेस डान्स
हा
असं
असे
येस
Yes.
येस विल
Agree.
शुअरली कन्वे टू ऑल आवर पार्टिसिपेंट्स आय एम सो हॅपी थँक्स
Well done. Well done. Vajanti and Monica, your team did very good.
थँक्यू थँक्यू
यस यस
Welcome.
डेफिनेटली डेफिनेटली सारे
Um,
कलाकार सब लोग जो थे वो बहुत ही सुलझे हुए थे बहुत अच्छे लय में थे सुर में थे
येस
और
थँक्यू सर थँक्यू सर
उनका जो कॉन्फिडेंस जो था वो बहुत ही खूबसूरत था काबिले तारीफ था
Thank you, sir, for your comments. Now, next we come to our own zone, the central zone. Manish, Nikhil, you'll
Yes,
go
ma'am.
ahead and say what you'll have to say.
I
Well,
think, yes,
Yeah, Nikhil.
Manish.
बोल
I think we all work very, we are very well connected, and every year we think how will we do something better. So this time we got something very unique. I'm sure you guys are going to love it. Manish, what do you feel?
Yeah. So we actually had a phenomenal time, a ball of a time, recording the whole thing, and we started off and जैसे concept बनता चला गया, we kept on enjoying more and more. So we enjoyed it. Let's hope
I hope
all
you
of
all
you like
enjoyed.
it too.
Yes. And I hope you'll enjoy our goat.
Yes.
नाउ कंप्लीटिंग वेस्ट जोन अभी हुआ ना वेस्ट
हाँ वेस्ट हुआ मैम अब
West
सेंट्रल
zone.
आ रहा है हमारा
Central,
जोन अब ये
central.
अगला हमारा जोन आ रहा है सेंट्रल जोन
ये CST
वाह
CST
वाह
Yes.
पीयूष
वेलकम वेलकम
हमारे लिए भी
Welcome.
जोरदार तालियां बचा
बिल्कुल बिल्कुल आई एम अनबाइस्ड सबके लिए बजाऊंगा ताली
मिलन नाम है मेरा और ये है मेरी स्टोरी। देखो तो मेरे दिल की किसने की चोरी। एक मदन मंजरी मिली मुझे, चमत्कार हुआ। रैना नाम था उसका, उसके प्यार में मैं बीमार हुआ। यूं ही राह चलते जिंदगी की हमदम का दीदार हुआ।
पोएम प्रीति देशमुख।
राह चलते जिंदगी की हमदम का दीदार हुआ, आकर सनम की रफाकत दिल गुले गुलजार हुआ। बरसती रही बूंदे अजमत की रूहानियत का भी एहसास हुआ। मुसलसल ये राब्ता इस ख्वाबीदा का ख्वाब हुआ। मगर वो मोहब्बत ही क्या जिसका सफर आसान हुआ। वक्त के तूफान से दिलदार फिराके यार हुआ। उल्फत ने ऐसी बदली करवट, अक्स आईने से जुदा हुआ। कुदरत का एक कहर, कुदरत का एक कहर और अफसाना इख्तिताम हुआ। अफसाना इख्तिताम हुआ। थैंक यू।
क्या बात है,
क्या बात है।
अरे मिलन की माँ, सुनती हो? अपने बेटे ने रैना को पसंद किया है। ये देखो, तेरे मेरे मिलन की ये रैना। জানি রে যদি তারে নাই চিনি গো সে কি
तेरे मेरे मिलन की रहना ओ तेरे मेरे मिलन की रहना नया कोई गुल खिलाएगी नया कोई गुल खिलाएगी तभी तो चंचल है तेरे नैना देखो ना तेरे मेरे मिलन की
आइए आइए मैं हूँ रैना का पिता कुछ लेंगे मेरे साथ पानी या शरबत मैं लूंगा रंग शरबतों का तू लेना मीठे घाट का पानी
तूने जो देखा है तूने जो जाना है वो भी नहीं भी हूँ मैं वो चाहोगे तुम जैसा हो जाऊंगा वैसा चाहो तो वादा ये ले लो तुम एक मुसाफिर हो मैं कोई राह अनजानी तुम एक मुसाफिर हो मैं कोई राह अनजानी मन चाहा मोड़ दे तो मेरे यार बात बन जाए शरबतों का मीठे घाट का पानी मैं रंग शरबतों का तू मीठे घाट का पानी मुझे खुद में घोल दे तो मेरे यार बात बन जाए शरबतों का तू मीठे घाट का पानी
क्या तुमने मेरे सोफे पे शरबत गिरा दिया है Are you a clumsy man? Clumsy नहीं जी I'm a पागल stupid man
गुनगुनाती है ये हवाएं गुनगुनाता है गगन गा रहा है ये सारा आलम
Zubidu Parampam Zubidubi pampara Zubidubi parampa Zubidubi nache kyun pagal stupid man
Zubi pampara Zubi parampam Zubi nache क्यों पागल stupid man
शखों पे पत्ते गा रहे हैं फूलों में भंवरे गा रहे
दीवानी किरणें गा रही है ये पंछी गा रहे
वो बगिया में दो फूलों की हो रही है गुफ्तगू जैसा फिल्मों में होता है हो रहा है हूबहू
Zubi pampa
वेरी नाइस बहुत बढ़िया
Zubi nache क्यों पागल stupid man
Zubi pampara Zubi parampa Zubi nache kyun pagal stupid man
बहुत बढ़िया
क्या तुम मेरा मजाक
ओरिजिनल बोल गए
तुम्हारे मैं टुकड़े टुकड़े कर दूंगा तुम्हारी जो दिल है ना दिल उसकी चैन खोल दूंगा सारा खून बाहर आ जाएगा कि तुम्हारे नैन है ना नैन उसको मैं निकाल के रास्ते पे फेंक दूंगा क्या दिल ये बेचैन हुए रास्ते पे नैन हुए
वाह
दिल ये बेचैन हुए
माफ करो, ये मंजुलिका को मेरे ऊपर मत छोड़ो प्लीज प्लीज। मैं कुछ भी करने को तैयार हूँ, आप जो बोलो। मैं नाचू, मैं कोई गीत गाऊं, क्या आरज़ू जगाऊं, अगर तुम कहो।
बहुत अच्छे।
क्या बात है। बस कर पगले, अब रुलाएगा क्या? तूने तो मेरा दिल छीन लिया। तूने तो मेरी बोलती बंद कर दी।
पहला नशा, पहला खुमार, नया प्यार है, नया इंतजार। कर लूं मैं क्या अपना हाथ, ऐ दिले बेकरार, मेरे दिले बेकरार, तू ही बता। पहला नशा, पहला
तुम्हें अपना बनाने की कसम खाई है तेरी आंखों में चाहत ही नजर आई है।
ये हवाएं जुल्फों में तेरी गुम हो जाए,
ये हवाएं जुल्फों में मेरी गुम हो जाए।
तुम इतना जो मुस्कुरा रहे हो, तुम इतना जो मुस्कुरा रहे हो, क्या गम है जिसको छुपा रहे हो, क्या गम है जिसको छुपा रहे हो, तुम इतना जो मुस्कुरा रहे हो। छन से जो टूटे कोई सपना, जग सुना सुना लागे, जग सुना सुना लागे, कोई रहे ना जब अपना। जग सुना सुना लागे, जग सुना सुना।
वो मेरी नींद मेरा चैन मुझे लौटा दो। वो मेरी नींद मेरा चैन मुझे लौटा दो। वो मेरा प्यार मेरा दर्द मुझे लौटा दो।
वेरी नाइस, वेरी नाइस,
वाह,
वेरी
क्या बात
ब्यूटीफुल।
है,
क्या
क्या
बात है,
बात है।
बहुत ही बढ़िया,
क्या
बहुत ही
बात है।
बढ़िया।
Thank you
नाइस
for the
सिलेक्शन एंड क्या,
appreciation.
थैंक यू।
बहुत अच्छा, बहुत बढ़िया।
थैंक यू सो मच सर, थैंक यू।
Thank
ग्रेट
you
ग्रेट,
very much.
ऑल सारे जितने भी गाने को जो रियलाइजेशन दिया, नया 2 मायने दिया, वो बहुत ही खूबसूरत था, बहुत बढ़िया।
पूनमताई तुम्ही म्हणत होता ना, निखिलला तुम्ही बांधून ठेवलं, इथे सोडलं आम्ही त्याला
सोडलं.
शारंगाई
अरे पण
सोडली.
निखिलला एवढं शांतपणे डान्स करताना बघवत नाही.
त्याला मला
बहुत
सांगावं
अच्छे.
लागलं, त्याला एक एक्सप्रेशन द्यायला नको, एकदम स्ट्रेट फेस पाहिजे.
हो, नाहीतर तो राम लखन सारखं नाचतो.
I was
Very
त्याला
nice,
असं
very nice.
बघायला
supervising
बरं
him from the
वाटतं.
back.
माय गुडनेस, सिरियसली
वो-
हे
वो
हे
मेरा-
एक आपल्यासाठी सरप्राईज आणि ट्रीट आहे म्हणजे.
खरं आहे.
और जग
हाँ,
जग
विनय
और चेन को खूब अच्छा निभाया उन्होंने.
आज का शाम किस किस के नाम करे हम.
बिल्कुल सही, बिल्कुल सही. बहुत अच्छे, बहुत बढ़िया.
कितने
थैंक यू,
ऑप्शन.
थैंक यू।
Thank you very much.
यूथ
आप सब
फेस्टिवल
लोगों
में
की मेहनत जो है वो सफल हो गई. वेरी नाइस.
धन्यवाद सर, धन्यवाद, धन्यवाद.
एक कोण आहे इथे?
हम यूथ फेस्टिवल में मुंबई यूनिवर्सिटी से जाता है तो सारे कॉलेजेस के परफॉर्मेंस देखते हैं एवरी ईयर. तो अभी
चार्जर
आ रहे थे कि हम लोग यूथ को
पटकन दे.
लग ही नहीं रहे थे कि डॉक्टर
चार्जर
इतने अच्छे परफॉर्म कर रहे हैं.
नहीं, अभी ये डॉक्टर जरा क्वेश्चन मार्क हो गया. डॉक्टर कम है, आर्टिस्ट ज्यादा हो गए.
इसी में मजा ज्यादा आता है. In fact,
आप
we
भी
have more
कुछ कम
charge for
नहीं
the
है यार.
we have more
आप भी
charge for
कुछ
the
कम नहीं है.
cultural event.
आप तो एकदम डिंचक नाच रहे हो बिल्कुल.
वो सबकी लीडर है, सबकी माँ है.
हाँ.
और जो उनके
हाँ,
बाजू में
वही
मनीष बैठा है ना, ये पूरा माइम है कि उन्होंने कॉन्सेप्ट किया है पूरा. सो
वेरी नाइस, वेरी
पर्दे
नाइस.
के
बहुत
पीछे के
बहुत सबको
कलाकार.
बहुत बहुत बधाई हो.
Thank you.
मैडम, उनके
धन्यवाद
धर्मेंद्र
सर.
वाली आवाज सुननी चाहिए आपको. मनीष कुछ बोलिए.
कौन क्या क्या?
हमें ये एक्ट करने में बहुत मजा आया.
और एक लाइन मनीष.
बाकी अब जो कुछ भी कहेंगे प्राइज जीतने के बाद ही कहेंगे मैडम.
आप
सही.
प्राइज जीत गए.
अभी रुको.
धन्यवाद सर. नहीं नहीं सर, सबने
अभी
बहुत
2
अच्छा
जोन
किया सर.
बाकी है, 2 बाकी
अभी
है.
है,
दो
बाकी है
बाकी है.
सर. पिक्चर अभी बाकी है.
We go over now to Marathwada. Let the zone head of Marathwada please come forward. Come forward.
मराठवाडा.
Good evening, everybody, respected judges and office bearers of.
Let me introduce her. She is one of our very senior, very dear members, Dr. Sunaina Malik, and she's a darling. And she is so enthusiastic and she dances so gracefully, and we just love her.
Oh,
Thank-
very good. We'd love to see her.
So, at the peril of sounding
Participating.
politically incorrect, I
Uh,
hope everybody has seen Madam's video of
Physical DOA conference. I welcome you all to the Marathwada segment. I'm the group leader along with my colleagues, Cheta Vishwe, who helped a lot in the editing and the video editing, because she was the one who went and got it done. And I'd like to introduce my act because I'm giving the introduction. We are going to begin with a typical Marathi Gondar by our girls,
Okay. Wow.
वाव.
Doctors Mansi Bang, Dr. Sheetal Solanke, Pallavi Khedkar, Rupali Panse, Aarti Mangulkar, and Sri Lata Devde. You'll love it. And followed by a dhamakedar Gana by Dr. Rupa, followed by a mono act by our very own Dr. Mansi Bang. All these people are from Chhatrapati Sambhaji Nagar, earlier Aurangabad. And then we have another Tadakta Tadakta song by Dr. Sunita Gopan Pallikar. And finally, a fabulous, sexy dance
by Dr. Mrunmayee Ambekar from Jalna. So here we go. And I told you, you'll love it.
Wow.
Lights, please. 1, 2, 3, music.
साऱ्या या जगाला तू संजीवनी देते, उग्र रूपा मागे सुद्धा वात्सल्य वाहते. तुझ्या कृपा दृष्टीचे मी दान मागते, गोंधळ मांडिते ग आई गोंधळ मांडिते.
आई जगदंबेच्या नावानं उधा उधा.
सरर होलिका जले शत्रु राह में मिले हमने, जब जब शमशीरें ताने है माए भवानी. नन आंधियां उठे शत्रु जड़ से ही मिटे हमने, बात यही मन में ठाने है माया भवानी. हम सब मर्द मावड़े बड़े खुददार हैं, अब हर एक दिन स्वराज का त्योहार है. अब ये शीश ना झुके तेरी लाज हम रखे, तेरे चरण की शपथ मां जगदम्बे है माया भवानी. जय माया भवानी. नदीच्या पल्ल्याड आईचा डोंगर, नदीच्या पल्ल्याड आईचा डोंगर, डोंगर माझ्याला देवीचं मंदिर, डोंगर माझ्याला देवीचं मंदिर. आलू जागर जागर डोंगर माथ्याला, आलू जागर जागर डोंगर माथ्याला, गेला लाठी भंडार दूर लोटून दे अंधार.
टाळ्या कुठे टाळ्या. हे हे हे. टाळ्या झाल्या पाहिजे. Lovely performance.
भंडार दूर लोटून दे अंधार, आलो दूरून रांगून
ओ क्या बात है.
कमाल. वाह, क्या बात है. आई भवानीचा उदो.
जब छाए मेरा जादू, कोई बच न पाए. हाँ, जब छाए मेरा जादू, कोई बच न पाए. आए फिर भी हाथ न आए। हाँ जब छाए मेरा जादू कोई बच न पाए। हाँ कभी मैं दर्द जगाती हूँ, कभी मैं जख्म मिटाती हूँ, कभी मैं दर्द जगाती हूँ, कभी मैं जख्म मिटाती हूँ, कभी मैं राज छुपाती हूँ, कभी खुद राज बन जाती हूँ। दिल टूटे हंसा छूटे फिर भी तू पीछे आए। हाँ जब छाए मेरा जादू कोई बच न पाए। हाँ भाजी गया भाजी ताजी ताजी भाजी, भाजी घ्या भाजी ताजी ताजी भाजी। राम राम मंडळी, कस काय बरं आहे का? ते तुमच्या ऑर्गनायझिंग मॅडम आहेत ना, त्या मला म्हणाल्या इथे फक्त डॉक्टर येणार आहेत प्रोग्राम बघायला. म्हटलं थोडी भाजी घेतील की एखाद दुसरं काहीतरी आपलं, तेवढंच आपल्याला आधार म्हणून आले बघा. काय बाई किती पायपीट झाली. दादा जरा हात लावा की टोकराला. काय बाई आजकालची लोक त्या जिम मध्ये 20-30 किलो असं उचलतील, फोटो टाकतील, पण या भाजीच्या टोकरीला हात लावणार नाही कोणी. सगळं नुसतं त्या इंस्टाग्राम साठी सगळं असं दाखवायचं फक्त शोबीज. पण आता कसं जग किती बदललंय ना, आजूबाजूला सगळे कसे असे अपडेटेड व्हायला लागलेत. आपलं छोटं दृष्टी कसं मोठं झालं. सासवडे सरांचं 1 बिल्डिंगच्या 2 बिल्डिंग झाल्या. सगळे कसे असे अपडेट व्हायला लागलेत की नाही. मला वाटलं आपण आपलं भाजीचा धंदा थोडा अपडेट करावा, पण आता अपडेट करणं काही सोपं थोडी आहे. आपल्याला काही आयडिया लागतील, थोडाफार हातभार लागेल. म्हटलं जरा चांगल्या लोकांना विचारावं कसं काय अपडेट करायचं, काय करायचं. म्हणून मी गेले आपल्या संतोष अगरवाल सरांकडे बरं का. त्यांचं ते सुशीला नेत्रालय त्याच्यासारखेच अगदी सुशील आणि गुणी आहेत बरं का सर, अगदी डाऊन टू अर्थ. सरांना म्हटलं मी सर मला बिझनेस एक्सपांड करायचा, भाजीचं आता टोकरी घेऊन नाही फिरायचं, मला आता दुकान टाकायचं भाजीचं. तर सर म्हणे भाजी कशाला, डू समथिंग बेटर. म्हटलं नाही सर भाजी कशी एव्हरग्रीन आहे, 12 महिने आपल्याला लागते. तुम्ही व्हेज खा नाही तर नॉन व्हेज खा, तुमच्या चिकनला आणि फिशला टेस्ट कशी येणार. तुम्हाला कांदा लसूण तर लावाच लागेल ना, ते आहे की माझ्याकडे. म्हणून म्हटलं सर भाजी आपली एव्हरग्रीन आहे. सर म्हणे ठीक आहे ठीक आहे, भाजी तर भाजी, पण आता जर तुला एक्सपॅन्ड करायचंय तर यू शुड थिंक, तुला असं एक ब्रँड अँबॅसेडर विचार करावा लागेल. तुझ्या दुकानासमोर असा फोटो की जेणेकरून लोक इन्स्पायर होतील. ब्रँड अँबॅसेडर म्हटलं की माझी ट्यूब पेटली. मला फक्त दिसले विश्वेंची सून आपली चेता हो आणि विश्वेंची मुलगी आपला आरती मॅडम. किती मेंटेन्ड आहेत, किती मेंटेन्ड आहेत. त्या दोघींचा फोटो माझ्या दुकानासमोर लागला की अशी लाईन लागेल. यांची भाजी खाल्ली की आपण असेच राहू, है की नाही. बरोबर आहे की नाही, पटलं की नाही तुम्हाला. मी अगदी फिक्स करून टाकलं की त्यांनाच आपल्याला ब्रँड अँबॅसेडर बनवायचंय. मग सरांचा सल्ला आवडला आपल्याला, सरांना थँक्यू म्हटलं. म्हटलं आता अजून पुढे जावं आपण थोडंसं. पायपीट करत करत उन्हात तानाची गेले बाई मी, पोचले आपल्या सासवडे साहेबांकडे. तर पण अगदी डाऊन टू होतं, लगेच ते अगदी सल्ला वगैरे सगळं देतात. खूप एक्सपिरियन्स आहे ना सरांचा. सर मला म्हणे की हे बघ मानसी, तुला जर एक्सपांड करायचं आहे
तुला चांगला बिझनेस करायचा आहे तर तू अशा 4-5 मशिनी घेऊन टाक. तुझी भाजी अशी 4-5 मशिनीतून बाहेर काढून द्यायची. डबल भाव मिळेल तुला, डबल. लोकांना वाटतं काय फर्स्ट क्लास भाजी आहे, सगळे मायक्रो ऑर्गॅनिझम्स गेले, एकदम स्टराईल भाजी, टेस्टी भाजी मिळाली आपल्याला. सरांना धन्यवाद केला मी. सर थँक्यू, खूप छान सल्ला दिला तुम्ही. तिकडून निघाले, थोडस पुढे चालत गेले, म्हटलं रिक्षा बिक्षा काही बघावी आपली. तर मागून मला हाक मारली. कोणी हाक मारली? अहो आपल्या सोनाली मॅडम, सोनाली भांगे मॅडम. त्यांना मी माझा प्रकल्प सांगितला की मला असं असं माझा बिझनेस अपडेट करायचा. सोनाली मॅडम म्हणे तुला बिझनेस अपडेट करायचा ना, फर्स्ट यू अपडेट युअर सेल्फ. असं छान ड्रेस घाल, छान साडी घाल, असं छान फोटोशूट कर, मग तुझा बिझनेसही अपडेट होईल. म्हटलं वा मॅडम, छान छान, थँक्यू मॅडम, खूप छान सल्ला दिला. थोडीशी पुढे गेले तर मागून जोरात एक फटका बसला मला. मागून वळून बघते कुठे तर दिसलं मला वंदना मॅडम. बॅडमिंटनचा शॉट मारला होता मॅडमनी, डायरेक्ट शटल माझ्या पाठीला. मॅडम काय बॅडमिंटन खेळतात, कोणी हातच पकडला मॅडमचा बॅडमिंटन मध्ये. सरांनी पकडलाय तेवढा. पण बॅडमिंटन मध्ये मॅडम फर्स्ट क्लास. म्हणजे मी अगदी ऍडमायर करते हो मॅडमना. मॅडमना मी सांगितलं की असं असं माझा विचार आहे. मॅडम म्हणे गुड गुड, चांगलं आहे मानसी, पण व्हॉट आय वुड सजेस्ट, ठीक आहे तुला भाजी विकायची आहे ना, विक तू, पण तुझ्या भाजीच्या दुकानाच्या बाजूला एक स्पोर्ट्स ऍक्टिव्हिटी पाहिजे. जे भाजी घेतील त्यांनी स्पोर्ट्स ऍक्टिव्हिटी करायची आणि मग घरी जायचं. म्हणजे तुम्ही कसे खाऊन पिऊन फिट अँड फाईन राहाल. म्हटलं मॅडम खूप छान सल्ला तुम्ही, थँक्यू मॅडम, खूप छान सल्ला दिला. आता सगळ्यांचे सल्ला ऐकले, एवढ्या उन्हात फिरले, डोकं अगदी गरगरायला लागलं. म्हटलं जरा देवाचं नाव घ्यावं, शांत बसावं. म्हणून मला आठवण आली आपल्या श्रीकृष्ण नेत्रालयाची बरं का. गेले श्रीकृष्ण नेत्रालयमध्ये, तिकडे भेटले ना आपले डॉक्टर साहेब, बंग साहेब भेटले. त्यांना आपलं राम राम केलं मी. तेवढ्यात डॉक्टर साहेब मला म्हणाले, अगं मानसी उठ, आता चहा नाश्ता तयार आहे, उठ नाश्ता कर. आणि मी असे खाडकन डोळे उघडले. थँक्यू.
व्हेरी गुड.
ये मेरा दिल प्यार का दीवाना
मर गई, हुई अम्मा मैं तो टूट के बिखर गई, हुई अम्मा, हुई अम्मा, हुई अम्मा, हुई अम्मा, चुई मुई से हिरनिया, हुई अम्मा, काले भेड़ियों से डर गई, हुई अम्मा, हुई अम्मा, हुई अम्मा। अम्मा हाय हाय मैं तो मर गई, हुई अम्मा मैं तो टूट के बिखर गई, हुई अम्मा, हुई अम्मा, हुई अम्मा, हुई अम्मा, चुई मुई से हिरनिया, हुई अम्मा, काले भेड़ियों से डर गई, हुई अम्मा,
वेरी गुड, बहुत अच्छा, बहुत वेरी नाइस,
Sir,
बहुत ही बढ़िया, बहुत ग्रेसफुल।
sir, we kept it.
बहुत ही बढ़िया।
Can't hear you, ma'am. Can't hear you.
जैसे गिरने वाले सब performance.
Present. I would like to hear what the judges want to say.
बहुत ही खूबसूरत.
शेवटचा डान्स तर असं वाटत होता की म्हणजे रवीना टंडनची मुलगी पण बाजूला राहील. एवढं
Yes,
हॉट
yes,
आणि
yes.
एवढं फ्रेश आणि एवढा बेस्ट होता डान्स. आणि पहिल्याचा गोंधळ हा महाराष्ट्राचा शान असलेला गोंधळ एवढा छान परफॉर्मन्स दिलेला आहे. एक नंबर झालेला आहे. मराठवाडा जिंदाबाद.
येस ऍक्च्युली इतकं सिंक्रो आणि हे इतकं छान म्हणजे इतकं ग्रेसफुल केलेलं आणि आता हा शेवटचा डान्स सुद्धा इतका ग्रेसफुल की ते म्हणतात ना की आपण डॉक्टर किंवा काय ते सगळं बाजूला ठेवून यू नो वो आइडेंटिटी एक साइड में रख के पूरे ग्रेस पूरे दिल से किया है.
बिल्कुल.
वो देख के ऐसे लग रहा था कि यहाँ पे बैठे कि उनको ज्वाइन हो जाए.
दिल से बहुत प्रोफेशनली किया, बहुत प्रोफेशनली किया.
मला वाटतं पुढच्या पिक्चर मध्ये त्यांना म्हणजे हिरोईन म्हणून घ्यायला हरकत नाहीये. मस्त. खरंच आहे.
यू नेवर नो कब कहाँ कैसे मौका मिल जाए.
सर मैम मैंने अपने बेटे को ये दिखाया था पूरा क्लिप, तो ही टोल्ड मी कि माँ आप तो उसमें हो नहीं, तो व्हाई आर यू डूइंग दिस? So I said I don't have to be in it every time. I'll dance physically at the next BOA or MOS conference. Let the youngsters also do their bit, because I think a senior is one who takes everyone along with them.
लेकिन आपका डांस देखने में भी हमें बहुत अच्छा लगता था अगर आपका एक झलक भी हो जाता तो.
आप बॉम्बे ऑफ्थल में आइएगा, पूरा का पूरा डांस देखने को मिलेगा आपको. सुना है मैम का.
जी जी जी.
बहुत बढ़िया.
थैंक यू मैम, आपने बहुत बढ़िया ट्रीट दिया है आज हम लोगों को. थैंक यू सो मच.
Thank you so much for your nice comments. I'm so happy. मेहनत सब.
सबकी मेहनत बहुत बेहतरीन थी.
हमें ये देखना मिल रहा है, ये हमारे लिए बड़ी बात लग रही है अभी. बहुत थैंक यू.
Invitation is open to you all to come for our BOA cultural, which is in Mumbai only.
हाँ, मुंबई में है. जब भी रहेगा तभी आप हमें पक्का इनविटेशन देना.
फर्स्ट अगस्त को है वेस्ट एंड में, फ्राइडे इवनिंग. निखिल will inform you. Please come. It will be a pleasure to have you.
हमारा सीट पक्का बुक कर देना.
सीट आपको स्टेज पे भी आना पड़ेगा, आपको छोड़ेंगे नहीं. आपका डांस लोगों ने.
ये प्रॉमिस है.
बहुत बढ़िया, बहुत बढ़िया.
Thank you so much. And now we call the final team to come and present Vidarbha team.
Vidarbha.
Good luck, Vidarbha.
Dr. Rafat?
Are they there?
I don't know.
Have his number. You want?
Shirish, did they manage to merge it? Did they do it?
No, Dr. Rafat is not there. He tried to get it done and
नहीं हुआ क्या गिरीश?
वो सर इंडिविजुअल वाले जो इंडिविजुअल प्ले कर सकते हैं ना एक एक जन को, वो लोग अगर नहीं होगा तो अपना स्क्रीन शेयर से पूरा एक नहीं हो रहा तो इंडिविजुअल प्ले तो कर सकते हैं।
करो मैडम की तरफ भेजा मैंने इंडिविजुअल। मैडम आपके पास है इंडिविजुअल कुछ?
इंडिविजुअल है उनका मेरे पास, बट आई वांटेड इट इन अ फाइल बिकॉज आई आस्क्ड सुनील, he said that I'm going to play it as a file. I won't play it as individual.
No, no, Karovi, you can play it from your screen individually because I don't think that Dr. Rafat can do it. You play it from your screen if he has sent it.
See,
At least it's have their participation.
my computer on which it is loaded is not working properly. I've taken it on another computer. Nikhil, will you be able to play it?
I'm just checking, ma'am. Give me 1 second.
Because I had sent it to him also.
Give me 1 second. Just give me 1 second.
Yeah, sure.
It's on my mail, is it?
It's on your WhatsApp.
Okay. Give me a minute. I'll do it. Oh, okay. Fine. I'll just mail it to myself and I'll try to play it. Till then,
Nikhil, if you open WhatsApp on your laptop, then you don't even have to mail it.
How to do that?
ठीक है, चल, no worries.
Just give me a second. I'll do it.
Yeah.
Till
Do it.
then, you just hold them.
The
till
Vidarbha
then.
team consists of Dr. Rafat Khan, who was going to sing a song, Nikhil Kondurwar, who's going to play the piano, Sujata Wankhede is a solo dance, Anupam Bagdi is a song, Yashpal Lamba is violin, Hita Bhagwat is song, and then there is a group dance.
Karovi, who has their individual acts? Who has it?
He had sent it to me today, I think, or yesterday. And the thing is that we had told him to compile it and send it to Sunil. And then they didn't do that. And I was trying to get in touch with him since afternoon, but I couldn't get through to him. So then when I asked Sunil whether I could send him the individual ones, because I really don't know how to club it all together. So he said no, he wouldn't like to play individual.
I have 4 videos. Do you want me to play them?
Please, Sunil, please, you can.
If you
You
have
can.
4,
Please.
the rest I can send it to you.
So I have 4 videos. I'll play them. Whatever is left, probably Dr. Nikhil or anybody else can play.
Yes, I'm
Yeah. By that time, Nikhil will download everything. You start playing so that we can
I
save on
am
time.
playing first by Dr. Nikhil.
The piano.
Yeah.
Just allow
He's
me.
a wonderful piano player.
Yeah, just give me a minute, please.
Nikhil Kondurwar.
वाओ,
Superb.
वेरी बहुत
क्या बात है।
एक्सेलेंट
क्या बात,
एक्सेलेंट
वाओ, मजा आ गया.
Next वाला सुनील.
Sunil, I have sent you the remaining also. You show them one by one.
Yeah. He is Dr. Rafat Khan.
डॉक्टर रफत खान.
Oh my नजर न लग जाए किसी की राहों में, छुपा के रख लूं आ तुझे निगाहों में, तू खो न जा. ओ माय लव, नजर न लग जाए किसी की राहों में, छुपा के रख लूं आ तुझे निगाहों में, तू खो न जा. ओ माय देख कर तेरी तरफ बहार आज हो रही है बेकरार, देख कर तेरी तरफ बहार आज हो रही है बेकरार, छू रहे हैं फूल यूं तुझे जैसे हो इन्हें भी तुझसे प्यार, ये हो न जा. Oh my love, नजर न लग जाए किसी की राहों में, छुपा के रख लूं आ तुझे निगाहों में, तू खो न जाए. Oh my मेरी हसीन दिलरुबा, मेरे दिल में छुप के बैठ जा. ऐ मेरी हसीन दिलरुबा, मेरे दिल में छुप के बैठ जा. तुझ में मुझ में फर्क ना रहे, आ करीब आ तू खो न जा. Oh my love, नजर न लग जाए किसी की राहों में, छुपा के रख लूं आ तुझे निगाहों में, तू खो न जाए. Oh my love.
बहुत अच्छे
क्या बात.
बहुत बढ़िया बहुत बढ़िया.
सामने जो एक तू न हो, दिल में कोई आरज़ू न हो. सामने जो एक तू न हो, दिल में कोई आरज़ू न हो. मंजिलें हजार हो मगर मंजिलों की जुस्तजू न हो, ये हो न जाए ओ माय
वाव.
Very
ओ माय गॉड. व्हेरी नाईस.
good feeling. Very good. Very good. Good confidence.
सीरियसली एक जोन में चले जाते हैं.
आणि गाणं आणि
Hi guys,
acting
this is
दोन्ही
Dr. Anupam Bagri. Hope you love this evergreen song from Bollywood. प्यार हुआ, इकरार हुआ, जीना यहाँ, मरना यहाँ, इन राहों को, इन बाहों को छोड़िए चलिया जाए कहाँ. मानना दिल तो है अनाड़ी, ये आवारा ही सही. अरे बोल राधा बोल, संगम होगा कि नहीं. हर जन्म में रंग बदल के ख्वाबों के पर्दों पे हम खिलते. हम है राही प्यार के, फिर मिलेंगे चलते चलते. हम है राही प्यार के, फिर मिलेंगे चलते चलते. दिल का भंवर करे करे पुकार जब प्यार किसी से होता है. जिया हो जिया कुछ बोल दो, अब दर्द सा दिल में होता है. तेरे घर के सामने घर बनाऊंगा टूटा ही सही. पल भर के लिए कोई हमें प्यार कर ले, झूठा ही सही, झूठा ही सही, हाय झूठा ही सही. हर जन्म में रंग बदल के ख्वाबों के पर्दों पे हम खिलते. हम है राही प्यार के, फिर मिलेंगे चलते चलते. हम है राही प्यार के, फिर मिलेंगे चलते चलते. ओ हसीना जुल्फों वाली जाने जहां, चाहे मुझको जंगली कह दे जाना जहां. महफिल महफिल तू फिरे, याहू याहू दिल कहे. महफिल महफिल तू फिरे, याहू याहू दिल कहे. बदल दे सितारे लपेटे हुए, हर जन्म में रंग बदल के ख्वाबों के पर्दों पे हम खिलते. हम है राही प्यार के, फिर मिलेंगे चलते चलते. हम है राही प्यार के, फिर मिलेंगे चलते चलते.
Gimana
जय शिव शंकर काटा लगे ना कंकर है कुछ कह दे जमाना मेरे जीवन साथी मेरे सपनों की रानी जिंदगी सफर है सुहाना कुछ तो लोग कहेंगे ना सुना दीजिए चैनाए मेरे दिल को दुआ कीजिए हर जन्म में रंग बदल गए ख्वाबों के पर्दे पे हम खिलते हम है राही प्यार के फिर मिलेंगे चलते चलते हम है राही प्यार के फिर मिलेंगे चलते चलते दर्द दिल
Sunil,
Yes, ma'am.
I think the songs are very long.
Yes.
They have already exceeded, not exceeded, they had this song for nearly 5.19 and I checked out their other songs. It's coming to a total of 26.9 minutes for their performance and we have given
I'll
them
just
only
play
18.
in between, and after 2 minutes or so, I'll disconnect.
So is there anybody there from Vidarbh Zone over here?
Except Shirish and
Madam, I think we can cut short the songs.
No,
We
but
just need
Shirish,
to
this
get
is not done. When we have asked everybody to give a very tight performance of 18 minutes, they cannot let somebody sing endlessly.
Yes, that
And they
is
have
there,
not
yes.
even submitted it to Sunil. They have sent individual performances where we keep writing that you form one group. All your acts have to be consolidated. From 15, I had increased it to 18. And then, the thing is, I've just calculated all the performances because one runs for 5.19, 1.5.16,
Yes, but madam,
4.27.
whatever judges said, we'll agree to that. If it is,
ऍक्च्युली हे
that's
लास्ट आहे हे लास्ट आहे सो त्यांना काहीतरी प्रॉब्लेम झाला असेल तर इट्स ओके तुम्ही आता जे बाकीचे परफॉर्मन्स आहेत ते दाखवून टाका आता एवढा वेळ बसलोय तर थोडा वेळ अजून आपण बघून घेऊ कोणावर असा प्रॉब्लेम नको व्हायला
मॅडम पूर्ण बघायचे की थोडा झलक बघायचे कारण की टाइम खूप संपसते
आता
Because there are some
वन मिनिटचा झलक दाखवा बस असं आम्हाला
1 मिनिटचा
कळेल
झलक दाखवा ओके मॅम लेट देम शो 1 मिनिट का झलक
Yeah, because we've got 4 more songs which are 5.5
ठीक है
minutes.
तो सुनील जी
4.5
प्लीज प्ले
minutes,
1 मिनिट
4.5.
एंड लेट्स रैप इट देन
Okay, जी.
1 मिनिट झालं की बंद करा तुम्ही दुसऱ्या फाईल लावा
चालेल
विरल सर
I'll play. I'm just playing by sequence.
Yes, just a minute. Yes, thank you.
Very
ओके
Okay.
Go on to the next. 1, 2, 3, 4, 5, 6, 7, 8 पे This was a 41-second clip, nicely edited and sent.
Yeah.
Play the next one. Dr. Yashpal Lamba.
Amazing.
Very nice.
Very
Very
nice.
So
nice.
beautiful.
Just
So
give me a-
beautiful.
I'm playing the last one, please. Just give me 10 seconds.
How many over, Sunil? There are 8 performances.
The last one, I have the only last one to play.
No. You have played how many? This is the 6th one?
I think I played 6.
This is the 6th one.
5 हो गए 5 हुए
This is 6th. No, they have 2 more.
No, I have played 6. This
Six.
is
I've
This is
said
the seventh. This is the
always
seventh one.
8,
this is the 7th one.
7. So there should be one more.
Play this one and see, Sunil, whether you
Yeah,
can.
play
Hello,
the
I am
one.
Dr. Hita Bhagwat, consultant ophthalmologist and corneal surgeon from Akola. I'll be singing the song Piya To Se Naina Lage Re. पिया तो से नैना लागे रे, जाने क्या हो अब आगे रे, पिया तो से पिया तो से पिया तो से नैना लागे रे, रात को जब चांद चमके जल उठे तन मेरा, मैं कहूँ मत करो चुंदा इस गली का फेरा, हाँ हाँ रात को जब चांद चमके जल उठे तन मेरा, मैं कहूँ मत करो चंदा इस गली का फेरा, आना मोरा सैया जब आए, चमकना उस रात को जब मिलेंगे तन मन, मिलेंगे तन मन, पिया तुमसे पिया
वेरी गुड, बहुत अच्छा,
वाह
Who was this?
वाह
Who was this?
बहुत ही बढ़िया।
Very nice.
Last वाला कौन था?
Sunil, there is one remaining which I've
No,
sent
ma'am,
you on
there are
your
7
WhatsApp.
actually. The first one was introduction.
Was
First
Okay.
it?
one introduction.
Okay, okay.
ये लास्ट
बहुत
में
अच्छा।
किसने गाया था सुनील जी?
So we
लास्ट में जो लड़की गाई थी पिया तो उसे नैना लागे रे, बहुत ही अच्छा गाया उसने।
नहीं किसने गाया था?
Dr. Hita Bhagwat.
Hita,
She is
Hita.
from our
क्या बात?
क्या नाम है?
Hita.
Hita
Hita
Bhagwat.
Bhagwat.
Hita Bhagwat.
Wow.
ओके
इतना
Nice.
टैलेंट है विदर्भ में।
I think it was a very, very nice ending to a very, very nice evening. The performance was superb, and this is actually one of my favorite songs. I read in the comments that it's in a 7/8 rhythm. I don't understand that, but it's very beautiful, and the part
This
she
is
sang, "Raat
this
ko
is SD
tumhara
Burman.
gali mein."
This is SD Burman
yeah.
guide.
I just loved it. I just loved it. Absolutely goosebumpy. Judges को कैसा लगा?
बहुत खूब,
बहुत ही
अच्छा,
बढ़िया,
बहुत ही बढ़िया
एंडिंग
गाया।
बहुत अच्छा हो गया। अगर विदर्भ वाले ने अगर बराबर उन्होंने 18 मिनट का किया होता तो आज मैक्सिमम प्राइजेस उनके लिए होते।
सही
बिल्कुल
अगर
सही,
उन्होंने
बिल्कुल सही।
परफेक्ट
talent,
अगर
but no
उन्होंने
quality.
हाँ उन्होंने परफेक्ट टाइमिंग भेजा होता तो पक्का उनके लिए बहुत सारा प्राइजेस होते। लेकिन इधर उधर हो
बिल्कुल
गया तो इट्स ओके, नेक्स्ट टाइम उनको बोल देना।
बट ये सॉन्ग से कहते हैं ना कि बहुत अच्छी तरह से वाइंड अप हुआ है।
वाइंड अप हुआ है।
Yes,
यस,
yes, yes, yes.
स्टार्ट और एंड बहुत बढ़िया हो गया।
बहुत बढ़िया।
और
बहुत
मैम
बढ़िया।
मिडिल में तो हमारा था, वो अच्छा नहीं था।
बहुत अच्छा
वो
था।
रिजल्ट के बाद देखते हैं यार, वो रिजल्ट
आपका
के बाद
बोलना है
देखते हैं।
कि शुरू से एंड तक एकदम समा बांध के रखा था। That's what you want to say.
हाँ तो हम
Yes,
लोग
yes.
ऐसे ही बैठे थे, इधर भी नहीं हिले इधर भी नहीं हिले।
आपको फिजिकली आना है बीओए में, हाँ, याद रखना।
Yeah.
बहुत खूब, बहुत
तीनों
खूब।
को आना है।
मैं तो पक्का होंगी, बाकी दोनों का मेरे को पता नहीं। मैं तो मेरा सीट तो
नहीं नहीं,
पक्का है।
सारे ही
नहीं,
आएंगे। त्रिलोक
ये
जी भी
देखने
आएंगे,
के
पूनम
बाद
जी भी
ये
आएंगे।
देखने के
बिल्कुल
बाद
आएंगे,
तो फिक्स हो गए।
बिल्कुल आएंगे,
हाँ।
बिल्कुल आएंगे, ऐसी क्या बात है।
मतलब
It's
इसके
our
पहले
honor,
थोड़ा डाउट
our
होता, बट
honor
अभी देखने
completely.
के बाद तो
शुरू से
मैं
लेके
फैन हो गई हूँ।
शुरू से
हाँ।
लेके आखिर तक पूरा समा बांधा हुआ था। निखिल जी आप लोगों ने बहुत बढ़िया। गॉड ब्लेस यू।
Thank you so
Thank
much.
you,
Thank
sir.
you so
धन्यवाद।
much.
Thank you.
मुझे
It was so
पता है
nice.
आपका इतना बिजी शेड्यूल में से आप इतना टाइम निकाल के इतना
इतना
सब कुछ
ब्यूटीफुली
आपने किया,
परफॉर्म कैसे कर
कुछ
पाते हैं?
मजाक नहीं है। बहुत मेहनत है इसके पीछे, बहुत मेहनत है। आई नो। तो
जी,
ये
मुझे लग रहा है इन सब के लिए।
Thank
यस,
you.
पर्दे
you,
के
पूनम जी।
पर्दे
Thank
के
you.
आगे नहीं, पर्दे के आगे तो हम लोगों ने देख लिया सबको, लेकिन पर्दे के पीछे रह के जिन्होंने
मैं-
भी ये काम किया है उन सबके लिए 3 cheers।
बिल्कुल
मैडम
सही।
एक डांस आपने अब तक नहीं देखा है, उसके लिए आपको इन पर्सन आना है। सुनैना जी का डांस, वो तो
Yeah.
एकदम अलग लेवल का है।
बस हम लोगों ने बुकिंग कर दी है, इसलिए
Booking
कोई
कर दिया
टेंशन ही नहीं है अब।
है। Yes.
ओके, हम लोग रिजल्ट दे दे।
Yes.
हाँ,
बहुत
अगर आप
एक
अगर
कॉल
अगर आप लोगों का आपस में चर्चा हो
हाँ
गई है तो
थोड़ा
प्लीज हम लोग
हाँ
वेट कर रहे हैं।
कैसे
हाँ तो
मतलब
हम
No. I just want to say one thing. See, there was a surprise element which was there. I know there are a lot of participations, बहुत सारे participants हैं. Even what we have declared for the prizes is less. So what I would request the judges to do is that
one more?
increase one more for
Yes,
in every
yes.
category.
Hmm.
Increase one more
यस
in every category. So there'll be 4 songs.
या
There'll be
मैडम
there'll be
इनफैक्ट
3
let
dances.
them
There'll
take
be
the
3
liberty of
dances. Just 1 second, Manish.
जी,
3 dances, 3 instrumentals, this 2 or 3 mimicries. No, mimax, and 1 poetry.
पोएट्री।
Yes,
एक्चुअली ये
and 1
आपने
bestie.
मतलब बोल ही दिया, क्योंकि मैं रिक्वेस्ट करने वाली थी कि इतने अच्छे मतलब ये ऐसा हो गया कि सीरियसली कंपटीशन हो गई, टफ वैसे तो एक एक प्राइस तो बढ़ा दे। तो
Yes.
बोल पूछने ही वाले थे हम लोग।
नहीं, बढ़ना ही चाहिए। एक प्राइस तो बढ़ना ही चाहिए।
ओके, तो हम लोगों को एक ब्रेक ले ले।
2-3
Yes.
मिनट के हम लोग
Sure.
यहाँ से अभी
Yes.
क्या मीटिंग ऑफ करते, यहाँ से अभी कैसे?
आप लोग म्यूट
म्यूट हो
करके
जाइए
म्यूट हो जाइए
Mute
और
और
करके
आप
जाओ,
अपने
no
वीडियो कॉल पे
problem.
डिसाइड कर दीजिए।
यहाँ से म्यूट
आप
करके जाए
वीडियो और
बस।
ये
हाँ,
ऑडियो
and
बंद
come
कर
back
सकते हैं।
again.
हाँ
आप सिर्फ
ओके
ऑडियो और वीडियो म्यूट कर दीजिए,
ओके
छोड़ना नहीं मीटिंग। और आप
At the
आपस
lower
में
end, you'll find audio and video.
हाँ ऑडियो वीडियो म्यूट करके आप डिस्कस करिए कॉल पे।
कॉल पे डिस्कस करके देन यू विल कम बैक.
वीडियो ऑन रहेगा तो भी चलेगा, हम सुन नहीं पा रहे हैं.
हाँ,
Any
खाली ऑडियो बंद
performance,
करेंगे तो ठीक
any
है.
performance which
हमें
needs
सुनना
to be
है.
repeated, let me know
सुन नहीं
while
पा
playing.
रहे हैं.
Till that time, play Gulabi Sadi.
Yes.
Oh, you want to see it again?
Yes, yes.
Yeah, because that was some music was not coordinating with that
ठीक
video.
है, let me
Yes.
try to do it
So
one more
while
time.
they are finalizing the
मीना ताई आपको कॉल
results,
करूं मैं?
let me take this chance to
कॉल कर ना. आपण एक
thank
काम करूया.
everyone
मला इथे बॅग
who's so
जायला मला कळलं नाहीये. जरा
enthusiastically sort of forming the groups and doing the acts, and each one's performance was very
हेलो.
good. And
मीना ताई आपका ऑडियो म्यूट करें आप. आपका ऑडियो
हाँ
म्यूट
हाँ हाँ
करें
हाँ
आप.
हाँ 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 हाँ. Yes, yes, yes.
lower left corner, you'll find the button, just click there.
Nikhil sir, do you want me to play?
Yes.
Yes.
Yes, please.
आप stop कर दीजिए, I'll play फिर.
Oh, sorry. Yes,
And
yes.
Sunil,
I'm
thank you so
stopping
much
share.
for all your help.
Ma'am, he'll play Gulabi Sadi, then we'll chat.
Yes.
On public demand, Gulabi Sadi again.
I'm loving this.
क्या बात है.
काजळ लावून आले मी आज, असं नका बघू अहो येते मला लाज. केला शृंगार आज घातलाय असाच, दिसते मी भारी जणू अप्सरा मी खास. नखरेवाली कुठे निघाली घालून साडी लाल गुलाबी, पागल करते तुझे मोरनीशी चाल. गुलाबी साडी आणि लाली लाल लाल, दिसते मी भारी राजा फोटो माझा काढ. गुलाबी साडी आणि लाली लाल लाल, दिसते मी भारी राजा फोटो माझा काढ. झाला क्लोज आता वाईट, मानवरती ओके राईट. फोटो काढतो असा होणार ज्याने वातावरण ताईट. मस्त खुशी मध्ये बायको माझी करीन पिलो फाईट. माझा होऊ दे पगार गिफ्ट करतो रिंग लाईट. नको मला चहा खारी आता जेवण करून जाईन. सेलिब्रिटी तू मी तुझा पिये बनून राहीन. येणार सेल्फी साठी क्राऊड मला फील होणार प्राऊड. जाशील इन्स्टावर लाईव्ह आणि मी कमेंट करत पाईन. करीन कष्ट माझ्या पैशाने घेणार मेकअप किट. राजा होणार मी इन्स्टाची स्टार. हाय गुलाबी साडी आणि लाली लाल लाल, दिसते मी भारी राजा फोटो माझा काढ. किती मी क्यूट किती गोड किती छान, दिसते मी भारी राजा फोटो माझा काढ. अदा माझी सिंपल नसले जरी डिंपल, हिरोईन दिसते मी हिरोईन. थोडे दिवस थांब अशी लाईन लागेल लांब, मी पण बनूनच दाखवीन हिरोईन. माझी चाशनी तू माझी खास, मी तुझा समर्थक उद्या पण आज मी बोलेलो किस मी. ती बोलली आज नाही बनू नको म्हणे इम्रान हाशमी. माथ्याची टिकली पैंजण बांगडी हिऱ्याची अंगठी, मारुती कारवी चांदीचं कंगण सोन्याचं गंटन. करेन गिफ्ट हा करत मजाकनी, पुरी करीन तुझी हर एक विश. नको करू शंका ना सवाल. हाय गुलाबी साडी आणि लाली लाल लाल, दिसते ती भारी म्हणे फोटो माझा काढ. गुलाबी साडी आणि लाली लाल लाल, दिसते ती भारी म्हणे फोटो माझा काढ.
Oh,
That was a
this
treat
was
to
so
watch.
amazing.
It's so good.
I love how he did not dance, but the swag you saw in the end.
Yes, yes, yes.
Is Sumit around?
Oh, he's not there. कभी कलाकार आते नहीं है ना, स्टार लोग छुप जाते हैं.
And it
I
was
think it was
behind the
amazing. You saw
curtain, which
Piyush,
was the
he did
best.
all the steps now. All the steps he did.
Yeah. Piyush was damn excited about the pillow fight. I saw that.
Piyush,
I
yeah,
know.
the pillow fight. At the
And
Maharashtra
you,
Goa conference, this
in
has
the
to play
day,
again and again. Huh?
during the day, I was in so much pain, and yet managed to do that. I had
Super,
to
yeah.
do it 2 or 3 times, but I completely enjoyed this. Thanks to Shon Dada, who made you play this again. Absolutely ball of a time. The last 3-4 minutes.
Piyush, now you have a pillow fight with your wife.
Arey, abhi too much of fights now. Bas na abhi.
Hello.
Don't start so soon in the day.
The judges.
They'll
So,
take a
Sirish
little
sir, thank
time.
you so much for having this cultural thing. It was really, really
Everybody
wonderful.
was a
And
winner for me.
yeah,
Thank you, Piyush,
Hello, I'm
Shirish,
not able to talk.
Viral,
I think that
Sean. Thank you so much for giving us the opportunity to do this program.
Sean's
And
rap was so cool, na? I gave him that part
Thank you so
because of
much
his
for
mooch and
doing
all,
this, bringing so much of color and passion and such amazing times.
Full emotion के साथ क्या? इमरान हाशमी full emotion में आ गया.
अच्छा हुआ और
मैं भी वही बोलने वाला था, निखिल.
Sarobi, you all have an unfair advantage of Nikhil and Manish. They are movie editors in themselves,
मैडम नजर मत लगाओ. मैं छुपा के रख दूंगी
You know
उनको.
what? ऐसा करूबी मैम आती है ना, तो ऐसे जैसे अजीत आता है ना, वैसे आता है बाद में एक तरफ रॉबर्ट, दूसरी तरफ पीटर.
मेरे पास एक आइडिया है मैम. नेक्स्ट टाइम हम लोग ये करेंगे ना, so like how we have an IPL का auctions, we'll auction on our talents.
Yes,
Then
yes.
it will be like a true mix. You know what I mean?
Let's do it that way, not zone wise.
Yeah,
then
let's
we
do
will
it
be
auctions.
we will be in extra only.
नहीं ऐसा क्या?
भाई तुम लोग ये सब प्रीमियर लेके जाओगे, हम लोग तो सब एक्स्ट्रा में ही रहेंगे.
You will be the team owner. You will be buying everybody.
You'll be the most valuable player.
आज का जो रैप किया है ना आपने,
मनीष ये ट्रेजरर है, पैसे
I know,
इसके
I
पास
know.
है, खरीदने वाला ये है, क्या बोल रहा है ये?
शोन एकदम
शोन
सीरियसली
दादा के लिए
अच्छा
तो
रैप किया.
शोन दादा के
जी
लिए तो
मैम, थैंक यू मैम.
डेट वाला भी ऑक्शन करना पड़ेगा.
वो लास्ट गाला भी शोन के लिए था ना, मूछों में ताव बड़े, वो सब उसी के लिए था ना.
I
बना
like
के रखता हूँ
Sharon's
और
mooch.
मुझे कुछ करना
बना,
पड़ेगा.
बना.
एमओएस में भी करना है भाई सबको. मैम
हाँ, एमओएस में यही करेंगे. हवन
करेंगे ये साल नवंबर करेंगे.
Yes,
पक्का.
We'll do Goan dance this time.
sure.
चलो done.
मजा आ रहा है, मजा आ
Go
रहा
and dance, you have to drink and dance then.
We anyway drink and dance, ma'am.
Anyway
Like that
drink
we
and
can't.
dance.
You have to get sozzled and dance.
Sausage we don't know. Then
All
we'll
is
fall
said
down.
by Mr. President. He is taking care of everything.
He's taking care of everything good.
He's the most caring
दोनों पहले आ
president.
गया.
जो जिसको चाहिए सब बांट देते हैं सर.
वो किसी को
Shirish is too
किसी
sweet,
को
yeah.
मना नहीं करते.
किसी
You
को
all
मना
do
नहीं
know
करते.
this meeting is recorded, huh?
Guys, हाँ, बस
100%. All of this is thappa.
Censor the conversation now.
But
Viral
I
sir नहीं
have
दिख
seen
रहे.
that
Viral sir किधर चले गए?
year after year, the performances are
सुनाई दे
getting
रही है आवाज?
much more.
Better and better. Better and better.
Yeah. The confidence levels and the unique instruments they bring is so amazing. It's very difficult to play all those.
No, and it's so much talent we've
I
got.
think Maharashtra can
Too
give
much, too much, too
any
much.
this state
Any other
run for its money, you know. If
Yes.
we club in all the talents, no, which we get
हाँ जी.
from all the zones.
I think
अरे
actually, why don't
Karobi ma'am, abhi what zones? Central can give a run for the money to every other state combined. So
Absolutely, I agree.
आवाज
Absolutely,
नहीं आ
I
रही है.
agree. You know
Maybe
that
they're not
stand-up
central.
comic act,
I
Piyush,
mean,
it was
all
so
the zones have
interesting.
really participated and done well here. Good, very good acts here.
Very nice. I mean,
Nah, ma'am, the
I
stand-up
echo your
comedy, it
words.
was so impressive the way it was one doctor to the other and then the badminton shuttlecock. It was so well scripted.
I know.
And that Kokila, I've
Yeah.
never heard that
मैं
song, but it was
तो
so amazing.
See, we
And
know
that is
Rohit,
based
we
on
know
आवाज नहीं आ
song,
रही है.
no?
we know
I
Rohit
don't know,
Bhatt is
it
like
was
this
beautiful.
humor
And
king.
the Gondal also.
Gondal
These
also
are
was
things
very
I have
good.
never seen, so it was unique, very
Hello.
interesting.
निखिल आई थिंक त्रिलोक सर की शायद ये बीच में आवाज उन्होंने उनको शायद अपनी आवाज नहीं आ रही, कुछ बोल रहे हैं. हाँ.
Judges are
I
ready.
think
Somebody-
we hi Usha, nice to
Hi,
see you.
hi. Judges are ready.
हाँ, so let them
So
get
we'll
online.
keep our mouths shut.
Yes.
Yeah,
बीच
we
में आवाजें बहुत आ रही है,
Over
सुनाई
to you,
नहीं दे रहा है.
Triloki ji.
त्रिलोक सर बोलिए.
बीच में आवाजें बहुत आ रही है, सुनाई नहीं दे रही है.
अभी हम सब म्यूट है सर.
ये
Voluntary.
आपका कार्यक्रम इतना इतना बढ़िया है कि किसको किसको हम नंबर 1 कहें, किसे 2 कहें, बहुत मुश्किल में डाल दिया आप लोगों ने.
You're muted, ma'am. You're muted, ma'am.
करो भी मैम, यू आर म्यूटेड.
आप ऐसे 1 2 3 4 मत दीजिए. 4 people, songs, okay, they are on equal level. 3 people, dances, equal level. ऐसे करना है.
I think they are still calculating.
Yeah.
So we are not going to do zone. Which zone is first?
वो हाँ,
Zone we are going to do.
वो भी बोल दीजिए मैम, करो भी मैम. जोन का बता दीजिए कि एक जोन का बोलना है.
Zone का
So
बोल
let
दिया.
me tell you one more thing. All the judges have been given special hampers from Maharashtra Ophthal Association. They have given them gift hampers which have reached their homes just now, except for Trilok ji, because his hamper will go to Usha Johari ma'am and we will deliver it tomorrow morning because it's become very late now. So
It's
thank
very
you
important to
judges for
note
giving
that
your
it is from
time, and
Maharashtra
it's a
Ophthalmological
very small
Society,
token,
not from
but
Central.
it's from all of Maharashtra Ophthal.
With a lot of feeling.
Accepting that.
Yes, yes.
A lot of
feeling,
yes. Ma'am, they got nashta.
Nikhil nasta.
They got
And we got chai.
Nobody could have done it better, yeah. Nikhil and Karuna.
अरे और मनीष हेडफोन पहन
अरे
के बैठे
Manish boss, तो he is there in the background, शांति से.
And did you see Sharang and everybody? They were all
Sharang, no,
everybody.
Sharang was the one who carried it all.
Absolutely. His Rena and all these
Yeah,
things.
he's amazing. He's amazing. He's amazing.
And did you see Usha ma'am's performances where she didn't have to smile at all? You know how much task we had making her move left to right and right to left? हाँ मैम.
Yeah.
मैम राइट हाथ कौन सा है, ऊपर कीजिए.
I was the
मैम
youngest
आपका
of
राइट हैंड
all.
ऊपर करिए.
राइट वाला हाथ बताओ मैम, राइट हैंड ऊपर करो.
आप
was the
लोगों का
youngest of
माइंड का
all.
तो बहुत बढ़िया था, बहुत लाजवाब
And
था.
Karobi literally wanted to hit me, from the back.
और आपको एक तो जोक पता ही नहीं है, हम लोग का वो बनाना वाला सीन में हम लोग घड़ी घड़ी बनाना खा जाते थे रिहर्सल के टाइम में.
And at the end of it, we got it as a gift, one
Yeah, we carried those gum bottles with us.
and gum bottles.
One kela and one banana.
One, yes.
I got 2 gum bottles.
Yeah.
अरे
That is because I gave you one under the can, na?
बीना जी भूख लग रही है.
The only
She's
person who
sitting
was
in a
not
restaurant. ऐसे नहीं अपना हिसाब तो नहीं कर रहे हैं वो.
Nikhil bhai, the
Don't
only
hassle.
person over here who was sleepy but not showing it was Manish bhai.
No, he was not sleepy यार.
He was enjoying each and every performance. I'm telling you.
Yeah.
I know he's put his headphones and he's sitting nicely.
He was singing all the songs.
Yeah.
Ma'am, call up Veena ji. I think she's doing stock taking and shutting her restaurant. वो हिसाब चालू है. आप उनको ही phone करिए.
I think you'll be able to draw her out.
सिरीज सर कन्सल्टिंग मध्ये बसलेत का?
May I call her?
हाँ प्लीज.
Sunena, your dance, dance while sitting was also very good. You're dancing while you're sitting.
Yeah, because actually that is my dance. I've danced.
But hats off, Sunena madam. You've been there since afternoon, the academic sessions, and now again right till the end of the cultural program. And I wanted to interrupt and speak in between. So I absolutely adored this post of Malik Madam that she had put on Facebook, where she mentioned a 72-year-old lady is now learning to swim at this age, and she
Yes.
showed her dive into the pool. So hats off to you.
Thank you, Piyush. Thank you.
Ajay, you dived today?
No, 2 weeks back. Actually, I learned swimming at 40, then I was 40. And after 32 years, I went back. I wanted to prove a point to myself.
Okay.
Did freestyle, I learned backstroke, and then my coach said, now dive. So I said, okay, dive. So dive. So I dived and got it recorded, and I wrote, I'm 72 years young, and I've my first dive.
Yeah, and then now next you have to do the butterfly.
Butterfly
That's
at
too
90.
good, ma'am.
Butterfly at 90.
Butterfly
Ma'am,
at 90.
we should get her for the LBO session this time. She has to
Yes.
speak about this.
I will.
Yes.
I will connect with you for this, ma'am. We always have
Vinata is
a...
back.
You know, Nikhil,
Nikhil, Vinata is back.
Yes, yes. Yes,
lady
ma'am.
who,
एक मिनट जी
yes.
मैम सुनैना जी आप बोलिए ये टेल मी नाउ
हेलो
म्यूट है
हाँ वीना जी बोलिए.
ओह ओके
नाही विनाता यू आर म्युटेड.
आवाज येतोय आमचा
हो
नाही,
हो
तुमचा
हो
नाही
आला
आला.
रोहनताई तुमचा आला
Yes,
वीणा
yes.
मॅडम म्युटेड आहेत.
आमच्याकडे रिझल्ट रेडी आहे फक्त काय झालंय
हा
की आपले जे पंडित जी आहेत त्यांच्याबरोबर फक्त बोलू शकलो
हाँ,
नाही
वो
आणि आमच्याकडे
बात नहीं
काही
हो
ना
सकी.
हाँ सर तुम इतेच आहात कुछ नाम ऐसे है ना कि जैसे ग्रीन साड़ी तो उनका नाम याद नहीं है तो हम लोगों ने ऐसे आपको कहा है तो
हेलो
आप में से कोई लिख के वो अनाउंस कर सकते हैं या कैसे चलेगा
ग्रीन साडी वॉज दॅट शेषा भगत नो.
हाँ बट
हाँ,
नॉट
समटाइम्स
भागवत हाँ
उनके पूरे नाम नहीं हमारे पास तो हम लोग वो
ग्रीन
गाना
साडी वॉज इन मॅडम सुनैनाज बॅच ना.
दैट उइमा विमा महाराष्ट्र जोन
द सेक्सी डांस नो.
या हम लोग ना आपको बराबर
सुनैना
बताते
मैडम.
जाएंगे.
डिस्क्राइब कर देंगे चलेगा
हाँ हाँ
सुनैना
Yes, yes,
मॅडम
चलेगा दौड़ेगा.
तिचं नाव काय होतं. द गर्ल इन द ग्रीन साडी.
Madhav's daughter.
Baker.
Madhav's daughter.
मृण्मयी is awesome.
वीणा ताई
मृण्मयी.
She's
वीणा
Runmai.
ताई
ग्रीन साडी वॉज मृण्मयी.
Runmai.
हाँ वीणा ताई हाँ मला सांगायचं त्रिलोकी सर क्या हुआ है ना कि अगर अभी हम अगर कुछ बताते हैं तो आपको अगर कुछ लगता है तो आप ही बता दीजिए मतलब
पूनम जी और मीना जी मैं एक बात बताऊं आप लोग सब कलाकारों से वाकिफ हैं मैं उनसे इतना वाकिफ नहीं हूं तो जो वैसे भी लेडीज फर्स्ट है आपका जो
अरे
मार्गदर्शन होगा उन लोगों के लिए मैं आपके साथ हूँ सहमत हूँ आई
जी
लीव इट अप टू यू
अरे थैंक यू सर थैंक यू सो मच. अच्छा करोबी जी मैं पहले आपको ना बताते जाऊंगी. आप
हाँ.
एक दो नंबर मतलब ऐसा 3 जन का नाम बताऊंगी.
हाँ.
हाँ पहला सिंगिंग में
सिंगिंग
सेंट्रल जोन का बंगाली जुगलबंदी हो गया था.
ओके दैट इज
मेरे तेरे
So
नैना
डॉक्टर
Sabyasachi
रंजीत मुखर्जी
and
एंड डॉक्टर
हाँ, तेरे
सब्यसाची
मेरे
रणजीत प्लस सब्यसाची.
राइट
जी. उसके बाद नॉर्थ जोन का जो था
निखिल
नॉर्थ
कुंदे
जोन
डॉक्टर
हाँ
मराठी सॉन्ग गाया था उन्होंने.
मराठी सॉन्ग गाया था.
दिल्या गेल्या
शपथ तुला
वचनाची.
आहे दिल्या गेल्या वचनांची शपथ तुला आहे. उन्होंने इतना
Superb.
बढ़िया गाया.
दर्शना
तो
हु वॉज दैट पर्सन.
निखिल
निखिल कुंदे
निखिल.
डॉक्टर निखिल
निखिल
कुंदे.
कुंदे
निखिल कुंदे.
हाँ कुछ
जी.
नाम है वो मैं बता देती हूँ और मैंने लिखे हुए हैं.
ओके.
और उसके बाद थर्ड मतलब तीसरा निकालना है तो वेस्ट जोन का मैं कोई इस गीत गाऊं है वो गाना गाया था.
हाँ
मैं
बहुत
कोई
अच्छा
ऐसा गीत गाऊं
सचिन
आरज़ू
आटले.
जगाऊं.
सचिन आटले हाँ
सचिन आटले.
सचिन आटले
हाँ, बहुत अच्छा
जी,
गाया
जी.
बहुत अच्छा गाया
सुपर
सचिन आटले
हाँ ये 3 जन का नाम है.
एंड द फोर्थ.
फोर्थ का हम लोगों ने मतलब पिया तो से नैना लागे रे लास्ट वाला
wow
जो
बिल्कुल
wow
बहुत
wow
सही
It was
superb
बहुत
from
सही
superb superb
what was her
जी.
name? शीशा
हिता
भगत.
हिता
हिता भागवत.
वो
हिता
लास्ट वाला जो
भागवत.
किया तो उसे
हिता
नैना लागे रे बहुत अच्छा गाया
जी हाँ हाँ. और
This
उसके बाद
was
अभी
from
डांस का आप ले लीजिए. डांस
हाँ.
का
हाँ जी
मराठवाड़ा का वो उयम्मा वो सेक्सी डांस.
wow wow
मृण्मयी अंबेकर.
मृण्मयी.
superb
यस
हाँ.
मृण्मयी
और उसके बाद वेस्ट
वेस्ट
जोन का ये रात ये मौसम
वो
डुएट
दोनों ने
उन्होंने
किया था.
डांस किया था.
that was
कपल्स
Vardhaman
में
right
वर्धमान
वर्धमान.
Vardhaman and Sneha
एक
Shrutika
हाँ उनका है. हाँ उसके बाद नॉर्थ जोन का दर्शना शाह, रागिणी पाटिल, दोनों ने सेम ड्रेस डाल के
क्या बात है।
अच्छा
बहुत अच्छे
हाँ
थैंक यू.
उनका या उसके बाद अभी इंस्ट्रूमेंट में निखिल कुंदलकर विदर्भ का
कोंदुरकर
वायलिन
उन्होंने
कंदुरकर।
वो पियानो बजाया था उन्होंने
पियानो,
बहुत
पियानो।
बहुत
बढ़िया।
अच्छे, बहुत बढ़िया.
देन
और
सेंट्रल
इंस्ट्रूमेंट में वापस सेंट्रल जोन ही जाता है, बांसुरी का है ना
ओ,
उन्होंने
मिहिर
मिहिर
it is मिहिर.
यस और तीसरा है यशपाल लांबा, उन्होंने वायलिन
वायलिन।
बजाया था
यस वायलिन वायलिन
वाह.
जी। उसके बाद मोनो एक्टिंग में हमारा निखिल नाश्ता का ग्रुप जो है उसको सिलेक्ट कर रहे हैं हम लोग।
ये तो
बिल्कुल,
बायस लग
बिल्कुल.
रहा है मेरे को।
पीयूष तो मेल बाद में.
बहुत ही अच्छा, बहुत बढ़िया.
और उसके बाद नीलू फुले और उनका एक्टिंग किया था, दो जन ने मिलके वो
टोपी पहन के किया था
बेस्ट जोन
श्रीराम
Best
लागू
zone.
और नीलू फुले
हाँ
वेस्ट
श्रीराम
जोन
लागू और नीलू फुले उनका
Yes.
बेस्ट था
What
एक्टिंग।
were their
Sami
names?
Datta.
Only one person.
Samir
that was
Datta,
that was
Samir
one
Datta.
डॉक्टर
person.
समीर.
एक ही पर्सन था बट
It was a monologue.
Yes, 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 yes.
मोनोलॉग किया था उन्होंने,
बहुत
बहुत
अच्छा.
बढ़िया।
Yes.
और उसके बाद पोयम में कोकिला का पोयम जिसने किया वो
हाँ.
बहुत
Wow.
बढ़िया
What
उन्होंने
was her
गाया।
name?
रूपाली
Abhyankar.
अभ्यंकर
Dr.
Dr.
Rupali
Abhyankar.
Abhyankar. And she
Rupali
a
Abhyankar.
poem by her late husband,
What's her name?
Dr.
डॉक्टर
Rupali
रूपाली
Abhyankar.
अभ्यंकर.
यस यस
By
उन्होंने
her late
इतना
husband
बढ़िया
who
मतलब
carry on
उसको
our hearts, Dr. Abhyankar.
यस
He was a
वो हम
gynecologist.
लोगों को यहाँ तक पहुंच गया, वो पोयम यहाँ तक
Yes.
पहुंच गया।
बिल्कुल
और
सही.
उसके बाद
और अभी
सरप्राइज
बेस्ट जोन जो है वो जाता है सेंट्रल जोन को।
बहुत अच्छे.
Thank you,
अभी
thank
मैडम
you,
ऑप्शन
thank
तो
you so
बनता है
much.
नेक्स्ट ईयर ना।
रनर अप भी बताइए
देखिए,
बिकॉज फिर
उसमें-
एक रनर अप बता दीजिए।
अच्छा एक रनर अप में जाता है तो फिर अभी एक्चुअली मराठवाड़ा विदर्भ को जाना चाहिए, लेकिन उन्होंने ठीक तरह से नहीं किया है, इसके वजह से एक्चुअली जाएगा नॉर्थ महाराष्ट्र को, कि उन्होंने परफेक्ट टाइमिंग में परफेक्ट परफॉर्मेंस और बहुत लोगों को उन्होंने
वो
दिया
बहुत
है,
इम्पोर्टेंट है.
वो बहुत बड़ा हाँ नॉर्थ
कंपटीशन
महाराष्ट्र को
में टाइमिंग
very
टाइमिंग
वो बहुत इम्पोर्टेंट है.
रूल्स एंड रेगुलेशन पालना बहुत जरूरी होता
बहुत
है।
जरूरी, बहुत
उन्होंने
जरूरी.
एग्जैक्ट 18 मिनट में इतने लोगों को उन्होंने दिया चांस, मेरे को लगता है 5 गाने हो गए, 2 डांस हो गए, फ्लूट हो गए, उसके बाद
हुए उनके 8 परफॉर्मेंस
हाँ
हुए उनके।
इतना उन्होंने 18 मिनट में दिया, बहुत बढ़िया। नॉर्थ महाराष्ट्र को उनको जाता है।
सेंट्रल जोन में
बिल्कुल सही.
जो एक बहुत चीज अच्छी लगी, एक बात जो बीच बीच में कनेक्ट कर रहे थे वो भी डॉक्टर थे।
डॉक्टर शारंग वर्तीकर है.
शारंग
डॉक्टर
वर्तीकर.
शारंग वर्तीकर.
तो उनको स्पेशल प्राइज
प्राइज.
मिलना चाहिए।
Special
आई
prize.
थिंक वो डिजर्व करते हैं.
100%.
He deserves it.
100%.
जजेस प्राइज
Special
उनको
judges
मिलना
prize.
Yes,
या
yes, yes,
जजेस
yes.
प्राइज उनको मिलना
He's another
चाहिए।
multi-talented person.
मैडम आपको पता नहीं है, लास्ट टाइम उन्होंने एक लेडीज का रूप लेके उसने एक्ट किया था, इतना ब्रिलियंट, मैं आपको बताऊंगा उसका
अरे
क्लिपिंग।
उनका समझ में आ रहा है, तो उनमें बहुत टैलेंट फुट के भरा है।
और मैम वो ना वो सितार बजाते हैं, अगर आप उनका सितार
Wow.
सुनेंगे तो ही इज मल्टी टैलेंटेड, बहुत ही
नहीं
अच्छा।
लेकिन उन्होंने खुद का कुछ नहीं दिखाते हुए आप लोगों को चांस दिया।
बिल्कुल सही. वो बहुत बड़ी
हाँ
बात है.
और लेकिन हाँ ये भी बड़ी बात होती है, लेकिन उन्होंने एक्ट भी वो इतना सा टाइमिंग में उन्होंने अपना एक्ट दिखा दिया है, तो उनको स्पेशल जजेस प्राइज जाएगा।
And the best thing was that वो सब जो fillers, he's written it also himself.
वो स्क्रिप्टिंग भी उसने ही की है.
Scripting उसने
स्क्रिप्टिंग
किया।
उसने ही किया है.
So we
बात
told him,
समझ में
"जी
आ
बाबा
गई।
enact कर."
ऐसा तो हम लोगों
किया था, ऐसे नहीं कि ऐसे ही बोल रहे।
Yes.
एक आगे वाले परफॉर्मेंस को उन्होंने वो कड़ी जोड़ के रखी थी।
Yeah.
Yes.
Because I told them that you make a story out of it, so that it becomes continuous, seamless kind of a thing,
तो इसीलिए
एक्चुअली मैं मैडम आपको बोलूं सच में, हाँ लेकिन सच में बोलूं कि आज ऐसा लगता है कि सबको प्राइज दे दे।
हाँ बिल्कुल सही, बिल्कुल सही.
सच में इतना बढ़िया हो गया था,
What,
लेकिन
ma'am?
थैंक यू सो मच, आप लोगों ने हम लोगों को जजेस करके बुलाया, हमारा शाम बहुत बढ़िया आपने
बहुत
किया है। थैंक यू सो मच, हम सबकी तरफ से आपको बहुत बहुत धन्यवाद। कभी कभी तो मेरे कैफे में आ जाना, हम लोग पार्टी करेंगे इसी
क्या
बात
बात है, क्या बात है.
But,
मैडम
जी,
आप लोगों को
पूनम जी,
इतने
त्रिलोकी
सारे
जी।
आई स्पेशलिस्ट फ्रेंड्स मिल गए, आपको कभी इनकी जरूरत नहीं पड़े, लेकिन सारे दरवाजे आपके लिए खुले हैं।
And वीना
Thank you
जी,
so much.
पूनम जी,
All over
त्रिलोक जी,
Maharashtra.
आरोग्य जी,
Thank you.
आपको,
हम ये
निखिल
बोलना
जी को,
चाहते
मनीष
हैं
जी
कि
को, सारी पूरी टीम को बहुत बहुत बधाई हो। और
थैंक यू।
आप लोगों ने बहुत अच्छी तरह से मैनेज किया और सबका आपने बड़ा ख्याल किया और सबको बहुत अच्छा मौका दिया। ये इस चीज को आप कंटिन्यू रखिएगा। आप सब
थैंक यू,
लोग,
थैंक
पूरी
यू,
टीम जो है वो बधाई के काबिल है।
थैंक
गॉड
यू।
ब्लेस यू।
सीरियसली मतलब आपके शेड्यूल में ये सब आप कर रहे हैं, मैं दिल से थैंक यू बोल रही हूँ क्योंकि मुझे मौका मिला। और वीना ताई, निखिल जी, आप दोनों को सीरियसली थैंक यू। और
बहुत अच्छे निखिल जी,
apart from
मनीष जी,
करोबी मैडम एंड निखिल,
करोबी जी,
तहे
बहुत
दिल
बहुत
से
बहुत बहुत बधाई हो
शुक्रिया।
आपको। गॉड ब्लेस।
थैंक यू
आप
सर,
सभी
प्रणाम
जजेस
आपको।
को इतने प्रेम से आपने सबको प्रोत्साहन दिया। You have described everything in detail about all
नेशनल
the
एंथम
prize
आउट।
winners. Thank you so
पीयूष
much.
जी, पीयूष जी,
Great
बहुत
Thank you.
अच्छा, बहुत बढ़िया, बहुत बहुत बधाई हो आपको।
Thank you, Piyush,
Thank you, sir.
for the
Thank you.
opportunity. And we almost feel that Trilok ji, Veena ji, and Poonam are part of our ophthalmic family.
Yes, yes, definitely,
हम
definitely.
हमेशा हर साल अभी ज्वाइन करेंगे, सिर्फ देखने के लिए क्यों ना हो,
Done.
लेकिन ज्वाइन करेंगे।
सीरियसली
थैंक यू डियर, थैंक यू सो मच
Thank you, dear.
निखिल।
Thank you.
Thank you,
Thank you very
thank you
much.
चलो
everyone.
मिलते
Thank
हैं,
you
जल्दी
Piyush, thank
मिलते
you
हैं।
Dr. Shirish, thank you
Yeah.
जरूर।
judges, thank you
Thank you.
Garovi ma'am, thank you
Thank
Sunana
you.
ma'am.
Thank
And
you.
I want to
Let's
say a
Manish
special
thanks.
thank you to Sunil Zadutech because he's done a wonderful job. And thank you all the judges, thank you all the participants,
My
all the
my
zone
pleasure.
heads.
Thank you very much.
And
Yes,
and
thank you to
Thank you.
everybody.
big thank you to our cultural boss.
Yes,
And
Garovi
you know,
ma, thank you.
from her bidu's, Nikhil
Thank
and
you.
Manish.
Everybody
Karobi
Thank
ma'am,
smile,
you,
thank you
get
so
in a
Vidus.
much.
group photo
And
before
a
we
huge
Yes,
exit.
yes.
thank you to Piyush, to
Shirish
Sean,
sir,
and to
Shirish
Shirish
sir.
sir. नहीं तुमको तो
Shirish.
सबसे लास्ट में सबसे important the president. Thank you so much sir for giving us this opportunity to do the cultural program. We thoroughly enjoyed it.
Yes,
Thank
exactly.
you.
Okay,
Thank
now
you
one
very much.
group picture, everybody
Shirish, thank
smile.
you.
Yes.
And Shirish,
Got
prizes
it.
for everybody and special prizes to the winners.
Thank
Sure,
you.
sure.
Thank
सबको
you.
बहुत
Thank you
बहुत
so much, dear.
मुबारक हो, बधाई हो सबको।
Thank you.
चलिए,
गुड
Thank
नाइट।
you.
have a
Treasurer
good night,
treasurer
stay
इधर ही है।
safe, thank you so much.
पीयूष,
And
treasurer
I
सर
think
इधर ही है।
I think
Treasurer sir
now
तो
we
हमारे
all
साथ
stand
हमेशा
up
ही
for the
रहते हैं, हमारे
national
दिलों में,
anthem.
दिल में रहते हैं।
Yeah, yeah.
Yes.
Let's all stand up for the national
National
anthem.
anthem. Sunil, please play.
जनगण मन
अधिनायक जय हे
भारत
भारत
भाग्य
भाग्य विधाता, पंजाब सिंध गुजरात मराठा द्राविड बंग विंध्य हिमाचल यमुना गंगा उत्कल जलधि तरंगा,
तव शुभ
शुभ
नामे
मना जागे तव शुभ आशीष मागे, गाहे तव जय गाथा, जन गण मंगलदायक जय हे भारत भाग्य विधाता, जय
जय
हे
हे जय हे
जय 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 हे
भारत माता
भारत माता
की
की
जय
जय।
MOS की जय.
जय महाराष्ट्र।
जय हिंद, जय महाराष्ट्र, जय
बहुत
हिंद।
बहुत MOS को बहुत बहुत बधाई हो।
थैंक यू,
शुभ
थैंक यू,
रात्रि। गॉड ब्लेस यू।
Thank
बहुत
you for
अच्छा
the
लगा।
beautiful evening. Thank
चलिए,
you so
good
much.
night.
Thank you.
Good
Thank you.
night.
Good
Thank
night
you,
team.
good
Good night.
night.
Good night. Shubh